or vaginitis, what do you think is the investigation of choice? So the investigation of choice is microscopy. Okay, so whenever there is a vaginal discharge, the investigation of choice is microscopy. Now, what is the characteristic thing that you will see in the microscopy of bacterial vaginosis? We call them as clue cells. Okay, we call them as clue cells. So what are clue cells? Clue cells are vaginal epithelial cells. Okay, so they are vaginal epithelial cells which are studded with bacteria. So these are cells जिनके ऊपर bacteria चिपके हुए हैं, right? So these are cells which are studded with bacteria. Okay, so that is going to be the classic finding of bacterial vaginosis. What is the classic finding of Candida? You can see the pseudohyphae. Okay, so you can see the pseudohyphae, especially in which staining? KOH staining. Right? So especially if you do the KOH staining, then you can see the pseudohyphae. Otherwise, you can see the budding yeast. Yes, so you can see the budding yeast. But if you put a KOH staining, you can actually see the pseudohyphae. So I will write the budding yeast or the pseudohyphae. Right? What do you see in the saline microscopy of Trichomonas? Right? What is this? So what you would see here is the organism itself. Do you know why? It is a flagellate organism. Right? So it is a flagellate organism. So you identify the organism with its flagella. Right? So you identify the organism with its flagella. Right? So those are going to be the classic findings on microscopy of these vaginal discharge. Now, the sixth point that I want you to write is how or what extra things that you should know about each of these, right? So the first thing is, for bacterial vaginosis, I want you to write what is called as Amsel's criteria. Okay, so Amsel's criteria say that if 3 out of 4 are met, we will make a diagnosis of bacterial vaginosis. So if I get 3 out of these 4 things, I will make a diagnosis of bacterial vaginosis. So what is these Amsel's criteria? So the first thing is, or the first component is off-white or gray discharge. Yes. So off-white or gray discharge. Second is pH more than 4.5. The third point is clue cells. But what I want you to know here about the clue cells is that the minimum requirement, okay, the minimum requirement of clue cells should be 20%. So at least 20% of the epithelial cells should be clue cells, right? So at least 20% of epithelial cells should be clue cells. And the last is what is called as whiff test. Right? So the last is the whiff test or the amine test, which is when you add 10% KOH and immediately after, if you smell the discharge, it gives a typical amine odor or a fishy odor, right? So when you add 10% KOH and you try and smell it, it's whiffing, right? You get a amine odor. Right? So those are the 4 components of Amsel's criteria, right? And what we said is that we need at least 3 out of these 4 to make a diagnosis. Okay? Okay. What should you know about Candida with respect to this? That the whiff test will be negative, right? So the whiff test will be negative. And what do I want you to know about Trichomonas? That in Trichomonas, the whiff test can be positive, right? So in Trichomonas, whiff test can be positive. Okay. But in the exams, if we ask you, which test is done for, then what would you answer? Then you will answer bacterial vaginosis. Okay. So which test is actually done for bacterial vaginosis, but it may be positive even in trichomonas, right? Next, is bacterial vaginosis a STD? No. So it is not a sexually transmitted disease, right? So it's not a sexually transmitted disease. And therefore, I want you to know that treatment of partner is not done. So bacterial vaginosis is not an STD and treatment of the partner is not done, right? Similarly, for candidiasis, it is usually not a STD. Please remember, I did tell you earlier that candidiasis or candida is a commensal in human vagina. It only overgrows in certain conditions. So what do we write for candidiasis? Treatment of partner is done only if he is symptomatic. So sometimes, yes, it may be transmitted as well sexually, but usually it is not a sexually transmitted disease. So generally you don't need to do partner treatment, but in case the partner is symptomatic, then we might have to treat the partner. What about trichomonas? Trichomonas is a sexually transmitted disease and treatment of partner has to be done. Right? So the treatment of the partner has to be done. Now, usually microscopy is good enough for diagnosis. Okay, what I'm saying is usually microscopy is good enough for diagnosis. But in case there is some doubt, maybe you're not able to make a diagnosis, then what is the best test for bacterial vaginosis? Now, when it comes to best test for bacterial vaginosis, प्लीज डू नॉट मार्क कल्चर. ऐसा लगता है बैक्टीरिया है तो कल्चर होना चाहिए, राइट? सो प्लीज डू नॉट मार्क कल्चर. कल्चर इज यूजलेस फॉर बैक्टीरियल वैजिनोसिस, right? The best test here is what is called as Gram stain, right? So the best test for bacterial vaginosis is Gram stain. It is not done in all patients. It is done only if the diagnosis is difficult, right? If microscopy was not good enough, right? Gram stain may what we calculate is a score which is called as Nugent score, right? So in the Gram stain, we will calculate the Nugent score. And if this score is between 7 to 10, we say this is diagnostic of bacterial vaginosis, right? So if the score is between 7 to 10, we say it is diagnostic of bacterial vaginosis, right? Okay. Again, microscopy is good enough for candida, but if in doubt, then what is the best test? Culture. Can you tell me the culture media? SDA. Yes, Sabarod's dextrose agar, right? So the culture media is SDA, Sabarod's dextrose agar, right? Then best test for trichomonas is again going to be culture of the organism. So one of the medias that I want you to know is Stewart's media, right? So one of the media that I want you to know is Stewart's media. And if I am right, this is the transport media for trichomonas. Yes, so this is the transport media for trichomonas, but you would know more microbiology than I do, right? Now, talking about treatment. So what is the treatment of choice for bacterial vaginosis? So for bacterial vaginosis, the answer is metronidazole. Okay, 500 milligrams BD taken for 7 days, or clindamycin 300 milligram BD for 7 days. right? So metronidazole or clindamycin, right? So 500 milligram and 300 milligram, and it is given BD for 7 days, right? Please remember, if they ask you about bacterial vaginosis in pregnancy, okay, so if they say your patient has bacterial vaginosis in pregnancy and you want to treat her, then again the treatment remains the same. So metronidazole or clindamycin, depending on which one is there in the options, right? So the treatment will remain the same in pregnancy. Okay, coming on to Candida. So what is the drug of choice for Candida? So for Candida, it is going to be fluconazole, 150 milligram single dose. Yes, so 150 milligram orally single dose is the drug of choice for candidiasis. What about in pregnancy? So in pregnancy, we will not give oral azoles. In pregnancy, we will give topical clotrimazole or miconazole. So pregnancy mein we will not give oral azoles, right? So we will not give oral azoles. We will give topical clotrimazole or miconazole. Okay, metronidazole is not contraindicated in pregnancy. It's safe. Okay, आपका knowledge गलत है. Okay, so metronidazole is safe. Then going on to trichomonas. What is the answer for trichomonas? So for trichomonas, the drug of choice is again metronidazole. Again, 500 milligram BD for 7 days, right? So this is also going to be 500 milligram BD for 7 days. And in pregnancy, it is again metronidazole. Okay, it is again metronidazole, right? Now, classically, we might want to ask vaginosis in pregnancy, what is it associated with, right? So remember, bacterial vaginosis in pregnancy is classically associated with preterm labor. Okay, so it is classically associated with preterm labor, right? Is it clear? So have you all written the table down? So this table is very, very important for exams. Yes. So this table is very, very important for exams. Exams se pehle ye table zarur dekh ke jana, right? So for your NEET or your central institutes, both the exams, this table is very, very important, right? Now, if you've all written the table, I will quickly show you the images that you should know from here. So let's quickly see the images. So this is the image in bacterial vaginosis. What are these? So these were what I called as clue cells, right? So these are what are clue cells. So these are the epithelial cells, and do you see that they are studded with bacteria, right? So these are epithelial cells which are studded with bacteria, right? So this is clue cell, and this is actually a pap smear image. So all these three infections, Candida, bacterial vaginosis, or trichomonas, can be seen on pap smears as well. The other image is saline microscopy, right? So the other image is saline microscopy. Now here I have brought this picture because it classically gives you what is a normal epithelial cell look like and what does the clue cell look like. So yahan pe niche wala is the normal epithelial cell, while the one at the top is what is the clue cell, right? So the bottom one is the normal epithelial cell, and at the top is the clue cell. So, you see how it is studded with bacteria, right? Is this clear? So this is what clue cell looks like, okay? Now, let's look at the next image. That's an easy one. Can you tell me what is this? So that's again a pap smear slide. And what are you seeing here? the pseudo-hyphae. Yes, so this is how you will see the pseudo-hyphae of Candida, right? So these are the pseudo-hyphae of Candida, right? So that's how you look at the pseudo-hyphae. Then let's look at the third picture. This is very easy. So that is what is the appearance of Trichomonas vaginalis. And all four pictures are of Trichomonas vaginalis, but they are all at different magnifications and with different stains. You don't have to know the stains or anything. You just need to know that if they give you this as a visual, you should quickly be able to pick it up. So as I said, these are beautiful flagellasms, right? So these, you can very clearly see the flagella, and that's how you look for them in the smears as well as in saline microscopy, right? So they're all four are Trichomonas vaginalis. Is it clear, everyone? Okay. This is very easy to pick up. What is this picture? Strawberry cervix. So that's what I meant when we said strawberry cervix. What you see is punctate small hemorrhages on the cervix, right? So small punctate hemorrhages on the cervix is what is described as strawberry cervix. Okay. Right. So that's the classic appearance of strawberry cervix. Right. Then. Okay. So those were the images that we have talked about so far. Then this is what you should know about vaginitis. Okay. One of the very important things that I want to highlight here is, do you realize that bacterial vaginosis is called as vaginosis? Do you realize this? That it is called as vaginosis and not actually vaginitis. Why? So please remember, in bacterial vaginosis, there is no inflammation. Right? So in bacterial vaginosis, there is no inflammation. So if they ask you, right, if they ask you, will you see polymorphonuclear cells in the discharge? The answer is no, right? So please remember that in the discharge, the ratio of polymorphonuclear cells to epithelial cells will be less than 1. Yes, so polymorphonuclear cells to epithelial cells, this ratio will be less than 1, right? There is no inflammation. So they may try and catch you on this, right? So please remember, it is actually a vaginosis, not precisely a vaginitis. There is no local inflammation. So the ratio of polymorphonuclear cells and epithelial cells is less than 1. Okay. Vagina के ऊपर जाते हैं, क्या आता है? So if you talk about cervicitis, right, the symptoms of cervicitis are very similar to vaginitis. Okay, symptoms are very similar. But this is going to be a mucopurulent discharge. Yes, which means it will be a yellow discharge. So it will be a mucopurulent discharge. That's what is the complaint of the patient. And when you see, yes, so she will see a yellowish discharge. And when you do a local examination, this mucopurulent discharge will be seen coming from cervix, right? So you will see the discharge in the cervix, right? So you will see this discharge coming from the os or coming from the cervix. Along with it, you know, the classic other complaints of the patient can be dysuria. So they present with very similar complaints. So they can also present with dysuria, intermenstrual bleeding, and even postcoital bleeding, right? So the main complaint is generally a mucopurulent discharge, but it may be associated with other complaints also. So what are the other complaints? dysuria, intermenstrual bleeding, and postcoital bleeding. What are the organisms that are associated with cervicitis? So I'm sure you already know this. This was chlamydia and gonorrhea, right? So the most common ones causing cervicitis is chlamydia and gonorrhea. What is the classic appearance? So if you do a per speculum examination of the cervix appears friable. Right? So the cervix appears friable. Right? So there will be discharge coming from the os and the cervix may appear friable. Right? So this is when it comes to cervicitis. And I'm all sure that you know the drugs that we use for cervicitis. So if I specially ask you, right? So if I specially ask you, what is the drug that you want to give for chlamydia? What is the answer? Doxycycline. Yes. So for chlamydia, it is doxycycline. 100 milligram BD for 7 days. But do you know that we can also give azithromycin? Yes, we can also give azithromycin 1 gram oral. Right? So for chlamydia, it is doxycycline, or we can also give azithromycin. Yes? भाई पूरी गायनी की क्लास खत्म हो गई और PS पूछ रहे हो per speculum examination. Okay? Per speculum examination. All right? What about gonorrhea? So gonorrhea, again, we can give ceftriaxone and azithro, right? So ceftriaxone and azithromycin, right? So that's for gonorrhea, right? Azithro remains as 1 gram oral dose, right? Ceftriaxone is 250 milligram IM single dose, right? So 250 milligram IM single dose. That's for gonorrhea. Okay? Now, yes, it is injection ceftriaxone 250 milligram IM single dose. Okay? Now, talking about PID. So, पहली बात तो ये है, how is PID different from these two? So, please understand, vaginitis and cervicitis are not included in PID. PID में क्या होता है? It is a upper genital tract infection. Okay, so it is a upper genital tract infection, which means it should include infection of uterus, fallopian tube, and or the ovaries, right? So uterus, fallopian tubes, and or ovaries. Yes, if gonorrhea is there, then we would preferably give actually both, right? So ceftriaxone single dose along with azithromycin 1 gram oral. Okay? So that is how PID is different from cervicitis and vaginitis. So सबसे नीचे vaginitis, फिर cervicitis और ऊपर चले गए तो PID, right? What is the classic complaint of PID? Or before I go to complaint, what women have highest risk of PID? Now, please remember, as such, all sexually active women, okay, all sexually active women are at risk of PID, okay? All sexually active women are at risk of PID, but the highest risk, okay, the highest risk is with women who have multiple sexual partners, okay, women who have multiple sexual partners, right? Now, in general, PID is a polymicrobial infection, right? So, in general, it is a polymicrobial infection. But if in the exams we ask you, one organism, then the most common single best answer will be chlamydia. If you can mark two answers, so if let's say every option has two organisms, then obviously the better choice becomes chlamydia and gonorrhea. Okay? Then a better choice becomes chlamydia and gonorrhea. मगर अगर एक देना है तो chlamydia. But सबसे अच्छा आंसर क्या है? सबसे अच्छा आंसर है that it is polymicrobial. Yes? Now, on this note, we will ask you some different MCQs as well. For example, most common cause of PID in adolescent, or rather not adolescent, in virgin girls, which means girls who are not sexually active, right? Then this is to be answered as genital tuberculosis, right? So this is to be answered as genital tuberculosis. If we ask you characteristic infection with intrauterine device users. So what is the classic or characteristic infection with IUD users? Then it is actinomyces, right? So with IUD users, it is going to be actinomyces. Okay? Then can you tell me PID is a disease of younger women or older women? Relatively younger or relatively older? So relatively younger. So if you ask age-wise, then actually adolescent girls will be at high risk. Right? So relatively younger women are at higher risk of pelvic inflammatory disease. Okay? Now, coming to what is the classic complaint of a woman who comes to us with PID? So the characteristic complaint is lower abdominal pain. Okay? Lower abdominal pain. It may be unilateral, it may be bilateral. Quite often it tends to be bilateral pain, right? So bilateral lower abdominal pain. And especially, if the girl describes the pain as worsening with coitus, then yes, it quite likely points towards pelvic inflammatory disease. Or if the girl describes it as pain after menses, so not with menses, after menses. So these are certain terms. Our patient describes the pain with these, we know that we are dealing with PID, right? So lower abdominal pain is the general answer. But especially if my patient is describing it as that it worsens with coitus, doctor, or the pain is typically more after menstruation, doctor, then yes, this is a patient with PID. But how do we make a diagnosis? Okay. Now to make a diagnosis, we say lower abdominal pain, right? So lower abdominal pain with any one of the following. So lower abdominal pain with any one of the following, right? What is that? It can be uterine tenderness. Okay. It can be adnexal tenderness. Or it can be cervical motion tenderness. So a woman coming to us with lower abdominal pain and any one of the following: uterine tenderness, adnexal tenderness, or cervical motion tenderness. Cervical motion tenderness means when you move the cervix, the woman winces with pain, right? So this is how we will make the diagnosis, right? So lower abdominal pain with any one of the following. Now, what can be the other complaints? Right? So what can be the other complaints of these women who have PID? They can also have, so along with lower abdominal pain, they can also have discharge. Okay? So they may may also say that there is discharge. Second, intermenstrual bleeding. Okay, intermenstrual bleeding. They may come to us with increased urinary frequency. In some less small number of patients, there may be fever with chills also. This is when the infection is severe, right? So this is when the infection is severe, right? So this is what an acute attack of PID is like, right? So this is what is a description of acute PID. Okay. So a woman who is having acute PID will typically have lower abdominal pain with any one of the following, which is uterine tenderness, adnexal tenderness, cervical motion tenderness. But she may have other complaints also, like discharge, intermenstrual bleeding, urinary frequency, and rarely fever with chills. Now, listen to me very carefully. 10% of girls with PID, right? So 10% of women with PID may present as right upper quadrant pain. Okay, so 10% of women with PID may present also with right upper quadrant pain. Why? Why do they have right upper quadrant pain when the infection is lower down? So this is a condition which is called as Fmge-Curtis syndrome. Right? So Fmge-Curtis syndrome. Right? So what is this Fmge-Curtis syndrome? This development of what? Development of perihepatitis. Okay? Development of perihepatitis in women with PID. Right? So these women develop infection of the liver capsule as well. It is not hepatitis. Please remember the key word is perihepatitis, around the liver, not inside the liver, right? So they will present with, upper right quadrant pain, right? So they will have upper right quadrant pain, right? And please remember, again, Fmge-Curtis can happen with both chlamydia and gonorrhea. But the single most important organism when we ask you, you have to answer it as chlamydia, right? So Fmge-Curtis can be seen with both chlamydia as well as gonorrhea. Magar agar ek organism mark karna hoga, then you will answer it as chlamydia, right? So the single organism that you will mark will be chlamydia, right? Is this clear? Now, once you know how PID presents, yes, I want to ask you a few things. Should you do a urine pregnancy test? Yes, right? A reproductive age woman presenting to you with lower abdominal pain, menstrual irregularity, urine pregnancy test should be done. Right? So if she has pain along with abnormal bleeding, you must do a urine pregnancy test as well. Okay? Then, if there is a discharge, needless to say, you should do a microscopy of the discharge. Yes, so we should be doing a microscopy of the discharge. Okay? Then the other tests for sexually transmitted diseases like HIV, syphilis, right? These should also be done. right? So other tests for sexually transmitted diseases like HIV or, syphilis, these should also be done. Coming to among the radiological investigations, the first investigation that we will do is ultrasound, right? So the first investigation that we do is ultrasound. Okay. Now, please remember, I don't want you to know any details, but just this much, that there are 3 ultrasound signs of PID. I just want you to know the names and I will show you the pictures. Okay? So the 3 ultrasound signs of PID are, the first one is called as cogwheel sign. Okay? It's called as cogwheel sign. I'll show you what the sign is. The second one is waist sign. Okay? WAI, waist. Right? Kamar. So waist sign. I'll tell you why it is called as waist sign. Right? And the third is beads on string sign. Right? So the third is beads on string sign. Right? So these are the 3 named signs which are seen in ultrasonography. Let me quickly show you these 3 signs. So these are the 3 signs that I want you to see, right? So this one first, if I put it as A, is what is the cogwheel sign, right? If you see, this is a dilated fallopian tube, right? So there is a dilated fallopian tube like this, and you feel that there are spokes of a wheel inside. Right? So this is all due to development of adhesions inside, and dilatation का क्या मतलब होता है? Hydrosalpinx. Yes, a dilated tube means hydrosalpinx. Right? So this is what is the cogwheel sign. There is development of adhesions inside. Okay? This is the second sign. This is again a dilated fallopian tube, but then suddenly there is a narrowing here. This narrowing is what is called as the waist sign. Patli kamar, right? So, patli kamar is what is waist sign. Why? Again, due to development of adhesions and strictures, right? So, due to development of adhesions and strictures. So, the tube is dilated, but there may be a sudden narrowing. Okay. Then the third sign is this. So this is the beads on string sign. So if you see, this is again a dilated fallopian tube, and here you are seeing beads. Right? So this is the beads on string sign. Now मुझे जल्दी से याद करके बता दो, right? जल्दी से याद करके बता दो, beads on string HSG पे किसका साइन था? Right? So beads on string HSG पे किसका साइन था? Tuberculosis. So when you see it in HSG, it is genital tuberculosis. But here we are talking about ultrasound. Right? So don't get confused. Right? So ultrasound is, beads on string is PID. HSG and beads on string was genital tuberculosis. Right? Okay. Sometimes we may also do a endometrial biopsy. Right? Sometimes we may do a endometrial biopsy in these women. Then please remember, if the endometrial biopsy report comes as plasma cell endometritis, then this is what is chronic endometritis. And the causative organism is chlamydia, right? So the causative organism is chlamydia, right? And why would we be doing an endometrial biopsy? Because these women with PID can also have infertility. लेकिन अभी बाद में बताऊंगी what I want you to know. So here I'm just telling you, why are we doing an endometrial biopsy? Because sometimes these women may present with infertility, and then if on endometrial biopsy you find out plasma cell endometritis, then this is classic 2 chronic endometritis, and this is seen with chlamydia. Okay? Finally, the gold standard investigation. Okay, the gold standard investigation for PID is laparoscopy. Okay, or a diagnostic laparoscopy, right? So diagnostic laparoscopy is gold standard, but it is very invasive. Yes, and here in laparoscopy, you will actually be able to directly see the fallopian tube. For example, this is a classic sign for or classic finding with PID. You see that the tubes are grossly dilated. Kitni moti tubes hain? So this is again what? Hydrosalpinx, right? So you can see the grossly dilated fallopian tubes. You will be able to see the adhesions also if there are adhesions. Yes, you remember I showed you a photograph in infertility of frozen pelvis. Do you remember that picture? Yes. So frozen pelvis can also be seen with PID. Do you remember I taught you this? So where you would see lots and lots of adhesions. Yes. So frozen pelvis can also be seen. But I taught you there also. If we say frozen pelvis, what is the single best answer for frozen pelvis? Genital TB. Do not first answer PID nahi hota, right? So if we ask you the first answer for frozen pelvis, you should answer it as genital tuberculosis. ठीक है? जल्दी से देख के बताओ ये क्या है? What is this? What is this? So this is what is perihepatitis. This is a photograph of Fmge syndrome. Why I want you to see this photograph is because the appearance of these adhesions is very characteristic. These are called as violin string adhesions, right? So these are called as violin string adhesions of Fmge syndrome. So whenever you see these adhesions, you should be able to know that these are the violin string adhesions of perihepatitis, which is Fmge syndrome, which is seen in women with PID. और ये adhesions किसके और किसके बीच में है? Liver capsule and anterior abdominal wall. Okay, so liver capsule and anterior abdominal wall. Right? So remember, diagnostic lab is the gold standard. Also, sometimes if needed, I can also take a biopsy, and then the biopsy will be taken from the fimbrial end of the tube. Right? So biopsy अगर लेना होगा तो कहां से लेंगे? We will take the biopsy from the fimbrial end of the tube. Right? किसका वायलिन बजाने का मन कर रहा है भाई? Okay, so बेकार है infection गंदा सान. Okay, पता नहीं नाम इतना अच्छा क्यों है. So violin string adhesions, right? So this is what you should know about acute PID. What is the treatment for acute PID? The treatment for acute PID is, if the patient is sick, then we might have to give inpatient treatment. Otherwise, we can also give outpatient treatment. So this will depend on severity of the symptoms. Okay, agar inpatient treatment dena hai, then we will give injection cefoxitin IV every 6 hourly, right? So 2 grams cefoxitin IV 6 hourly, right? And along with this, we will give doxycycline 100 milligrams BD IV, right? So 100 milligrams BD IV. अगर outpatient treatment देना है, right? If we have to give an outpatient treatment, then it will be the same. Ceftriaxone, 250 milligrams IM, single dose, along with doxycycline, 100 milligram BD for 14 days, right? So 100 milligram BD for 14 days. Is it clear, everyone? Then, once we know this part, talking about what is the long-term sequelae. So what is the long-term complications of PID? Okay, so the long-term treatment of PID or complications of PID can be infertility. So please remember, infertility is not a presentation of acute PID. इसलिए acute में नहीं लिखवाया. Okay, so this is the long-term complication of PID, which is infertility. Then, what else? Ectopic pregnancy. Okay, ectopic pregnancy. What else? Hydrosalpinx. What else? Chronic pelvic pain, right? Chronic pelvic pain, okay? And finally, what else? It can also cause recurrent, okay? It can also cause recurrent PID. Your exams are fond of asking, light chali gayi thi meri, okay? So light had gone. So your exams are fond of asking long-term complications. Okay. So long-term complications are infertility, okay, ectopic pregnancy, hydrosalpinx, chronic pelvic pain, recurrent PID. The order in which I have written is important. Okay, so the single best answer will always be infertility, followed by ectopic, followed by hydrosalpinx, followed by chronic pelvic pain. Okay, chalo. So this was what you should know about infections. Okay, now just a few words that I would want you to know about fistula. Okay. Just a few words that I want you to know about genitourinary fistulas. So, what are genitourinary fistulas? Okay, the genitourinary fistulas are abnormal connections between genital tract and urinary tract. Okay, so abnormal connections between genital tract and urinary tract. Now the most common, okay, the most common genitourinary fistula is VVF, vesico-vaginal fistula. इसके बाद कौन सा आता है? Uretero-vaginal fistula, मतलब between ureter and vagina. हाँ जी बेटा, सेफ्ट्राइएक्सोन IM होता है, सेफॉक्सिटिन IV है. ये तो फार्मा है ना बच्चे, ठीक है? So uretero-vaginal fistula, and the least common is urethro-vaginal. Okay, between urethra and vagina, right? So most common is VVF. Now the first thing that you have to know is, what is the most common cause of VVF? So please remember, the most common cause of VVF in developing countries, जैसे कि India, is obstructed labor. So अभी आप OBS में पढ़ोगे what is obstructed labor, right? So the most common cause of VVF in developing countries is obstructed labor, but in developed countries, it will be as a complication of gynecological surgeries or as a complication of radiation therapy, right? The single most answer here is gynecological surgeries. Okay. Now, coming on to how would a patient with fistula present? So, a patient who has the genitourinary fistula will present as continuous leakage of urine, right? So, continuous leakage of urine, which is painless. It will not be associated with urgency, not be associated with features of stress incontinence. Yes. So which means not aggravated by coughing, sneezing. Okay. So there will be no features of urgency and there will be no features of stress incontinence as well. Right? So continuous leakage of urine, which is painless, is what should make us think of vesicovaginal fistula. Now, please remember, yes, Divya, you are right. Now, please remember, inpatient में oral देंगे, IV देंगे, doxy, और outpatient में oral doxy देंगे. Okay, Divya? Right. Now, when it comes to continuous leakage of urine, we think of VVF. Now, please remember, if VVF is happening after a gynae surgery, then it is a delayed complication of gynae surgeries. What do you understand by this? Which means it will not present within 1 day, 2 days, or 3 days. Yes, it's a delayed complication, right, which will present later. Right? So these fistulas which happen because of surgical complications will happen relatively after a gap from the surgical procedure. Right? So they will happen after a gap from the surgical procedure. Right? Usually the first presentation will come 7 to 10 days after surgery. Right? So the first presentation will come 7 to 10 days after surgery. Okay. Now, coming to how do we make a diagnosis whether my patient has a VVF or a ureterovaginal fistula? So the first thing is look at the patient's history. If the history is continuous leakage and no acts of mituration, then this goes in favor of VVF. Can you tell me why? Can you tell me why? Because whatever urine beta G is coming to the bladder, it is escaping out from the vagina. So nothing is collecting inside the bladder. So the patient never has a desire to pass urine, right? So there will be no acts of normal coitus. Okay. Whereas what will be the patient's complaints if it is ureterovaginal? She will have continuous leakage. Sometimes it can be intermittent also. So with ureterovaginal fistulas, sometimes it can be intermittent leakage also. It depends on the size. Okay. So continuous leakage or intermittent leakage. But the most important thing here is with normal acts of maturation. So here the patient will pass urine also. Why? Because some amount of urine is always reaching the bladder. Right? So some is escaping from the fistula, but some is also reaching the bladder. right? So eventually bladder kabhi na kabhi full hoga and she will have a desire to pass urine. So if the continuous leakage has no acts of, right? So if it has no acts of maturation, then it is VVF. Okay, if it is associated with acts of maturation, then it is ureterovaginal. Okay, then it is ureterovaginal fistula. Okay, is it clear everyone? Right. Test कौन सा करते हैं? So investigation of choice. Investigation of choice is 3 swab test. Okay, the investigation of choice is 3 swab test. So what do? You are going to put dye into the bladder. So retrogradely, you will put dye into the bladder like methylene blue or indigo caramine. Right? So retrogradely, we have put the dye in the bladder. Now what do? You keep 3 swabs in the patient's vagina, one below the other. Right? So you will keep 3 swabs in the patient's vagina, one below the other. Now you will see what is the staining of these swabs. Okay, listen to me very carefully. If the upper 2 swabs are wet and stained, then this is a VVF. If only the lower swab is wet and stained, then it is urethra, okay, ureterovaginal fistula, right? So if it is only the lower one, then it is ureterovaginal fistula, right? And if only the top swab is wet, only top is wet and not stained, तो कौन सा होगा बताओ? If only the upper swab is wet and not stained, then what is it going to be? Then it is going to be ureterovaginal fistula. And I'm sure you know why is it not stained. Okay, why is it not stained? Because we have put the dye in the bladder, right? So if only the top one is wet but not stained, then it is ureterovaginal fistula. Okay, ureterovaginal fistula mein the urine is coming from ureter into the vagina, not from the bladder into the vagina, and the dye has been put into the bladder. Right? So if the upper one is wet and not stained, it is ureterovaginal. ठीक है, समझ में आ गया सबको? So the investigation of choice is 3 swab test. Right? So you will have to combine the 3 swab test and what is written in the history to give the answer whether it is VVF or whether it is ureterovaginal fistula. Right? Lastly, when are we going to, or what is the surgery that we are going to do? So the most commonly done surgery for VVF is called as LATSCO. Okay, it's called as LATSCO, right? So LATSCO is the most common surgery that we do in VVF. Right? You don't need to know the details, just know the name and know that this is a vaginal surgery. Okay, so this is the most common surgery and this is a vaginal surgery, right? So let's go. Also remember that after you have operated, you have to keep the Foley's catheter for 14 days. Right? So you have to keep the Foley's catheter for 14 days after you have done the surgical correction. This is also a very potential MCQ. Right? So you should keep the Foley's catheter for 14 days. Is it clear, everybody? Right. So this is what you should know about VVF. Don't bother to go into more details. जो भी MCQ आएंगे वो यहीं से आएंगे. बहुत ज्यादा टाइम वेस्ट नहीं करना है. This is good enough for exams. Right. So 3 swab में फिर से बता देती हूँ and then we are done for the day. Right. So 3 swab test में we have put the dye in the bladder. Right. Like methylene blue. We can also put indigo caramine. Then we keep 3 swabs in her vagina. One at the top, then another uske niche, another one uske bhi niche. Then you will see which swabs are stained. So if it is the upper 2 which are stained, it is going to be bladder. Remember, the bladder is in the upper 2/3 of the vaginal wall. Lower 1/3 is not bladder. Yes, you remember cystocele? I told you cystocele is in the upper 2/3, right? So if the upper 2 are wet and stained, okay, it is going to be vesicovaginal fistula. Okay? And if it is only lower 1 stained, it is urethrovaginal fistula. एक बार याद कर लो, urethrovaginal आंसर मार्क मत करना. इट इज अ वेरी रेयर थिंग. यू शुड नेवर मार्क रेयर थिंग्स इन योर एग्जाम्स, नहीं तो बहुत रेयर मार्क्स आते हैं. ठीक है. सो आंसर ज्यादातर या तो VVF होगा या urethrovaginal होगा. यूरिथ्रो में क्या देखना है? द अपर वन विल बी वेट बट नॉट स्टेन्ड बिकॉज यू हैव पुट द डाई इन द ब्लैडर. राइट. सो दैट्स व्हाट यू नो अबाउट द 3 swabs test. In general, if we ask you the best investigation for VVF, the best investigation for VVF is cystoscopy. ये एक और लिख लो. The best investigation is cystoscopy. Why? This is something that we will do pre-operatively, right? So this is something we will do pre-operatively. This will show us the exact size of the fistula, the site of the fistula, and whether it involves the ureteric openings or not, because the surgery will depend on these parameters. So cystoscopy we do pre-operatively to look for site of the fistula, the size of the fistula, and whether the fistula involves the ureteric openings or not. Right? So don't answer it as the IOC. The investigation of choice, okay? The investigation of choice is 3 swab test, okay? It is going to be the 3 swab test, right? So this is what you should know about VVF. I said don't bother about too many details. They don't ask in the exams. It's not required, okay? Do this. You should be able to solve the questions that come in your exams. Right? So vaginal and vulval cancer, we don't do it in class. It's a rare MCQ. तो जब सब कुछ पढ़ लोगे बच्चे सिवराम, और अगर वेजाइनल कैंसर या वल्वल कैंसर पढ़ने का मन हो तो एम्स कैप्सूल खोल लेना. You have vulval cancer in the AIMS capsule, right? It is hardly ever asked as an MCQ, and I believe that you should put more of your energy on things which are likely to be asked. Right? So when you have done everything else from your class notes and you want to read vulval cancer, please go to AIMS capsule. In that obs and gynae part, I have discussed vulval cancer as well. Okay? So I will rather suggest that you do it maybe close to your central institutes. Right now, don't waste your time on it. It is not required. Okay? Chalo. Any other doubts that you want to ask? Okay. So now, I have tried to give my best, okay? So आप लोगों का भी फर्ज बनता है अब to give your best, okay? एक टीचर के लिए सबसे अच्छा दिन कौन सा होता है? Do you know that? जब आप लोग अच्छा परफॉर्म करते हो, right? You get the branch of your choice and you send a message to us that madam or sir, I have secured this rank and I'm going to become a radiologist. I'm going to become a neurosurgeon. I'm going to become a gynecologist, right? So those are the days that make us happy. Those are the days that make us what we are. Yes? So वो जो खुशी है, वो मैं चाहती हूँ कि आप सब हमें दो. एक बार सारे बच्चे, you know, you have to work to that level that you are able to reach where you really want to reach, right? And you're working so hard. The only thing you need is dedication and discipline, right? अगर discipline का साथ छोड़ दोगे तो फिर आगे जाना मुश्किल हो जाता है. It becomes difficult to stick to your path. Sticking to your path is what is the most important thing, right? No matter how old you get, no matter how young you are, if you want to achieve big in life, you have to stick to the tasks that you have taken in your hand. So you will all ensure कि आप सब खूब मेहनत करोगे. और मेरे हिसाब से ना मेहनत किसी और को बताने के लिए नहीं होती. You don't work hard to tell anyone else that you are working hard. जब अंदर से ऐसा लगे that you are not cheating your own self, you have to be truthful to yourself for every moment, right? So when you get this feeling from within that you are not cheating yourself, you are doing what you can maximally do. That is the level I want you to achieve. I don't want you to tell anyone else how hard you are working, your mom, your dad, your teachers. No. The only realization is self-realization. I want that हर बच्चे को वो feeling अंदर से आनी चाहिए कि I am being truthful to myself. मैंने जो आज अपने दिन में किया वो मेरा best shot था. I don't care what happens after that. You have to reach this zone where the result is not mattering to you because you are being truthful to yourself in giving your best shot. That is where I want you to reach. Okay? And you guys have seen us so many times on camera in the classes, but unfortunately, we couldn't see you this year, right? So if I make a small request, I would love to see you guys on screen. So send me a picture on the Facebook club. Or साथ में anything from the class that you remember, you can write there, right? You can also make it as an Insta story. You can put a picture with your class notes. Anyway, जिस तरह से भी आपको लगता है कि आपको मेरी क्लास की एक मेमोरी रहेगी कि हमने मैम को एक प्रॉमिस किया है. What is that promise? Promise of being truthful to yourself, right? So post a picture wherever you want to, maybe club, maybe Instagram, anywhere where you're comfortable, right? And maybe you can write a small memory of the class that we shared. I will also cherish those memories and you will also cherish. And we will keep these memories for your result day. Okay? We will keep them for your result day. And this photograph, this picture that you're going to take is going to every time when you go away from your path, वो मेरी याद दिलाएगा कि मैम ने promise लिया है और मैं जब promise लेती हूँ तो मैं रखती भी हूँ and I want other people to keep the promise as well. Okay? So promises have to be made, they have to be kept, and you have to be truthful in keeping your promises. Right? So Dr. Sameer has joined us. Welcome, Dr. Sameer.
और वो फोटो मेरी क्लास की भी हो सकती है, जरूरी नहीं है कि दीप्ति की क्लास की हो. इट कैन बी माय क्लास फोटोग्राफ एज वेल, है ना. और रेडियोलॉजी में वैसे भी विजुअल ज्यादा अच्छी लगेगी मुझे लगता है.
Very much. And we guys totally enjoyed. I think August was a month where we spent the entire month with you people. And just to tell you a little about कि सिर्फ आप लोग मेहनत नहीं कर रहे हो, I would like to say a small thing about कि आपके टीचर्स भी बहुत मेहनत कर रहे हैं. पिछले 1 महीने से मेरे घर में टीवी नहीं चला है. I have a small child. He's 8 years old who is not even going to school, right? He is with us and he's been so supportive. उसने कहा भी नहीं कि मैं टीवी देखूंगा, right? Just because कि वो इंटरनेट बंद नहीं होना चाहिए, right? कि वो इंटरनेट जिससे क्लास चल रही है वो बंद नहीं होना चाहिए, right? So when Dr. Sumer takes a class, I'll be around कि कोई flickering नहीं होना चाहिए, लाइट जाएगी तो क्या करना है, right? पानी पीने के लिए भी we don't get up. I'm not trying to say कि हम महान हैं या कुछ हैं. I'm just saying कि दोनों तरफ से मेहनत लगती है to bring desired results. So हमें वो ensure करना है कि हम वो मेहनत हम करें. हमने ensure करा है, आप भी ensure करोगे कि वो मेहनत आप करोगे, right? So you also have to give in that kind of effort where you feel proud of yourself and as I said you feel happy with what you have done. वो बहुत जरूरी है. सर तो बार बार बोलते हैं नो रिग्रेट्स, नो रिग्रेट्स. सो यू हैव टू फील हैप्पी विद व्हाट यू हैव डन. बिलीव मी, रिजल्ट अच्छा आएगा ही आएगा. ऐसा हो ही नहीं सकता ना आए. राइट? एंड आई एम a जीता जागता example of that you don't have to be super bright to do well in your life, to be a good doctor or to be a good clinician. I was a very average student throughout, but I knew this little fact about my own self, that I am average. So I knew one thing, that the only way I have is to work hard. So I knew this little thing about myself, and I was truthful about it to myself. I wasn't shy. I'm not shy right now also saying that I am an average person. I'm very proud of what I am, because this averageness has given me the constant push in my life. It has told me to work hard. So even if you have some negative aspect, जिसको लोग negative कहते हैं, आप उसको positive में convert करो. Right? So somebody might have said there some negative thing about you. Right? Let them say. You convert that negative into positive. उसको अपने plus point में convert कर दो. So even if it is average, I have said it in one of my podcasts as well, average is awesome. Simply because average people don't know when to stop. So they keep going on and on and on. वो मेहनत करते रहते हैं. Right? So you should all do that. You should feel happy about what you are doing. Results will be good. Okay? So we will talk a little bit about strategy as well today. Right? We'll guide you on what to do further.
Quickly ना आप लोग को बच्चे, will show you a small graph in front of you. Please see. I'll give you the goals of each month. And before that,
okay, before we give you the goals,
I'll just call Krish to.
Krish is going to come. He's a little sleepy and tired, but he'll say hello to all the great Bhaiya Didis. So Krish, they're all doctors, and they are the future specialists and the future of this country. Okay, so say thumbs up to all Bhaiya Didis. Okay.
So I want you to see, beta. I am going to give you clear goals for September, October, November, December. Okay. So people who have an exam this year, September is the month to finish the syllabus. September का गोल याद कर लो बेटा, कोर्स खत्म करना है, क्लास खत्म करनी है, नोट्स खत्म करने हैं, क्वेश्चन बैंक खत्म करना है. सितंबर का गोल है फिनिश योर क्लास एंड DQBs. अक्टूबर का गोल होगा रिवीजन एंड वी विल हेल्प यू इन रिवीजन विद DVT. वी विल हेल्प यू फॉर रिवीजन विद DVT बेटा. नवंबर का गोल होगा सेंट्रल एग्जाम्स, वन मोर रिवीजन. दिसंबर का गोल होगा फाइनल रिवीजन, CBT, practice, more grand test, revision. Okay, so this has to be your strategy for your final years. Okay, I just wanted you to see a quick ideas that we have. I'll just show you some of them. ठीक है, सारे नहीं दिखाऊंगा, एक ये देख लो. So September 22 onwards, I already told you, on eMedicos we will start doubt solving sessions. Doubt solving sessions में the teachers will be available to you live on the eMedicos app. है ना, उससे आपने टीचर से रिवीजन करवाना है या कुछ पूछना है, वो आपके ऊपर है.
राइट, आप कहोगे टीचर को कि कोई
टीचर विल बी सिटिंग देयर फॉर यू फॉर दोज आवर्स. सपोज अगर मैंने 2 घंटे अलॉट किया तो 2 hours आई विल बी देयर. यू कैन आस्क एनीथिंग यू वांट टू, and I will schedule separate sessions for junior बच्चास and senior बच्चास,
छोटे और बड़े बच्चों,
doubts can be of
आप
those
लोगों को हम अलग कर देंगे. अब अलविदा कह दो एक दूसरे को. Right, so doubt solving will be separate. So whatever you want to ask in those 2 hours, 4 hours, the faculty will be continuously there on the eMedicos. लेकिन आपके ऊपर है, आप कितनी देर तक कुछ पूछना चाहते हो. आप आके पूछ सकते हो. You can log out, you can come back again, ask an MCQ, or even ask the faculty to teach you a topic. Right? So it will be like a one-on-one, and faculty will be at your discretion. आप जो उन्हें कहोगे वो वैसे आपके लिए करेंगे.
And plus these will be happening multiple times, so it is not like कि आपने मिस कर दिया, कोई बात नहीं, ये multiple time करेंगे. एम्स के एग्जाम तक they will be happening, so that you have ample time to talk to teachers. Just like we used to do in the face-to-face class. I don't want you to miss the face-to-face class this year. जैसे face-to-face class में break में टीचर के पास आके खुल के बात करते थे, जो जानना था बात करते थे, वैसी जगह मैं आपको फिर से दूंगा. Okay? Another thing I want to remind you is that आप में से जितने भी बच्चे रेगुलर कोर्स के हैं, you will have a big revision session with us called as DVT in the mid-year, in the mid-October.
And we will make it dance level, okay? It will be really, really super for your revision. Short में जल्दी से 19 subjects को most effectively, most high yieldingly कैसे revise करना है close to exams, उसके लिए there will be DVT for you, okay?
And I'll request all the third year and fourth year students, if they are around, to say best of luck to your senior bachas right now in the chat box also. है ना? अब उन सबको best of luck करना. And I also want to point out to all of you that gradually the students who are going to give exam this year, you have to increase the frequency of your grand test. अभी आप महीने में एक दे रहे हैं, even if you're giving once a month, okay. But then gradually in October we will start giving once every 2 weeks. In December, we will give one every week. In December, we will give one per week. But grand test को बढ़ाना शुरू करना बेटा. We have to increase the frequency of grand test. Okay? And I also want to point out to you that we will be having 3 more CBTs this year. Lot of students are asking CBT क्या होगा? CBT will be held in computer centers. But considering the situation this year, आप पे करने की भी option दी जाएगी. If you are in a containment zone, you can do it at home also. There will be 3 CBTs conducted this year. 13th October will be AIMS pattern. 18th October will be Neet pattern. 13th December will be the final Neet PG CBT that will happen. Okay. So keep those dates in your mind. Okay. And I also want to point out to the regular batch students कि revision करते समय अभी आप September में please finish your class tests. So that when you're revising, you can pick up another test called as SWTs from the online test series.
Okay, here I would like to add something. I had given August में DQB promise, and the students have been absolutely amazing in following it. Tomorrow, I think 10 p.m., me and Dr. Sumer will come live on the Facebook club, and we are going to come with new targets for you all. Okay, so join us in the Facebook tomorrow in the club itself. We'll be live there at 10 p.m. tomorrow after your class is over, and we'll talk about some more targets for you, how to keep you on track, right? And then again, we'll take all kinds of queries that you have with respect to your study or planning or whatever, okay?
And I also want to tell the students, tomorrow we will announce the date of DAMS Grey Matter quiz also. DAMS Grey Matter quiz, the preliminary round will be conducted in September on the eMedicos app. Then the final will be conducted on DAMS Daily YouTube channel, and the winner will get 50,000 rupees. So it's a big, big quiz nationwide. All the students from the entire country participate in this quiz. Tomorrow I will announce DAMS Grey Matter quiz also, beta. Okay. And finally, I want you to have the targets very simple, clear for you. September का टारगेट है finish your class tests, finish your classes, finish your DQB. एक बार one reading खत्म करनी है पूरे सितंबर के अंदर. अक्टूबर का टारगेट है revision, DVT, SWT, GT, and we will help you with live doubt solving on eMedicos. Okay? AIMS से पहले we need to add AIMS capsule, previous papers. नवंबर दिसंबर में टारगेट होगा revision of notes, CBTs, grand test, DVT revision. This is how we will go about till the end. So we thought that today we will just quickly show you the methodology of how to go about the future as well. Okay. And now we want to finally, leave you with a task. Like, Deepthi has already talked about that. A same task is from my side also. If you find anything interesting from the workbook, please, send a picture of yours with the workbook. Show me the quality of notes that you have made.
Yeah.
I've already seen many of you have made quality notes, beautifully labeled images in the workbook and all that. It's so beautiful.
Dr. Sumer wants to see your notes, but I want to see you all because that gets me connected to you. I want to see your picture with some memory of the class ताकि मुझे याद रहे ये वाला बच्चा था और ये शैतान था या ये अच्छा बच्चा था. Write your quality as well. In fact, write this. With the picture of the class and yourself, write one quality about yourself. ये लिखो, चलो. Right?
Now I will
one
request,
quality about yourself.
Yes. And now I'll request the senior wala bachas to tell us who is the best junior that you met in this entire lockdown period on the eMedicos chat. इस chat में सबसे बढ़िया junior कौन सा मिला आपको? बड़े बच्चे
बताएंगे कि उनको कोई छोटा बच्चा अच्छा बच्चा लगा कि नहीं लगा, ये सारे गंदे बच्चे थे। छोटे बच्चे शैतान हैं, है ना?
I think, Mimamsa would be on the top of the list, I think.
Okay.
Farhan, Shinchan, Mohta Bhai, Anudeep, okay. So great. So we could create, आज हमने एक ऐसी चीज की है जिसको आज आप वैल्यू करें कि आज आपने इस पिछले 6 months में you all have created relationships. You have created a invisible thread which is binding all of you, all of us together. है ना? Situation मुश्किल थी, there was a lockdown going on, pandemic था, चिंता थी, बहुत मुश्किल टाइम था, but we could all pump each other up, we could boost each other up, we could be together in this scenario, and this situation will pass, normalcy will come back. We just need to hold on, stay positive, beta. And I also want to tell all of you that once you will be through this, you have a story to tell to your grandchildren that once upon a time there was a pandemic and you had, your colleges were off, everything was off, but you would remember that dance classes were going on at those times. सब भूल जाओगे जब आप grandfather बन जाओगे, grandmother बन जाओगे, but at least you will remember the emotion that we will have today. ये feeling नहीं भूलोगे आप कि यार हाँ सर उस दिन मजा तो आया था, है ना? That is my dream that one day if I can meet you as a head of department or as a professor, as a neurosurgeon, as a cardiac surgeon, it would be a great exercise. I also want the junior bachas to know that new challenges are coming up for you in form of next. And we have done multiple seminars. I'll keep doing more of them for you.
And the chota bachas, you better get serious now, okay? Things are, I wouldn't say they are tough, but they need all your, attention in the form of concept clearing and application of concepts. Yes. So next में ये बहुत जरूरी है. And even I would like to tell something to the students here who are our regular batch students कि आज MCI का एग्जाम हुआ था बच्चे और उसका पेपर बहुत क्लिनिकल आया है.
Just like we predicted.
जैसे हम तुम्हें पढ़ा रहे हैं.
I want all of you to understand that students who are appearing for MCI screening, they will come to us and they will say, "Sir, आप लोग ज़्यादा पढ़ा रहे हो, इतना conceptual नहीं आएगा, one liner आएगा."
MCI को ये थोड़ी चाहिए होता है.
And we keep telling them, भाई ऐसा नहीं है. And this year MCI screening has been a totally clinical paper, just like we predicted. The more full of clinical vignettes, full of visuals. No one-liners, वो कबाड़ा जो सब बाजार से खरीद रहे थे बच्चे, totally बेकार.
So please remember, जो आपको हमने clinical vignette TND free में दिया है इस साल रेगुलर के साथ, please use it. आपको वो बहुत अच्छा लगेगा. And जो classes आपकी conceptual हुई हैं इस बार, completely conceptual applied clinical classes, you will really understand the difference of these classes once you face the exam. Yes, the paper is going to be clinical. It is going to be applied. So the more you are, strong with your concepts and application, the stronger you will come out, right? So use the clinical vignette TND as well for your revision.
And I would again request you, stay positive, stay motivated. Things will happen. Sab kuch hoga. You have done a great thing by coming into this medical profession. आगे भी अच्छा होगा. You will make, a big name in future. अपना ध्यान रखेंगे. Don't worry about people telling you. थोड़ा बहुत लोग बोलते रहेंगे तू पढ़ रहा है अभी तो मैं तो कमा रहा हूँ और ये सब थोड़े टाइम की बात है. Gradually you will have a social status which other people do not have. वो अभी लगता है जब हम 3rd year 4th year MBBS में होते हैं ऐसा लगता है कि बाकी लोग अच्छा कर रहे हैं या others are doing better. It is not like this. Another 5-6 years, you will find out the difference. You will know what status a doctor has in the society is massive. आप बहुत अच्छा कर रहे हैं, आगे भी आप बहुत अच्छा करेंगे. I wish a happy Onam to all the students from Kerala who have joined us today. And I can see still, Vinod is still trending on the chat.
बस करो बाबा, कितना टाइम करोगे?
भाई विनोद को तो छोड़ ही दो, है ना? And I also want to tell the final year students, take care of yourself. We will be announcing another set of case presentation, and next set of case presentations that we will schedule tomorrow will be of ophthalmology and pediatrics. उनका case presentation भी हम आपका करवाएंगे बेटा.
So with this little chat today, we'll say goodbye with a heavy heart.
But we might have missed a lot of your comments, so please write them on the Facebook club. Let us know. We want to connect back to you. We want to talk to you, and we want to
we will see you
make sure
tomorrow.
that we keep connecting to each other again and again.
Yes.
Tomorrow we'll come live on Facebook club as well. This week we could not come for obvious reasons. Either of us was having a class. So tomorrow we'll come 10 p.m. in the night. We will come live on the Facebook group, take more of your queries, help you make a better strategy. Stay positive till then, and I'm sure ये समा भी निकल जाएगा. I'm sure, और आप आगे भी बहुत अच्छा करेंगे. Stay positive. Make sure that you convert this situation into your opportunity. Convert this crisis into an opportunity. Work harder. Put in more time. लोगों को नहीं सोचेंगे. लोग कुछ भी कहते रहेंगे. We will not let people tell us what we want to do in life. Okay, we will not let people rule us out. We will not let the opinion of people govern what we will become. We will become what we want to become. हम वो करेंगे जो हम करना चाहते हैं बेटा. Stay positive. You have the potential. You have the capability. God bless you. We wish you all the best. Deepti, final words.
Bye. I would just say I totally enjoyed teaching all of you. And I would again say something that I always say. Thank you for giving me an opportunity to be with you, to teach you, because it's a learning experience for us as well. Every time we sit with students, we learn something new, and this is how knowledge continues, right? So I wish you all the very best. We are still around. We will be around until and unless we make you reach where you want to reach. This is just a little official goodbye as far as classes are concerned, but not otherwise. We are going to stay around. We are going to be cushioning you. Don't worry.
And I want to tell you once more that I hope you enjoyed my dancing skeleton that I used in radiation physics class today. So I'll end up with some music playing so that you can enjoy the night.
All right, guys, welcome back. After the forced break, there was again small issue, not a very big issue. I think that issue is resolved now. So let us continue our discussion. We were talking about give me 1 second. Yeah, so we were talking about the gestational age classification. That baby is called as preterm, term, postterm according to period of gestation, and then there is a sub classification of early term, term and late term. And yes, after you are written about the gestational age classification, then let's talk about the length of the baby. What is the length of the baby? Length of the baby is gestational age in months, the square of it would be the length of the baby. This is valid for first 5 months. Yeah, gestational age in months square would be length of the baby for first 5 months. Am I audible? Is everything visible? Yeah, give me 1 second. Guys, am I audible? Yeah, I switched off the fan. I hope you people are able to hear. Okay. So fan was creating chaos. Alright, guys. So yes, I am without fan. AC is not working over here. I feel like I'm a villager. Yes, length of baby, gestational age in months square, and then length of baby is gestational age. gestational age multiplied by 5 after 5 months. Yeah, this rule is called as Haas's rule. Yeah, this rule is called Haas's rule. All fine, all fine. I have switched off the fan, no problem. Yes, guys. So we have covered the weight of the baby. So nice of you. The world is still full of good people, and world is still survivable, guys. So yes, there are happy people. There are nice people all around. So there are few good people over here. Many good people over here. I can see the chats. So we have covered length of the baby. Then after length of the baby, let's talk about fetal hematology. What changes, what things are seen, what things are to be understood in hematology. Earliest site of erythropoiesis. Earliest site of erythropoiesis would be considered as yolk sac. Then there will be shift and there will be erythropoiesis happening in liver and spleen. Then finally bone marrow. Now you need to write down this. This is the sequence of erythropoiesis site. Earliest site would be yolk sac. Then liver and spleen. Then bone marrow. Yeah. Yolk sac produces one of the most primitive hemoglobins known, Gower 1 and Gower 2. These are the hemoglobins produced by yolk sac. Yeah. There is one more hemoglobin produced by yolk sac called HB Portland. Remember, Gower and Portland hemoglobins are by yolk sac. Liver produces HbF, extramedullary erythropoiesis, HbF. Bone marrow, medullary erythropoiesis, adult hemoglobin, HbA. Yeah, alpha beta chain, adult hemoglobin. Yeah, yes, most predominant hemoglobin is HbF. It is roughly 75% at birth. So this is the most predominant hemoglobin in fetus. That's why the name HbF, fetal hemoglobin. Yeah. Now, important points about this hemoglobin and blood. Fetal RBCs are large in size, very large. They have short lifespan. I know these are theoretical things, yes, but these are important things. Then we will jump onto the clinical aspects for sure. First you write down these small theoretical things. Short lifespan of 90 days. Fetal RBCs have high reticulocyte count. Yeah, I said RBCs are large, lifespan is small, less, and the reticulocyte count is high. High hemoglobin. Yeah, roughly 18 to 20 gram percentage is seen. High hemoglobin levels are seen. Then high oxygen affinity. High oxygen affinity. You remember oxygen affinity in our biochemistry days, we used to hear that oxygen affinity is inversely proportional to something called a 2,3-DPG, diphosphoglycerate. So there would be low 2,3-diphosphoglycerate. DPG levels are low in fetus. Diphosphoglycerate. So guys, fetal RBCs large, lifespan 90 days, reticulocyte count is high, hemoglobin is high, oxygen affinity is high, 2,3-DPG is low. These fetal RBCs, if you remember yesterday I had told you that alkali resistance is there. So these are alkali and acid resistant RBCs. Based on alkali resistant test principle, there is a test called APT test. Fetal RBCs do not undergo hemolysis on adding alkali. Then these are acid resistant also. You will hear this test called as Klehor test. We will talk about this in Rh negative pregnancy. Klehor Betke test. We will talk about it for sure, I promise. Alkali test principle is there in app test principle. Fetal RBCs are alkali resistant. Klehor Betke test, acid resistant. Fetal RBCs are acid resistant cells. Okay. Yeah, we will talk about those things for sure. Right now we are talking about fetal hematology, and you have written these 7 strong important points about hematology in fetus. Then after fetal hematology, let me just show you one graph just to complete what we talked about. Yeah. So this is a graph. As you can see in this graph, there is yolk sac producing RBCs, and then liver, and then finally bone marrow. Give me 1 second. Yeah. So this is what I was talking about hematopoiesis, yolk sac, liver, and then bone marrow. Remember, yolk sac is predominant site in early first trimester. The change in erythropoiesis happens at 6 to 10 weeks. Yeah. So liver becomes predominant. You write down this line. Liver becomes predominant source after 6 to 10 weeks. Yeah. And bone marrow becomes predominant source in third trimester. Yeah. Bone marrow becomes predominant source in third trimester. Alright. Yeah. So my dear friends, we have covered hematology part. Then after hematology, there are few one-liners which you need to remember. Yeah. So hematology is over. Then urinary system in fetus. This is all about fetus. Okay. Urinary system in fetus. Fetal urine production. Fetal urine production. Nowadays we say it is 9 to 11 weeks. Earlier the answer was 12 weeks. 12 weeks is the old answer. Fetal urine production is as early as. Yeah. Fetal urine production is as early as 9 to 11 weeks. Earlier the answer was 12 weeks. As early as 12 weeks. Now we say 9 weeks. Then after urine production, total volume produced, total volume of urine produced is 650 ml to 1 liter per day. Then kidney maturity is said to have happened when there is 260 milliosmoles. Osmolarity of urine is 260 milliosmoles per liter. So whenever amniotic fluid osmolarity is 260, we say kidneys have become mature. This is about urinary system. Then respiratory system. In respiratory system, there are few important points like breathing. Does the baby breathe inside? Yes, it does. Breathing is chest wall movement. Breathing is chest wall movement. This happens from 11 weeks. I have written few things about the urinary system and respiratory system. Yeah, guys, I hope you all are yes, all fine. Yes, okay. I have written about urinary system and I have written about respiratory system. Breathing begins from 11 weeks. Then surfactant production begins in type 2 pneumocytes. Type 2 pneumocytes. We call them as Clara cells. From 20 to 24 weeks, but the right answer is 20. Yeah. Remember, surfactant production begins from Clara cells, type 2 pneumocytes from 20 weeks. Surfactant is seen in amniotic fluid from 28 weeks. Yeah, surfactant is seen from 28 weeks. Yeah, urine production, now the answer is 9 to 11 weeks. Earliest production 9 weeks you should pick up. Yeah, surfactant production is seen from 28 weeks. Okay. Then surfactant is from 20 weeks and it is seen in amniotic fluid from 28 weeks. Then surfactant production is increased by steroids and decreased by insulin. Surfactant, surface active agent, is responsible for decreasing surface tension. That's the name, surface active agent, surfactant. It is increased by steroids and yes, it is decreased by insulin. Every week of gestation is from last menstrual period. Mark my words. We count pregnancy from last menstrual period. Breathing is chest wall movement. It is not respiration. Respiration is exchange of gases which happens in placenta. You have written in your notes. O2, CO2, simple diffusion in placenta. That's respiration. Breathing is chest wall movement. And yes, breathing happens from 11 weeks. You know, breathing invites amniotic fluid and I told you that lung formation is dependent on amniotic fluid. Okay. Kidney maturity is when the osmolarity reaches 260 milliosmoles per liter. Okay. Alright, I hope the questions are answered. Now, after you have written about surfactant, then let's talk about another system called as GI system. Swallowing begins from 10 to 12 weeks. Underline 10. Swallowing 10 to 12 weeks. Then meconium formation. Meconium formation is from liver from 16 weeks. Yeah? Meconium is formed from liver from 16 weeks. Meconium is nothing but bile, bile salt, bile pigments. It's green in color. Yeah? Then about endocrinal system. Endocrinal system, you write down glucagon is seen in fetus from 8 weeks. Yeah? Glucagon is seen in fetus from 8 weeks. Insulin is seen in, now there are two questions over here. Insulin is seen in fetal serum 12 weeks. I repeat, insulin is seen in fetal serum 12 weeks. In pancreatic cells 9 to 11 weeks. 9 is the right answer. Yeah. So two questions about insulin. Yes, this is given in Williams obstetrics. Insulin is seen in pancreas, pancreatic cells from 9 to 11 weeks. Yeah. And yes, in fetal serum it will be 12 weeks. Okay. After endocrinal, then let's talk about cardiovascular. Cardiovascular. Now, for cardiovascular system, the topic is fetal circulation. I want you people to have a look at one slide, try to understand the slide, and then I will dictate things. Because this slide requires a complete understanding of the topic, and then we will write down things. Okay, give me 1 second. I think that slide is deleted out. Okay, I can't see that slide right now, and that slide is important. I will try to bring it after the lunch break. Right now I want you people, I will request you people to leave one page over there about fetal circulation. We will talk about it for sure, and let us talk about the next topic. I want you people to leave fetal circulation topic. Let's talk about another topic called as maternal physiology. So fetal circulation topic is pending. We will cover that for sure. Yeah, fetal circulation topic is pending. We will talk about it. Now let's talk about the topic called as maternal physiological changes. Now we will talk about maternal physiological changes, guys. So yes, in order to avoid this haphazard situation, I'll just jump onto the topic called maternal physiological changes. So please start writing down about maternal physiology and medical disorders. Yeah. Maternal physiology and medical disorder. In this topic, we are going to talk about what is normal in pregnancy and what is considered as abnormal in pregnancy. So everything will be covered about normal and abnormal. We always see these patients in our antenatal ward. Yeah. We see patients of anemia in pregnancy. We see patients of heart disease in pregnancy. We see patients of diabetes, and then hypertension, then sometimes vomiting. All these things would be covered over here. We will go systematically. So physiologically, there is weight gain in pregnancy. Normal weight gain is roughly 11 to 12.5 kg. This is normal weight gain. Even WHO writes it as 12 kg weight gain as normal weight gain in pregnancy. 2 kg plus 5 kg plus 5 kg. First trimester, second trimester, third trimester. Normal weight gain in pregnancy. Yeah. Now, if patient is thin, she is having BMI of less than 19, then the normal weight gain for her should be 16 to 18 kg. Her normal weight gain should be 16 to 18 kg in order to bring out normal pregnancy outcome. She should gain more. If patient is obese, yeah, if patient is obese, then her normal weight gain is 6 to 8 kg. This is for obese patient. Yeah. So for thin patients, BMI less than 19, you pick up 16 to 18 kg. For obese patients, 6 to 8 kg. For other patients, you pick up 12 kg as answer. Okay. Yeah. Then, calorie requirement in whole pregnancy is roughly 80,000 capital C calories, means kilocalories. 80,000 C capital calories. Yeah. So we are supposed to give this additionally on top of what is daily normal for a non-pregnant patient. So we are supposed to give additional calories per day. Additional calorie requirement per day, the answer would be 350 C capital calories. Additional calories per day. Now, remember this thing, this is not uniform throughout pregnancy. First trimester has different figure, second trimester has different figure, and third trimester has different figure. So remember this thing, for first trimester, no additional calories are needed. Yeah, that's the right answer. No additional calories for first trimester. Okay. So guys, I have yes, it is given in PSM also. Yes, we have talked about weight gain physiology. Weight gain is there, 12 kg, 2 plus 5 plus 5, calorie requirement 80,000, and yes, 350 calories per day is the additional calorie requirement per day as an over average additional for the daily additional in pregnancy. Yeah, got it? Remember, for first trimester, no additional calories to be given. Guys, 0 would be the answer for first trimester. Then this 12 kg weight gain is subdivided into parts, like 6.5 kg is water, 3.5 kg would be fats. Yeah, calorie C capital is kilocalorie. It is written as capital C-A-L, cal. Okay, na? Yeah, K-cal. Alright, 6.5 kg is water, 3.5 kg fats, 1 kg of proteins, 1 kg others. This is the division, subdivision of 12 kg. Okay. Now water is not retained alone. Water is retained along with sodium and potassium. Sodium retention is 1000 milliequivalents and potassium retention is 300 milliequivalents. Yeah, capital C means kcal. Yes. Okay, this water retention and sodium potassium electrolyte retention is due to estrogen. Estrogen is known to cause water retention. Yeah, you must have heard in gynecology, estrogen causes water retention. Fats are deposited due to hyperinsulinemia in pregnancy. So naturally, normally pregnancy has more insulin levels. Okay. Numbers are very simple. You just have to revise these figures. 6.5 plus 3.5 becomes 10. 1 plus 1, 12. This is total 12 kg for weight gain in pregnancy. Yeah. Fat deposition is 3.5 kg. Proteins are deposited due to anabolism in pregnancy. Okay. But that's it. Figures are over. These are the figures which you have to remember. Okay. Yeah. Alright, guys. So after you have written these facts about the weight gain physiology, let's talk about the physiology called breast changes. What are the changes happening in breasts? There would be weight gain of roughly 300 to 400 gram. Hyperpigmentation, okay. Colostrum is seen from 12 weeks. Yeah. Colostrum is seen from 12 weeks. Pregnancy has estrogen also. Pregnancy has progesterone also. It's not only progesterone. Okay. All right. Okay. So I will now write the things about other physiological changes. Yes, I was talking about breast changes, changes in breast, hyperpigmentation, colostrum. Now, breasts will have 4 important physiological changes called mammogenesis, lactogenesis, galactokinesis, and galactopoiesis. Mammogenesis, lactogenesis, galactokinesis, galactopoiesis. What are the meanings? Mammogenesis would mean breast development. Lactogenesis would mean milk development. Galactokinesis would mean milk ejection. And galactopoiesis would mean continuous milk formation. Yeah? Breast development, milk ejection, and continuous milk formation. Now, breast development would have fatty tissue, duct development, and alveolar tissue. Fat is because of insulin, duct is because of estrogen, alveolar would be because of progesterone, estrogen, and prolactin. Yeah? These are the hormones responsible for breast development. HPL is also there for all. Human, placental, lactogen is there for human, placental, lactogen is there for overall mammogenesis. Yeah? Lactogenesis, milk development. When will milk get developed? It requires withdrawal of estrogen and progesterone. Once estrogen and progesterone levels go down, there will be milk formation. Yeah? So once baby is delivered out, milk will be formed. Okay? Lactogenesis. Galactokinesis would be milk ejection, and the only hormone responsible is oxytocin. Okay? Oxytocin. And galactopoiesis, continuous milk formation, requires 2 things: prolactin and sucking. Baby will suck the milk and that would give a galactopoietic signal and there will be more milk formation. Yeah? So the agents responsible for continuous milk formation would be called as galactogogues. Yeah? Galactogogues. Alright, so you have written about the 4 parts of breast physiology. You have written about breast development, that's mammogenesis, milk development, that's lactogenesis, milk ejection, that's galactokinesis, and continuous milk formation, galactopoiesis. Now, clinical cases. If patient has decreased milk formation, what should be the treatment? Decreased milk formation, the answer would be anti-dopaminergic. Like metoclopramide. You know, perinom injection, metoclopramide, will increase the milk output. Yeah? All good? Guys? Okay, I'll go slow for sure. Patient has decreased milk output, you give metoclopramide injection. Patient has breast engorgement. So milk is not coming out. Milk is formed, but it is not coming out. So what should be given? The answer is, they are mechanical breast pumps. Or drug of choice, oxytocin. Yeah, mechanical breast pumps, drug of choice, oxytocin. Alright, guys, girls, so you have written about patient who has decreased milk formation, patient who has breast engorgement, a patient who wants to stop lactation. Patient who wants to stop lactation for any reason, let's say fetal demise, or patient does not want to breastfeed the baby because of some personal reason, or she is HIV positive, and in India HIV positive is not an indication, not a contraindication of breastfeeding, but if she decides not to breastfeed, then she has full legal right to. But then understand, if she wants to stop lactation, then we give dopaminergics. Yeah. Colostrum is formed in the cells of the breasts as early as 12 weeks. It is not coming out. It doesn't come out. Yeah. It will be there in the cells of the breasts. Yeah. It will not come out. No. So dopaminergics will be given if patient wants to stop lactation. So there is a drug of choice, cabergoline. We can give bromocriptine. These are the drugs which will be given to stop the milk formation. Pyridoxine, which is vitamin B6. Yeah. Guys, so cabergoline, bromocriptine, pyridoxine are lactation inhibitory drugs because these will have dopaminergic action, and pyridoxine per se becomes dopa in brain. So that is why dopaminergic drug, pyridoxine, is not a dopaminergic drug, but it becomes dopa in brain, so it helps in stopping lactation. Even high dose estrogen, which is not given nowadays, but you should know high dose estrogen is also used for stopping the milk formation. Alright? Okay. So my dear friends, we have talked about some clinical cases related to breast physiology. Now after talking about breast physiology, let's talk about signs of pregnancy. Signs of pregnancy. What are the signs of pregnancy? First, remember the name. It's called Jacquemus sign. Also called as Chadwick sign. Technically they are one and the same, but there is a little difference. I will talk about it. Jacquemus sign, Chadwick sign is bluish discoloration of vagina and vestibule. Yeah, bluish discoloration of vagina and vestibule. Okay, I'll put a word respectively. Yeah, I hope everything is fine. Okay, hanging. Are you able to hear me? Okay. Give me 1 second. Pregnancy. First, remember the name. It's called Jacquemin sign. All that sign. There's a little difference. I'll talk about it. Jacquemin sign, Chadwick sign is bluish discoloration. All right. I'll repeat from signs of pregnancy because it was hanging. It was not getting conveyed to you. So Jacquemin or Chadwick sign is bluish discoloration of vagina and vestibule respectively. Jacquemin for vagina, Chadwick vestibule. Okay, it is due to venous congestion. It is from 8th week. Okay. Again hanging. Give me 1 second. Okay, let me refresh. I'll repeat some signs of pregnancy because it was hanging. It was not getting conveyed to you. So Jacquemin or Chadwick sign is bluish discoloration of vagina and vestibule respectively. Okay, am I audible to you? Are you able to hear, guys? All good? Yeah. So we were talking about signs of pregnancy written as Jacquemin or Chadwick sign, venous congestion from 8th week. Then there is a sign called Goodell's sign. Goodell's sign is softening of cervix. This is due to water retention. This is due to water retention. Goodell's sign. It is from 6th week. It is from 6th week. Third is a sign called Osiander sign. What is Osiander sign? See, when a patient comes to us in early pregnancy, these are the signs seen in early pregnancy. On speculum examination, you see Jacquemin or Chadwick sign. On PV examination, you see Goodell's sign. When you do bimanual examination, when you put both hands inside, one hand inside and one hand in the abdomen, then you will do bimanual examination. And in bimanual examination, you will find lateral fornicial pulsations. That is Osiander sign. Lateral fornicial pulsations. This is due to dilated uterine arteries. Yeah, dilated uterine arteries, distended uterine arteries, increased blood flow will lead to Osiander sign. Yeah, again, 8th week, Osiander sign. Okay, then there is a sign called as, then there is a sign called as Piscaseck sign. What is Piscaseck sign? Again, this is bimanual examination. Bimanual examination. Put one hand inside, one hand on the abdomen. You do examination and you will find what? Sometimes there is implantation on the lateral wall of the uterus, which is generally not the case. Most common site of implantation is posterior wall, near fundus. But if implantation happens on the lateral wall, then what will happen is uterus will grow only on one side. So uterus will become asymmetric. So asymmetric enlargement of uterus due to lateral implantation. Yeah, asymmetric enlargement of uterus due to lateral implantation. This will be seen between 6 to 10 weeks. Pisca-Seck sign. 6 to 10 weeks. Then there is a sign similar to Pisca-Seck sign. It is called a Hagar sign. Guys, Hagar sign, again bimanual examination. When you do bimanual examination and in early part of pregnancy, 6 to 10 weeks, uterus is occupied only in the upper part, lower part is empty, and that is Hagar sign. Empty lower part of uterus plus softening of isthmus. Yeah, that is Hagar sign. Softening of isthmus is there. On bimanual examination, you will be able to bring your fingers close to each other. Your abdominal and vaginal fingers would be, approximated because there is softening of isthmus. Okay, I will show you one sign over here. Okay, look at this. Somebody has done bimanual examination, and see, this is the part called isthmus. Yeah, and that part isthmus is soft. That is why your fingers can come close to each other in this part. This is typical Hagar sign picture. Yeah. If it was single hand examination, then it was PV examination, and PV examination, Goodell sign, softening of cervix. Remember, softening of cervix, Goodell sign. Softening of isthmus is Hagar sign. Hagar sign 6 to 10 weeks, and Goodell sign from 6 weeks throughout pregnancy. Yeah. All right. So guys, hopefully you have understood the signs of pregnancy. Okay, this sign, as I told you, is bluish discoloration. Here you are seeing cervix and vagina. Both have become, there is a bluish tinge to them. This would be Jaquemer-Chadwick sign. Chadwick is basically for vestibule, but basically they are all bluish discolorations because of venous congestions. Okay. All right. So you have written signs of pregnancy now. There is one more sign of pregnancy which I have to finish, and that sign is called Palmer's sign. Palmer's sign means regular, rhythmic uterine contractions felt on bimanual examination. Yeah, regular rhythmic uterine contractions felt on bimanual examination. That's Palmer's sign. 4 to 8 weeks would be the time of Palmer's sign. Some books are written 6 to 8. So 4 to 8 is a better answer. It's a correct answer for Palmer's sign. 4 to 8 weeks. Alright. These are the signs of pregnancy. Okay, after signs of pregnancy, there are few changes happening in the skin of pregnant patient. One, there is cloasma gravidorum. Cloasma gravidorum is also called pregnancy mask. It is due to melanocyte stimulating hormone caused by increased estrogen. Yeah, Cloasma gravidorum, pregnancy mask. This is hyperpigmented facial patch. Okay, hyperpigmented facial patch, Cloasma gravidorum. Then there is Linea nigra. Again, hyperpigmented, but this time hyperpigmented midline over abdomen. Guys, these are the things which you see on inspection of per abdominal finding. Yeah, on inspection you see linea nigra, Cloasma gravidorum. You also see on inspection something called as stria gravidorum. Stria gravidorum. Stretch marks of pregnancy. These are pink colored. Pink is coming as orange. Okay, let it be. Pink colored stretch marks of present pregnancy. Pink colored stretch marks of present pregnancy, stria gravidorum. Then stria albicans. Albican is coming as green, but it is white in color. These are white colored stretch marks of past pregnancy. Yeah, stria gravidorum, pink colored present pregnancy, stria albicans, white colored past pregnancy. Then there are vascular spiders seen in pregnancy. Vascular spiders. These are dilated capillaries. Vascular spiders are dilated capillaries due to estrogen. Yeah, estrogen is responsible for capillary dilatation. Yeah, these are also called spider angiomas. Okay, vascular spider angiomas. Then there is Palmer erythema. Same reason, Palmer erythema. Lastly, raised body temperature. The skin temperature is increased, core temperature is slightly increased because of progesterone. Progesterone is thermogenic hormone. Yeah, progesterone is thermogenic hormone. Alright, so guys, you have written signs of pregnancy and you have also written the changes in skin during pregnancy. Now let's talk about hematological system. Hemat system, and here we will talk about anemia and pregnancy as well. See, pregnancy, as I told you, 6.5 liters, 6.5 kg of water is retained in pregnancy. So where is it going? It is going in plasma. So plasma volume expands, volume increases by 40 to 50%. Water retention is there, so plasma volume will increase. RBCs will also increase. RBCs would increase. Yeah, but the percentage would be lesser than plasma, 20%. So plasma is increasing, RBCs are increasing. If you add these two lines, you get hemodilution in pregnancy. Yeah, hemodilution in pregnancy. Now, hemodilution is good or bad? Hemodilution is good actually. It increases placental perfusion. Yeah, it increases placental perfusion. Yeah. Secondly, hemodilution decreases blood viscosity. So what happens to blood viscosity in pregnancy? It decreases. Hemodilution happens. And once baby is delivered out, that hemodiluted blood will be lost in labor and delivery. Yeah. So hemodilution is good. What happens to RBC concentration? See, total RBCs are increased, but RBC concentration falls. Yeah. Similarly, hemoglobin concentration falls. So hematocrit levels will fall. Yeah. Because hemoglobin concentration falls, oxygen carrying capacity falls. Yes, you heard it right. Oxygen carrying capacity decreases because it is dependent on hemoglobin concentration. Hemoglobin concentration falls in pregnancy. Then WBC count increases in pregnancy. Yeah. So there is leukocytosis. Yeah. Normally up to 11,000 is seen in non-pregnant. But in pregnant patients, 15,000 is seen in ANC. 25 to 30,000 is seen in labor. You need not worry, this is normal. This is not related with infection. This is physiological leukocytosis, and this is because of neutrophilia. Neutrophil count increases. Yeah. There is eosinopenia. Yeah. Neutrophilia, eosinopenia, absolute lymphopenia. Okay, just because neutrophil count has increased, there is neutrophil count increment, there is neutrophilia, there is eosinopenia and absolute lymphopenia. Alright, so this is about WBC count. RBC lifespan is slightly decreased to 110 days. Erythropoietin, you need more RBCs, so erythropoietin is going to increase by 50%. Don't worry about figures, just remember what is increased, what is decreased. Yeah, all are physiologically increased except, so you should write eosinophil count. Eosinophil count is decreased. Yeah, all are increased, all are decreased, these things are asked. So yes, you should know what happens to the counts and what is normal and what is abnormal clinically also. Yeah, imagine a patient who is in labor and her report labor WBC count has come and it has come out as 25,000. You will unnecessarily give her antibiotics when it is not needed. Understand, it's not a sign of infection. It is physiological. It is normal. Nothing to worry about. Yeah. So yes, erythropoietin count, erythropoietin levels would increase. Then platelet count decreases to low normal values. Yeah. So average platelet count will definitely fall. Average platelet count falls in pregnancy, but the levels are still in the normal zone. Yeah. Guys, girls, then all clotting factors are increased in pregnancy. Pregnancy is a procoagulant condition. Yeah, all clotting factors are increased in pregnancy except factor 11 and 13. Okay, all clotting factors increase except factor 11 and 13. So why pregnancy is procoagulant? What is the advantage? Advantage is that it reduces the amount of blood loss after delivery. But remember, most important reason why PPH is prevented is living ligature and uterine musculature. Most important reason of PPH prevention? This is natural defense. The answer is living ligature. Yeah? Figure of 8 muscle fibers or middle crisscross fibers of uterine musculature. Yeah, myometrium has living ligature fibers, middle crisscross fibers. That's the most important reason of PPH prevention. Alright, guys. So hopefully you have written about clotting factors. You have written about hematological changes. Then after hematological changes, let us talk about the pathology of this system called anemia in pregnancy. Anemia in pregnancy. As per the definition, less than 11 gram% is anemia. WHO definition also, Indian definition also, less than 11 is anemia. Yeah, we have, we must have heard in PSM, the P Plus initiative. Yeah, Anemia Mukt Bharat. So yes, we follow 11 gram as normal and less than 11 as anemia in pregnancy. Mild anemia, moderate anemia and severe anemia. Mild, moderate, severe. Mild, moderate anemia. Mild would be 10 to 10.9. Okay. Moderate would be, yes, platelets are reduced. There is excessive platelet consumption. But remember, they are still in the normal range. They fall, average platelet count falls, but it is still in the normal range. Okay. So if you get a question, what happens to average platelet count? It falls. Is there thrombocytopenia in pregnancy? No. Yeah. Guys, girls, yes, there are things which are theoretical. So I have covered theoretical. Now I will talk about the clinical thing, anemia in pregnancy. So those who are thinking that yes, everything is theory. Yes, theory has to be strong for sure. If theory is strong, then your clinical cases will be solved very easily. Yeah. I am not running. I hope you people are able to write down properly. Guys. Okay. Fine. Okay, I'll do a revision of what I have written about the hematological system. Okay. I said plasma. What happens to plasma? Plasma is increased. Water retention is there. So plasma is increased. 40%. Don't remember the figure. Just remember what happens to plasma. RBCs are increased. Yeah. Because erythropoietin is increased. The demand is increased. Yes. RBCs are increased. There will be hemodilution because RBCs are increased lesser than plasma. Okay. Then RBC concentration falls because of hemodilution. Hemoglobin concentration falls. Oxygen carrying capacity falls. Why WBC count increases? See, understand, pregnancy requires more defense. And neutrophils are defensive cells. So there would be need of neutrophils. And yes, neutrophils will be very high in labor process. 25 to 30,000 is the leukocyte count. It is considered normal in labor. Yeah. So there is neutrophilia. Alright, guys. Okay, I hope I have slowed down and I hope you people have understood. Okay. Fine. Thank you. Okay. So, good people. I was talking about the neutrophil count. Yes, it increases. RBC lifespan decreases. Erythropoietin increases. Yeah, there is more demand of RBCs. So kidneys will produce more erythropoietin. Platelet count falls to low normal. All clotting factors are increased except factor 11 and 13. Factor 11 and 13, they are actually decreased in pregnancy. Okay, got it? So far so good. This is now clinical case, anemia in pregnancy. Believe me, out of 2 pregnant patients, 1 will be anemic. Incidence is 50%. Yeah, anemia is so common. Yeah, 50% clinical cases are anemics. Percentage was 66%. 2/3 patient population was anemic. Now it's 50%. Hey, we have reduced the population percentage of anemia. Mild is 10 to 10.9. Moderate is 7 to 9.9. Severe is less than 7 gram percent. Yeah, mild, moderate, severe. Very severe, less than 4. Okay, got it, guys, girls? Now, most common anemia. What do you think will be most common anemia? What is wrong with the pregnant patients in India? They are having iron deficiency. Yeah, pregnant females, non-pregnant females, iron deficiency is most common anemia in pregnancy. Iron deficiency anemia. Okay, IDA is most common anemia in pregnancy. Guys, remember this thing, that iron deficiency anemia, as you must have heard in patho also, it is microcytic hypochromic. Microcytic hypochromic, that means size is less, size of cells would be less, color of cells would be pale. Okay, there is anisocytosis, poikilocytosis, that means shape and size would be abnormal. Microcytic hypochromic anemia is iron deficiency anemia. Then MCV would be less than 75 femtoliter. MCHC would be less than 30%. Yeah, MCHC less than 30%. It is most sensitive RBC index. You know RBC indices, MCV, MCH, MCHC. Most sensitive RBC index would be MCHC. It is less than 30%. Okay, guys, after you have written MCV, MCHC, remember serum iron level would be low, less than 30 microgram per deciliter. Yeah, serum iron level would be low. Serum ferritin would be very low. TIBC would be very high. Okay, and serum ferritin is most sensitive marker of iron deficiency anemia. This was most sensitive RBC index. Serum ferritin is most sensitive marker of iron deficiency anemia. If you get a question, best investigation for IDA, you pick up serum ferritin. Okay, best investigation for IDA, serum ferritin levels. Okay, there is no iron deficiency anemia patient who has normal serum ferritin, as simple as that. You have to understand serum ferritin is best investigation for IDA. Then erythropoietin levels would be very high, because there is anemia, there is hypoxia to kidney, there will be more stimulus to produce erythropoietin. Erythropoietin levels should be high in pregnancy. Red cell distribution width would be increased. RDW is increased. Let me tell you investigations again. I said IDA, peripheral smear, microcytic, hypochromic. Size is less, color is pale. MCV less than 75 femtoliter. MCHC is most sensitive RBC index. Serum iron, serum ferritin will fall. TIBC and erythropoietin will rise. RDW, red cell distribution width, will also increase. Now then, what do we do in clinical scenario? How do we prevent anemia in pregnancy? So what is Indian government telling us? What guidelines are we following? Let's talk about those guidelines. So write down prevention of IDA in pregnancy. Now those who are thinking that figures are not important here, figures are slightly important. You should know the figures which I will be telling you. Prevention of IDA in pregnancy is by IFA pill. You must have heard in PSM also, no problem. You have to write down these things. IFA pill contains 60 milligram elemental iron. Yeah, 60 milligram elemental iron plus 500 microgram folic acid. Okay, 60 milligram elemental iron plus 500 microgram folic acid. This is present in one IFA pill. Yeah. So 1 pill per week. Yes, you heard it right. 1 pill per week is given in non-pregnant patients of reproductive age. Yeah. So yes, I am talking about prevention of IDA. 1 pill per week. Non-pregnant patients should take 1 IFA pill per week. Yeah. Now suppose if this patient comes to me and tells me, doctor, I want to become pregnant. Make me pregnant, doctor. Make me pregnant, doctor. I'll say, okay, no problem, I will. But then remember, I will have to change the modality of treatment over here. Okay, so she is planning pregnancy. So what is to be done? If patient is planning pregnancy, then stop IFA pill. Yeah, you don't have to give iron folic acid combination pill. You just have to give folic acid supplementation. Give folic acid pill. No iron, only folic acid. This figure would be 400 microgram daily. Yeah, guys, girls. So 400 microgram daily is to be given to a patient who is planning pregnancy. This is to be given to prevent neural tube defects. Yeah, this is to prevent neural tube defects. Guys and girls, so yes, we are giving this folic acid pill to a patient who is planning pregnancy. This is to be continued till the end of first trimester. This is to be continued till the end of first trimester. Yeah, guys and girls. Wife is gone. Sleeping. Guys, so yes, we are continuing folic acid till the end of first trimester. Then what? Concentrate. Focus. Then what? After folic acid pills in first trimester, then you have to restart. I know. Yeah. All good. All fine. Yeah. Thank you. Okay. Acha, people are writing weird things now. Great. I am so proud of you. Everyone has, ascaris in unmentionable area. Those who are writing weird things. Ascaris in unmentionable area. Even albendazole cannot treat you, guys. Even albendazole cannot treat you. Okay. Focus. I was talking about folic acid pill. And then what? After first trimester, after the end of first trimester, restart IFA pill. Restart IFA pill. 1 pill per week. 1 pill per day. After first trimester. Those who wrote what is T1, what is T2, what is T3? T1 is like first trimester, T2 is second trimester, T3 is third trimester. This is what we write in our clinical notes also. Okay. So yes, after first trimester, give 1 IFA pill per day. Alright. Yo, guys. This pill is to be given for 180 days. These are the new figures. You must have heard in PSM also. For 180 days during pregnancy and 180 days in postpartum period. Yeah, why not iron in first trimester? Good question. Iron is not given in first trimester because of emetogenesis. Patient is like and you're giving iron, she will have more. Yeah. So remember, iron is to be avoided in first trimester. It causes vomiting, emesis, and vomiting is very, there's lots and lots of vomiting in first trimester because of HCG, human chorionic gonadotropin. Okay. So don't give iron in first trimester, and safety profile is also not good with of iron in first trimester. We do not know whether it is totally safe. Iron pills are totally safe in first trimester or not. So yes, remember this thing, iron not in first trimester. Okay. Okay. Right. So guys, 180 days during pregnancy, 180 days postpartum. So that is all about how to prevent iron deficiency, anemia in pregnancy. Now question is, that folic acid thing, that was 400 microgram, 500 microgram. What if patient has history of neural tube defect in past pregnancy, or she has anticonvulsive therapy going on, anticonvulsant going on? If patient has history of neural tube defect in past pregnancy or anticonvulsant going on, you are supposed to give 4000 microgram per day. Yeah? 4000 microgram per day. And that has to be given at least for 3 months before pregnancy. Yeah. You people are typing so fast that before reading the question, the slide goes up. Yeah. So stop typing nonsense things. Yes, I know you are laughing over there. Oh, amazing. Don't type that you are laughing. Wow, you are laughing. Logon ko bataएं. Why are we laughing? Oh, please. Okay, guys, you are typing so fast. My God. Are you writing or typing or using your hand for something else? I want to know. Guys, I don't think you are writing. Please write down things. Yeah? Guys, stop typing. Stop typing nonsense. I will talk sense and I will talk about, yes, prevention of neural tube defect. If patient is already having neural tube defect in past pregnancy, the answer is 4000 microgram per day, at least for 3 months before attempting pregnancy. Okay? So this is the figure. Now, if patient has no such history, but she has folic acid deficiency, proven case of folic acid deficiency, then how much is the dose? Then the answer is 1000 microgram per day. Yeah? That is the treatment dose, therapeutic. Yeah? Guys, in non-pregnant patient, guys, question is for how many weeks in non-pregnant patient? Non-pregnant patient should take 1 per week. This is prevention guideline. I am talking about iron. What about folic acid? 400 microgram per day if she is planning pregnancy. Otherwise, one pill has 500 microgram folic acid and 60 milligram elemental iron. I talked about neural tube defect. The answer is 4000 microgram. And I talked about no neural tube defect, but she has folic acid deficiency. The answer is 1000 microgram. If patient has diabetes, come on, tell me. Diabetic patient, options: A, 400, B, 1000, C, 500, D, 4000. How much folic acid for prophylaxis, for prevention? Yes, anyone? Tell me the answer. Diabetic patient. She is diabetic, known diabetic patient. You want to prevent neural tube defect in her. How much folic acid you should give to her? Daily folic acid. Is it 400, 500, 1000, 4000? You have written so many figures. Guys, the right answer is surprisingly 400 microgram. Yeah, 400 for diabetics also. 400 for diabetics. When was it 4000? 4000 microgram was for patient with history of neural tube defect. She has one baby with spina bifida, or she had an encephalic baby in past pregnancy. The answer is 4000. Yeah. If she has no neural tube defect but she is a proven case of folic acid deficiency, the answer is 1000. If diabetic patient is there, the answer is still 400 microgram. Microgram. You write microgram. 400 microgram. Alright, guys, the answer is 400. Okay. Now you have written about folic acid. Now I want you people to write down treatment of iron deficiency anemia. Okay, to treatment of iron deficiency anemia. Now she is a proven case of iron deficiency anemia. Simple words, hemoglobin less than 11 gram percent, patient is IDA unless proved otherwise. So you are dealing with iron deficiency anemia patient. We get so many patients in our OPD with hemoglobin of 7, 8, 9, 10. You know, I hardly see patients of 12 hemoglobin. Pregnant patient, Indian pregnant patient, 12 is like, wow, amazing. Less than 11 is so common. Yeah, and we have to treat if it is less than 11. We have to prevent if it is 11 or more. Take it very simply. 11 is the cutoff. Less than 11 is anemia. Treatment is 2-IFA pill per day. 2-IFA pill per day. Am I clear about this? 2-IFA pills per day. Now, from what time till what time? No, when you diagnose iron deficiency anemia, she has crossed first trimester. Don't give iron in first trimester. She has crossed first trimester, you give 2 IFA pills per day instead of 1. Yeah. Now, when you will give this, hemoglobin starts rising. But only after 2 weeks of treatment. And at the rate of 0.7 gram percent per week. Okay, 0.7 gram percent per week. This is the rate of rise of hemoglobin. Your target hemoglobin is 11 gram percent. Make it 11. Come what may, make it 11. So you have to make it 11. What if target is achieved? Then what you will have to do? You have achieved the target, you make it 1 IFA pill. 1 IFA pill per day. As in all patients. How we prevent anemia? We have to continue prophylactic dose. We don't stop iron tablets in pregnant patient. Okay? So if it is achieved, 1 IFA pill per day. Reticulocyte count increases in 7 to 10 days. This is a marker of improvement. Reticulocyte count increases in 7 to 10 days. It's a marker of improvement. Okay. Clinically also patient will become better. She is able to tolerate work well. Earlier she was having fatigue and she was not able to do her daily routine activities. Now she is able to do that. Her hemoglobin has improved. General wellness is improved. Right? That happens after we start iron folic acid pills. Yeah. Most common side effect of IFA pills is GI upset. And we all know this. Yeah, nausea, vomiting, constipation are so common with iron pill. Yeah, most common side effect, GI upset. I hope you remember, nausea vomiting was your life-saving answer in your second MBBS. Yeah, you used to give nausea vomiting as answer for every side effect of every drug. Yeah, this drug side effect, nausea vomiting. Ondansetron side effect, nausea vomiting. Examiner will kill you for that. Yeah. So guys, remember, iron, yes, it's sure, nausea, vomiting and constipation would be there, and that's why many patients do not tolerate iron tablets. My question to you is, what if she doesn't tolerate oral iron? Then we will give injectable iron. So write down indications of injectable iron therapy, parenteral iron therapy. Indications of parenteral iron therapy. We don't give iron in first trimester, take it from me. Indications of parenteral iron therapy would be A, non-compliant patient. Yeah. B, intolerant patient. Non-compliant, intolerant. Non-compliant patient is that patient who is not taking pills. Intolerant is vomiting them out. Yeah. And then severe anemia. Severe anemia in early third trimester. Early third trimester is less than 34 weeks. Mark my words, severe anemia in early third trimester. Okay. Yes. So what is severe anemia? I told you less than 7 gram percent. So if she has 6 gram percent and she is 29 weeks, you give her parenteral iron therapy. Remember, hemoglobin increases at same rate with parenteral iron. Then what is the advantage? Compliance. You are giving injection. So the patient will take iron, she will get iron into her body for sure. Here compliance is assured. You are giving injection. Yeah, rate of rise is same. Absolutely same as oral iron therapy. Yeah. Guys, girls, hemoglobin increases at the same rate with injectable iron therapy. Most common injectable iron therapy is iron sucrose. I would say best injectable iron therapy has come out as ferric carboxymaltose. But it is so costly that it is not the most common. Okay, that's why iron sucrose is given in your hospital also. You see patients in antenatal ward admitted for anemia, daycare admission, they are given iron sucrose and sent home. Yeah, iron sucrose is most common iron given to these patients. Yeah. Now iron sucrose, 1 ml of iron sucrose has 20 milligram of iron. You remember this calculation? 1 ml, 20 milligram iron. Okay. So 100 ml of normal saline plus 100 milligram of iron. This combination is given to patient who is admitted for daycare. Yeah, that day admission and that day discharge. 100 ml of normal saline, 100 milligram of iron. Combination is given. Yeah, you have to give very slowly initially. Yeah, and then you have to gradually increase the speed. Yeah, so 20 drops per minute. Actually 10 to 20 drops per minute for 30 minutes. This is how we check for reaction. Yeah, hypersensitivity reaction in IV iron therapy. This iron sucrose is always IV iron. Yeah, ferric carboxymaltose is also IV iron. We have stopped giving injectable IM injections to pregnant patients and to all patients nowadays. We don't give IM injections. We give IV iron sucrose. Yeah. Guys, girls, this is like how we check for hypersensitivity reaction. Thankfully, iron sucrose does not give hypersensitivity reaction commonly. Okay, guys, how much iron should be given? How much is the total requirement? Total iron requirement in anemic patient would be calculated as 0.3 into weight in kilogram into hemoglobin deficit. Yeah, 0.3 into weight in kilogram into HB deficit in gram percent. Yeah, you have to add 500 milligram for iron stores. Guys, 0.3 weight in kilogram, HB deficit in gram percent. I'll give you one example. Let's say weight of patient is 50 kilogram and hemoglobin is 7 gram percent. Weight 7 gram, weight is 50 kilogram, hemoglobin is 7 gram percent. Your target, you know, target is 11 gram percent. Yeah, those who do not know what is NS, not anus. NS is normal saline. What has happened to you guys? Push, push, push. I know you people are hungry and tired, but push. Yeah, we'll take break soon for sure. But first you write down these things. Guys, I said iron calculation is 0.3 into weight in kg into HB deficit in gram percent. You have to add 500 milligram for iron stores. Yeah? Yes, you have to add 500 milligram for iron stores. Weight is 50 kg, hemoglobin 7, target 11. So deficit is 4 gram percent. So 0.3 into 50 into 4 plus 500. Yeah? Okay, 0.3 into 50 into 4 would come out as 460 plus 500, 960. Yeah, guys, girls, 460 plus 500, 960 milligram would be the dose. And yes, this would be the iron calculation. What are the indications of blood transfusion? When are you supposed to give blood to the patient? Remember, first is hemoglobin less than 5 gram percent in any trimester. May she be first trimester case, second trimester, third trimester. Hemoglobin less than 5 is an indication of blood transfusion. Number 2, severe anemia. Severe anemia when? Severe anemia in late third trimester. I told you severe anemia in early third trimester, you give injectable iron. Severe anemia in late third trimester, you give blood transfusion. So beyond 34 weeks, severe anemia, you should give blood transfusion. Yeah. Third would be refractory anemia. You are giving iron, but it is not getting cured. Something is wrong in your diagnosis. Refractory anemia, treatment is not possible, treatment is not successful, you give blood transfusion. Then anemia causing CCF. No, it's not 560. People are writing 560. 0.3 into okay, एक minute, one second. Guys, one small mistake. I agree to my mistake. It is not 0.3. let me make my mistake in red. It is 2.3. Sorry for that. 2.3. 2.3 into weight in kg into HB deficit. I am sorry, 2.3. 2.3. So 460. My mistake. 2.3 into weight in kg into HB deficit in gram percent. Yeah, it is 2.3. Please make it a change. It's not 0.3. It is 2.3. Okay, my mistake. All right. Yeah. Guys, girls. 2.3. 2.3. Yes. Yeah. Okay. So indications of blood transfusion: hemoglobin less than 5, severe anemia in late third trimester, refractory anemia, anemia causing CCF. Abhi aaya lal. Anemia causing CCF, congestive cardiac failure. Suppose the patient is anemic and she has developed congestive cardiac failure due to anemia. Don't look at the figure of anemia. Don't look at 7 is there or 6 is there. You just give blood transfusion. Yeah, I know. Fan is not there, so my mistake. All right. So yes, anemia causing CCF. Then hemorrhagic episode in a case of anemia affecting vitals. I said hemorrhagic episode in a case of anemia which is affecting vitals. Okay, you should give blood transfusion, and yes, one packed cell transfusion will increase the hemoglobin by 1 gram percent. 1 packed cell, 1 gram percent. Alright, guys and girls? I know, Ratta hai mujhe answer, because I give this example everywhere. So yeah, so you know that I had memorized that figure. I am sorry for that, guys. 2.3 was the thing. Maaf karna, my baap, kill me if you want. Okay, so guys, girls, so you have written about indications of blood transfusion. We have covered the topic called anemia in pregnancy. Let me give you some clinical cases. Primi gravida plus iron deficiency anemia of 8 gram percent plus 29 weeks of gestation. Come on, tell me. What is the correct treatment? A. Oral injectable or parenteral? Oral injectable or blood? Yeah, I will switch on the fan for sure. First, you read this question and tell me the right answer. You can type it out. I will switch on the fan for time being. Please allow me to do so because it's so hot over here. Yeah, Mumbai की गर्मी है. Okay, tell me. I said primi gravida, 8 gram percent, 29 weeks of gestation. What will be the right answer? What should I do? Oral injectable or blood transfusion? The answer would be oral iron therapy. Yeah, we have to give oral iron therapy. How much? 1 IFA pill per day or 2 IFA pills per day? The answer would be 2 IFA pills per day. Yeah. Then once you have given 2 IFA pills per day, when will you check hemoglobin? Hemoglobin is checked after 4 weeks. Yes, 4 weeks. You check hemoglobin. If you check after 2 weeks, believe me, hemoglobin will remain the same. Yeah. It will rise after 2 weeks at the rate of 0.7, 0.7, etc. Yeah. So understand, hemoglobin is checked after 4 weeks. If HB rises, but less than 1 gram %, it is called inadequate response. Yeah, this is a definition of inadequate response. Either she is not taking the pills or she is, not tolerating the pills. Inadequate response would be the thing called less than 1 gram % over here. Okay. If inadequate response is there, this is also indication of parenteral iron. Okay, parenteral iron therapy. Why not injectable iron? Injectable iron is obviously costlier. It is having risks as compared to oral iron. I mean, there was a question, why not injectable at the first place? Oral iron therapy is the best iron therapy, believe me. Oral iron therapy has treated many millions, and injectable is only reserved for 3 cases: non-compliant, intolerant, and severe anemia in early 3rd trimester. Okay, got it? Very clear. This case is the early 3rd trimester, 29 weeks. So I will give her oral iron therapy. Okay, next question. Primigravida, iron deficiency anemia, 6 gram %, 30 weeks of gestation. Primary iron deficiency anemia, 6 gram %. I have just changed 8 to 6. The answer changes to injectable iron therapy. This is what we will give. Okay. Iron deficiency anemia in early 3rd trimester, which is of severe type, then you will have to give injectable iron therapy. Again, another case. Primary gravida, iron deficiency anemia, hemoglobin 3 gram %, 12 weeks of gestation. You need to give blood transfusion. Why? Because any patient less than 5 gram % is a risk for congestive cardiac failure. She might have cardiac failure because of severe anemia. You should treat by blood transfusion. And I told you, 1 packed cell transfusion increases hemoglobin by 1 gram %. So make her stable. At least bring her above 5. Yeah. So you'll need to give her packed cell transfusion till the time her cardiac status is fine, or hemoglobin has come above 5. Yeah. Once she is more than 5, then our treatment modality, which is discussed already, which will be covered then. Yeah. Guys, so hopefully you understood when you should give oral, when you should give injectable, and when you should give blood transfusion therapy. Alright. Guys, this is all about anemia in pregnancy. Let us now talk about the next system. Next system after hematological system is cardiovascular system. Cardiovascular system. First we will talk about physiological changes, then we will talk about pathology. Guys, word of caution. Whichever things I will be writing in this topic called as physiological changes in CVS are only for pregnant patient. Mark my words, pregnant patient only. I am not talking about non-pregnant patient. Remember, obstetricians do not like MD medicine people. MD medicine people do not like obstetricians. We hate each other. That's a known fact. So whatever things I am going to write, please do not utter in non-pregnant patient. This is only for pregnant patient. Yeah? We hate them. They hate us. Equally. You see in your hospitals. Yeah? I pray that no obstetrician should marry MD medicine. Never. Bad combination. Those who are thinking medicine, don't think partner obstetrician. Yeah. It is like combination of angina and vagina together. Yeah. Dangerous combination. Yeah. Very dangerous. Our concepts are different. Their concepts are different. Our concepts are related to pregnant patient. Pregnancy has cardiovascular changes which are not seen in non-pregnant patients. Okay. Guys, our territory is below umbilicus. Their territory is above umbilicus. Yeah. We do not recognize patients by face. I hope you understood what I mean. If I go somewhere and if my patient meets me somewhere and asks me, doctor, do you recognize me? I would say no. I would have to see in whatever. Yeah. So understand this thing, that cardiovascular system changes which I will be dictating is only for pregnant patient, not for non-pregnant patient. Okay, guys, girls, cardiovascular changes. And I think you people need a 10-minute break because this is not a lunch break. Lunch break would be at 2:30, guys. So if you want 10-minute break, I can give you 10-minute break right now. Okay, do one thing. Take 10-minute break because everyone is demanding 10-minute break. I am giving 10-minute break and come back. Right now it is 12:37. Come back at 12:47. Alright, everyone, I am back. Yeah, those who are thinking when will be the lunch break? Lunch break would be at 2:30 because the time, because of that technical issue got in between. So 2:30, please bear with me. I will be taking a lunch break at 2:30. So I hope you don't mind. If you do mind, then I don't care. Sorry, guys, girls. So 2:30. So let's continue our session. We were talking about the cardiovascular system before we jumped onto the break. In cardiovascular system, we will talk about the physiological things first. Physiological things coming up your way. Yeah, physiological things. So what happens to the heart rate in pregnancy? Heart rate increases by 15 to 25%. Don't remember the figures, just remember what happens to heart rate. Heart rate increases. What happens to stroke volume? Stroke volume increases by 20 to 30%. Because plasma volume is increased, blood volume is increased, stroke volume will be increased. Okay? Yeah, so I was talking about heart rate, stroke volume. Then after heart rate and stroke volume, you multiply these two things, you will get cardiac output. Cardiac output is also increased 40 to 50%. It starts increasing from 5th week. Yeah, and it peaks in antenatal care, ANC. That means before labor. Peaks in antenatal care at 32 weeks. Roughly 28 to 32 is the time when it peaks. Then, if I write overall, when does it peak? It peaks in postpartum period. Immediate postpartum. Yeah? Guys, girls? So, hopefully you understood this. If you get a question, maximum cardiac output, the answer would be immediate postpartum. That is why we say highest risk of cardiac failure is when the patient is in immediate postpartum period. Then the second rank goes to second stage of labor. Then the third rank goes to 32 weeks, 28 to 32 weeks. Yeah? Immediate postpartum period is the most dangerous time for any patient who has high risk for cardiac failure. Yeah, like heart disease patient, like anemia patient, highest risk of cardiac failure. So you have written about heart rate, you have written about stroke volume, you have written about cardiac output. Yeah, so do you hear murmurs in a normal patient? No, we don't. Murmurs are not heard in normal patient, but there is normally heard soft systolic murmur in pregnant patient. It is up to grade 2. Up to grade 2 murmur is considered normal, nothing to be worried about. Diastolic murmur of any grade is pathological. That means there is some heart disease for sure giving rise to diastolic murmur. Yeah. So systolic murmur could be physiological, could be pathological, but diastolic murmurs are always pathological. Yeah. Then there is left axis deviation in ECG. See, when patient is pregnant, especially in third trimester, there will be pressure on the diaphragm and the heart would rotate. Heart would rotate on the left hand side outwards. So there is left axis deviation seen in ECG. Chest X-ray shows increased cardiac shadow. Chest X-ray, X-rays are contraindicated in pregnancy, but remember this line. Chest X-ray shows increased cardiac shadow. Yeah. Understand, this doesn't mean cardiomegaly. It is due to rotation. Okay. Guys, girls, after break I have talked about cardiovascular system. I talked about heart rate as the first point, stroke volume as the second point, cardiac output as the third point. Few facts about cardiac output I told you. When does it peak? When is it starting? When it is rising? That was covered. Then about murmurs, I covered murmurs. Then ECG showing left axis deviation and chest X-ray showing increased cardiac shadow. Yeah, these all things are considered normal. Okay, diastolic murmur is never normal. Okay, I'll slow down. Yes, please write down this up to this point. Yeah, give me 1 second. I'll drink water till the time. There are 6 grades of murmur, right from mild to harsh. Up to grade 2 is soft murmur. Grade 3 and more would be pathological. So grading is according to the severity. Okay. Yeah. So I was talking about chest X-ray, but remember this thing, cardiomegaly is always pathological. Okay, cardiomegaly can never be normal. Then, what happens to the blood pressure in pregnancy? Now, interesting thing about blood pressure, I told you already that vessels become dilated because of cytotrophoblastic invasion. So, peripheral vascular resistance decreases, peripheral vascular resistance falls, systemic vascular resistance falls. That's why blood pressure falls. Okay, it dips, blood pressure falls down right from first trimester. Yeah, blood pressure decreases from first trimester. Okay, got it? Alright guys, so you have written about blood pressure, but which blood pressure would fall more? Remember, diastolic blood pressure falls a lot because of peripheral vascular resistance, decrease in peripheral vascular resistance. Okay, BMW speed. I hope you are able to cope up. I hope you are able to write down things till this point. All good? Guys, take a deep breath. And what will you do? Push. Yeah. Please finish these points. I have written up to blood pressure, point up to blood pressure. Yeah, please finish up till this point called blood pressure. Diastolic blood pressure falls a lot. Systolic blood pressure falls mildly. Okay. Yeah. Systolic falls mildly, diastolic falls a lot. So what happens to systolic minus diastolic, which is called as pulse pressure? Pulse pressure. What should happen to pulse pressure? Pulse pressure increases. Pregnancy is hyperdynamic circulation. Hyperdynamic circulation. Okay. Okay. Yeah. After blood pressure, then central venous pressure. Central venous pressure remains constant. One of the very few things which would remain constant in pregnancy, central venous pressure. Yeah? Guys, systolic blood pressure falls slightly because understand that the systolic blood pressure depends upon peripheral vascular resistance and cardiac output also. Cardiac output, though it increases, but vessels are dilated, na? That's why systolic blood pressure doesn't fall a lot, because cardiac output compensates for the fall. So systolic blood pressure does not fall a lot, it falls slightly. Okay, that's why pulse pressure is increased, no? Okay, central venous pressure is constant. Lower limb venous pressure is increased. I told you in our previous discussion that uterus puts pressure on IVC. So lower limb venous pressure is increased. That's why I told you varicose veins, pedal edema, these all things are due to pressure effect. Central venous pressure constant, lower limb venous pressure increased. Okay, guys, remember, pedal edema is physiological, it is pitting in nature, pitting edema, it is painless edema, and it is relieved on rest and leg elevation. Yeah, this is related with venous pressure. So pedal edema is relieved on rest and leg elevation. Yeah. One more thing about the pressure effect is something called as supine hypotension syndrome. This is also due to pressure effect on IVC. Yeah. In normal patients, normal pregnancy, there are anastomoses formed between the veins of SVC and IVC in the abdominal area. Yeah, that is why pressure on IVC doesn't really trigger decreased cardiac output, because blood returns back somehow. But if the anastomosis between SVC IVC vessels do not happen in abdominal wall, then there is a possibility of supine hypotension syndrome. Try to understand this, that uterus puts pressure on IVC. Blood gets accumulated in lower limb. Blood does not flow back to heart. So heart will get less blood. So there will be hypotension. If there are anastomoses in abdominal wall area, the veins of IVC, veins from IVC and veins from SVC will have connections, and the pressures would be, the blood will go back and hypotension would not happen. So in those patients where anastomosis fail to develop, there will be supine hypotension syndrome. I am writing over here, due to failure of development of venous anastomosis. Yeah. So IVC blood remains in the lower part of the body. It doesn't flow back to heart when the patient is supine. So there is reduced preload. There is hypotension. So what should I do? What should I do? How should I treat this patient? Treatment is very simple. Left lateral position. Just have to give left lateral position. Nothing else. You will cure the supine hypotension at least for time being. And that is the treatment. Guys, I hope you are able to see what is going on, because again some network issue. Hopefully no. Yeah. Alright. Yes, everything is visible. Fine. Understood. Yeah. Guys, pedal edema is a property of third trimester, can be seen in second trimester sometimes because of hypoproteinemia. Pedal edema can also be due to protein reduction in blood. I'll talk about metabolic system, I'll talk about proteins. Proteins get reduced in blood. So one more reason of pedal edema is hypoproteinemia, which is not dependent on, the trimester. It can be there in any trimester. But pedal edema most commonly seen in third trimester, late pregnancy. Okay? Right. Supine hypotension syndrome, I told you left lateral position is the only treatment given. Okay? Got it? Very clear? Let us talk about heart diseases in pregnancy. Heart diseases in pregnancy. Most common heart disease in pregnancy is rheumatic heart disease, RHD. Yeah, most common heart disease, RHD. In RHD, mitral stenosis is the winner. Mitral stenosis is very common. Second rank is MR, which is very, very less. MS is very common. Yeah. Second most common heart disease would be congenital heart disease. Yeah. Second most common. After rheumatic, there will be congenital heart disease, and in congenital, most common congenital heart disease would be atrial septal defect, ASD. Most common congenital heart disease in pregnancy. My dear friends, I am talking only and only about a pregnant patient. This is not about the baby. This is about pregnant patient. Yeah, a pregnant patient suffering from atrial septal defect. That's a congenital heart disease in pregnancy. Yeah, guys, most common congenital valvular heart disease is mitral wall prolapse, MVP. Give me 1 second. Hello. मैं लेक्चर ले रहा हूँ, बाद में बोलता हूँ. नहीं, बाद में बोलता हूँ. बाय. Sorry. So yes, guys, I was talking about most common congenital valvular heart disease, and the answer was mitral wall prolapse. Then most common congenital cyanotic heart disease would be TOF, and most of the TOF would be, diagnosed, treated TOFs. Okay, so TOF is a congenital cyanotic heart disease, and it will be most common congenital cyanotic heart disease. Though it will be treated till the time patient has become pregnant, it will be already treated, cured, but then you remember this figure, this answer. Then, worst heart disease in pregnancy. Worst heart disease in pregnancy is Usmle syndrome. Yeah, Usmle syndrome is reversal of shunt. Medical topic, yes, must have been covered. Reversal of shunt is the worst heart disease to have in pregnancy. 50% mortality. Yeah, guys, girls. So I am talking about pregnant patient. I am not talking about baby. This chapter is dedicated to pregnant patient, not the baby. Yeah, rheumatic heart disease of mother, congenital heart disease of mother. Yeah, worst heart disease is Usmle syndrome. This is all about mother. This is all about pregnant female. Okay, guys, girls, I hope you have understood this. Worst heart disease, Usmle syndrome. Now, after you have written this about worst heart disease, now I want you people to write down few more facts about this heart disease topic. Guys, WHO has made a classification of heart disease as per the severity. So severe heart disease which should require termination of pregnancy are written as WHO category 4. Yeah, we will talk about WHO category 4s also. Right now you just write down about heart disease symptoms. What should be the symptoms? You must have heard in medicine for sure, but then there are symptoms which are present in normal pregnancy also. So guys, what symptoms do you think should be causing alarm in your mind if patient is pregnant and she has symptoms? See, dyspnea is there in pregnant patient also. Yeah, she will feel breathless, but that doesn't mean she has heart disease. So what I'm talking about are the symptoms which are alarming signs in pregnancy. Yeah, alarming symptoms in pregnancy, not signs, alarming symptoms in pregnancy which should warrant ruling out of heart disease. So what are these symptoms? Please write down symptoms requiring assessment of cardiovascular status. I am writing here serious diseases should be ruled out if patient has these symptoms. Yeah. Number 1, progressive dyspnea or orthopnea. Yeah, progressive dyspnea or orthopnea. Then cough only during night time. When she is lying down, then she is coughing, nocturnal cough. Then hemoptysis seen in pulmonary edema. Yeah, cardiac failure can lead to hemoptysis. Then syncope, okay, syncope as people pronounce. Then chest pain. These are symptoms which should warrant assessment of cardiovascular status. Yeah, there are certain non-specific symptoms like pedal edema, breathlessness on work, fatigue. All these things are seen in normal pregnancy also. Yeah, guys, so these are the symptoms which should warrant assessment of cardiovascular status. Guys, so please write down these 5 symptoms and then some clinical findings I will tell you. First you write down these 5 symptoms. Guys, all good? Yeah. Hopefully you have written these 5 symptoms. Okay. Then clinical findings. In clinical findings, see, if there is cyanosis, there has to be, you have to rule out heart disease. Clubbing, JVP dilatation. See, engorgement, jugular venous pressure. JVP is a marker of central venous pressure. Central venous pressure remains constant. If there is persistent neck vein dilatation, distension, then you should rule out cardiac failure. I told you systolic murmur of which grade? 3 or more. There are 6 grades of murmur. If 3 or more, then you should rule out heart disease. Diastolic murmur, cardiomegaly. I told you about the cardiomegaly and diastolic murmur. If there is persistent tachycardia, most common cause of tachycardia, by the way, is anemia. In pregnancy. Yeah. Persistent split S2. Yeah. Remember, S3 is normally heard in pregnancy. S3 is normal in pregnancy. No doubt about it. Fourth heart sound, that's abnormal. If you are able to hear on stethoscope fourth heart sound, you are dealing with cardiac failure. Yeah. And pulmonary hypertension. That's not normal. That's abnormal. Yeah. So these all things would suggest that patient has heart disease. Okay. You have written about symptoms. You have written about clinical findings. I'll show you one slide which are actually physiological things, which are actually seen in pregnant patients. Have a look at this. There is, I will write here, physiological. No problem. So guys, memory shuffle because of the flow in the memory artery. Yes. Jugular venous distension. Yes, it is normal. Jugular venous distension is considered normal, but persistent is abnormal. Yeah, so mark my words, persistent word is given, then it is abnormal. Otherwise it is normal. Okay. Yes. Then S3 is normal, I told you. Murmurs of systolic variety of grade 2 or grade 1. Yeah. S2 split is normal. S1 widely split is also normal. Yeah. But S2 persistently split is abnormal. Yeah. The word is persistent. Persistently split S2 is abnormal. Okay. Guys, so take it from me. S2 split is normal. Persistently split S2 is abnormal. S3 is normal. S4 is abnormal. Okay. Guys, so I have just now covered some dangerous symptoms which should be, markers that we have to rule out heart disease. Then some signs, clinical signs, and then I would like you people to write down conditions which are WHO category 4 heart diseases. Okay. I am writing here WHO category 4. WHO category 4 heart diseases. What do I mean by WHO category 4 heart diseases in pregnancy? Those diseases where pregnancy is contraindicated. Patient should not become pregnant. Yes, these are those indications which become indications of medical termination of pregnancy on medical grounds. Yeah. WHO category 4 heart diseases are coming up. Guys, so what are the conditions which are WHO category 4 heart diseases? A, severe left ventricular obstruction. severe left ventricular obstruction. Then B, pulmonary hypertension. C would be LVEF less than 30%. Left ventricular ejection fraction. LVEF less than 30%. Guys, you are supposed to terminate pregnancy if left ventricular ejection fraction is less than 30%. Then D would be Marfan syndrome. With aortic root dilatation. Marfan syndrome with aortic root dilatation of more than 4 centimeter. Okay, guys. Then E would be peripartum cardiomyopathy. History of peripartum cardiomyopathy with residual ventricular dysfunction. Yeah, I said peripartum cardiomyopathy. A patient who has peripartum cardiomyopathy. I'll cover this topic. But if she has residual ventricular dysfunction and she has become pregnant again, then you are supposed to terminate pregnancy. Tell her not to become pregnant. If she becomes pregnant, terminate pregnancy. This is for the sake of mother. We have to do MTP on medical grounds. Yeah, and yes, pulmonary hypertension, understand, it's seen in Usmle syndrome also. So I am writing Usmle syndrome also. That also becomes WHO category 4 because there is pulmonary hypertension. Reversal of shunt will happen only in the presence of pulmonary hypertension. Yeah, guys. So yes, these are the conditions where you are supposed to do termination of pregnancy. Guys, after you have written this, write down indications of cesarean section. Indications of cesarean section. Technically speaking, heart disease per se becomes, it's not an indication of cesarean section, guys. But there are some aortic wall involvement or aorta involvement conditions which are actually indication of cesarean section as per the updates, as per the new books. So I am writing aortic root dilatation of more than 4 centimeter. Marfan syndrome. Yes, the same thing which is for MTP will also be for cesarean section. Strange. How come, sir? Understand this thing. If patient has come to me in early pregnancy, then I would terminate pregnancy. Yeah. If patient has come to me near term, then I would, reach term and then do cesarean section. Yeah. So depending upon when she presents, the answer would be indication of cesarean section as same. Marfan syndrome with aortic root dilatation more than 4 centimeter. And if she comes in early pregnancy, then tell her to terminate pregnancy. MTP, abortion. Yeah. Second, aneurysm of aorta. Aneurysm of aorta. Then dissection of aorta. Okay. Dissection of aorta. Fourth is, guys, fourth is a condition which is not an indication for cesarean section only, it is also indication for MTP. That is class 3 class 4 NYHA. That means left ventricular ejection fraction less than 30%. Same thing which you have written in MTP. Same thing I am writing over here. What is NYHA? New York Heart Association classification. So class 3, class 4 NYHA patients should undergo cesarean section because normal delivery, attempting normal delivery may lead to high chance of cardiac failure. Class 3, class 4 NYHA, indication of cesarean section. Okay, guys, girls, one indication, patient on warfarin therapy. Patient on warfarin therapy in past 2 weeks. Plus she has gone in labor. This is not an absolute indication, it's a relative indication. Some people give antidote of warfarin and attempt vaginal delivery. So this is a relative indication. It's not an absolute indication. Okay. So these are some of the indications of cesarean section in a patient who already has heart disease. Okay. Guys, girls, after you have written these things, now I want you people to understand that there are conditions triggering CCF in these patients. Means heart disease patients. What are the conditions which can trigger CCF? She already has heart disease, which is a risk factor for CCF. Number 1, anemia. Number 2, beta agonist. Never ever give beta agonist to a heart disease patient. Number 3, ergot derivatives. Yeah. Number 3, ergot derivatives. You are not supposed to give ergometrin, methyl ergometrin in a heart disease patient. These drugs can trigger congestive cardiac failure because of vasospasm. Yeah. Then hypertension. Then hyperthyroidism. Infection and fever. See, all these things are, excess, are the conditions which cause excess load on the heart. Yeah, guys. So anemia, beta agonist, ergot derivatives, hypertension, hyperthyroidism. See, hyperthyroidism will cause tachycardia, infection fever will cause tachycardia, and yes, these all things would lead to cardiac failure in these patients. There are few more. Pain can cause tachycardia and then cardiac failure. Then smoking. Then caffeine, alcohol. Yeah. So addictions can lead to cardiac failure in a heart disease patient. So avoid the avoidables. And yes, we admit these patients. Oh. Alright guys, welcome back. It's not a lunch break. We still are online, and yes, we are continuing our topic. So with all patience and yes, with all the necessary push and power, we are going to continue our session. I think you are able to hear me now.
Welcome back. It's not a lunch break.
Yeah. Finally. Yeah, so I just now covered the conditions which can trigger CCF in heart disease patients. And you have written 9 points about 9 conditions about those dangerous things which can cause CCF in heart disease patients. We have to avoid the avoidables, and yes, we have to avoid the avoidables, and yes, we have to admit patients. Let's say gone. Hope everyone is able to see me. Okay, so guys and girls, Now I want you people to write down NYHA. Patience, patience, patience. Okay, NYHA classification you already have covered in medicine subject. There are 4 classes of patients. NYHA classification, class 1 means no symptoms at all. Patients are to be admitted at 36 weeks. No symptoms. She has heart disease, but she has no symptoms on accustomed activity. Fine, that's great. She should be admitted at 36 weeks for safe confinement. Yeah. Class 2 would be patient who has symptoms on accustomed activities. So she is telling you, doctor, I have dyspnea, doctor, I have palpitation on doing routine work. Yeah, she has dyspnea, symptoms like palpitation, chest pain on accustomed activities. You have to admit at 28 weeks. If she has symptoms on less than accustomed activities or symptoms at rest, guys, for class 3 and class 4 you are going to do immediate admission. Convince her for doing MTP if LVE, if left ventricular ejection fraction is less than 30%. If she doesn't allow, then she will be kept admitted in hospital till she delivers the baby. Immediate admission throughout pregnancy. Yeah, immediate admission throughout pregnancy. Guys, so class 1, no symptoms, 36 weeks. Class 2, symptoms on accustomed, 28 weeks. Class 3, class 4, symptoms on less than accustomed activities and symptoms at rest, immediate admission throughout pregnancy. Okay, we are admitting these patients to treat the CCF, congestive cardiac failure. Treatment of CCF is same as that in medicine. D. Diet, dilators, diuretics, digoxin. Yeah, so diet should be salt and fluid restricted. Dilators and diuretics for prevention and treatment of CCF. Digoxin is only for therapeutic purpose, only for treatment, not for prevention of cardiac failure. Okay? So very simple. Diet, dilators, diuretics, digoxin. Digoxin is only for treatment purpose, not for prevention purpose. Prevention purpose, dilators and diuretics are used for treatment also and prevention also. Okay? So D. Now, if patient has stenotic lesions, then the treatment is valvotomy. We all know this. As per medicine knowledge, stenotic lesions require valvotomy, regurgitants require replacement. Yeah? But best time is after delivery of surgery. Best time of surgery is after delivery. Yeah, if that is not an option, then second best time is second trimester, around 18 weeks would be the time when surgery is offered, surgery is done in these cases. Our best time is after delivery, no doubt about it. Yeah, remember, regurgitant lesions are better tolerated than stenotic lesions. Yeah, if you get a question, most common heart disease causing maternal mortality. Try to understand this, that they have asked most common heart disease causing maternal mortality. They have not asked about worst prognosis heart disease or heart disease which will lead to mortality in most cases. No. So they have asked most common heart disease causing maternal mortality. Since they have asked most common, they are talking about incidence, and nothing can beat mitral stenosis in incidence. So I'm writing in big words, mitral stenosis. Yeah, mitral stenosis per se, if it is mild, moderate, it doesn't lead to mortality in most of the cases. Yeah, but then since the number of mitral stenosis cases are so many, most common heart disease causing maternal mortality would be mitral stenosis. Am I clear about this non-controversial thing made controversy unnecessarily? Yeah, most common heart disease causing maternal mortality is mitral stenosis. Yeah, if you get heart disease with maximum risk of mortality, those will be class 4 NYHAs. Yeah, even Usmle syndrome is class 4 NYHA. Yeah, remember, Usmle syndrome is having maximum mortality. Yeah, so the two different things. Heart disease with maximum chance of mortality would be Usmle syndrome. Is it indication of MTP? Yes. But mark my words, it is not an indication of cesarean section. Yeah, it is indication of MTP. Abortion, yes, she is getting rid of pregnancy so that she can survive, yes. But she has already reached third trimester, she has reached term pregnancy, then we don't do cesarean just for the sake of Usmle syndrome. Yeah, guys, so remember, it's not an indication of cesarean section. Alright, guys, after this I want you people to write an associated part of this topic called as anticoagulation. Anticoagulation in pregnancy. Anticoagulation in pregnancy, indication, patient with history of valve replacement. Yeah, so there are different anticoagulation protocols, and I will tell you the most commonly used protocol. Number 1, heparin in first trimester. Heparin is safe in first trimester. It's a large molecule, it doesn't cross placenta. Warfarin does cross placenta, so warfarin is avoided in first trimester. Heparin is in first trimester. Then warfarin in T2, T3. But warfarin is a long-acting drug, so it should be stopped well before labor. So heparin from 36 weeks. So you have to switch over. You have to switch over at 36 weeks. You have to restart heparin. I don't want patient to have PPH due to warfarin. Yeah, avoid warfarin in first trimester. It has chance of warfarin toxicity, warfarin embryopathy. So first trimester, strict no. Warfarin in second and third trimester, switch over to heparin at 36 from 36 weeks. No anticoagulation in active labor. So once patient goes in active labor, don't give any anticoagulation. I don't want her to develop PPH. Restart heparin plus warfarin 6 hours after vaginal delivery. Yeah. So when she has delivered the baby, restart. For cesarean section, there is a little bit of controversy. For cesarean section, we practically restart heparin warfarin after 24 hours. But American College of Obstetricians and Gynecologists, they say 6 to 12 hours is sufficient time to restart. Remember this thing. If you are asked when to restart heparin and warfarin, I would request you to pick up 24 hours after cesarean section as the answer. For vaginal delivery, 6 hours. If they don't write anything, when to restart heparin and warfarin after delivery, 6 hours. Best answer, 6 hours. Okay? Most of the deliveries are vaginal deliveries. Unless you are in private hospital where all patients are undergoing cesarean section nowadays, which is really very bad. Guys, so take home message, take home mantra is that you are supposed to give heparin at the right time, warfarin at the right time. You don't have to give warfarin in first trimester, don't have to give warfarin in late pregnancy, and don't give anticoagulation in active labor. Okay, this is first protocol. This is one protocol. Second protocol, which is easy to remember, is continuous heparin, unfractionated heparin. Unfractionated heparin. This is continuous heparin throughout pregnancy. Yeah. Third protocol is continuous low molecular weight heparin throughout pregnancy. But believe me, best anticoagulant drug is actually warfarin. Yeah, but warfarin is very dangerous in first trimester and in late pregnancy. But those patients who are at a very high risk of developing clots in the artificial valve, high risk patients, they should take the risk of warfarin. Yeah, it's better to take a risk of warfarin with warfarin risk of fetus than no warfarin and risk of clots in mother. So remember, this is only for high risk patients. High risk for what? For only for high risk patients. High risk patients for what? For development of thromboembolism. These patients are given continuous warfarin. Explain the patient the risk of warfarin on fetus. Yeah, fetal warfarin toxicity, fetal warfarin syndrome can happen. Congenital anomalies can happen, but then it's better to take that risk than dying, obviously. So remember, most common protocol is combination of heparin warfarin at the right time. Yeah, other protocols may also be used, but then most common is heparin plus warfarin combination, the first one. Okay. Alright, I hope you have understood these things. Only for high risk patients we advise them warfarin. Guys, first protocol, match, okay. Those who are not able to write down this, please write down this. I will have water till that time. Yes, warfarin is teratogenic. Yeah. Warfarin is teratogenic. Okay. I told about anticoagulation in pregnancy. Yeah, this one. You want this one, right? Yeah. History of wall replacement surgery. And these are the protocols. This first protocol has to be remembered for sure. Questions were asked, will be asked from this first protocol. Okay. If you get a question, patient has wall replacement surgery done, which is anticoagulation of choice in first trimester, the answer is none other than heparin. Yeah. After first trimester, warfarin, no doubt about it. Okay. All good. 36 weeks. Yes, that's a time when you have to switch over to heparin again. You have to stop warfarin, start heparin from 36 weeks. Because you are approaching term gestation, she can go in labor anytime. Warfarin is a long-acting drug. Guys, so hopefully you are on track. I have written some protocols, and this first protocol has to be remembered by heart. Okay, got it? Unfractionated heparin. UFH is unfractionated heparin. LMWH is low molecular weight heparin. Yeah, continuous heparin therapy. Now, monitor. W and H. W, there is warfarin, it is to be monitored by PT, INR. Monitor warfarin by PT, INR. Monitor heparin by APTT. Yeah. Factor 10A levels are also to be checked in special cases, in some cases, not in all. Remember, for you, take home message, PT for warfarin, APTT for heparin. Prothrombin time is to be monitored for a patient on warfarin. APTT, activated partial tissue thromboplastin time, is to be monitored for heparin, unfractionated heparin. Yeah, APTT, unfractionated heparin. Now, interesting question is, what if patient is on warfarin and she goes in labor? So remember, warfarin plus labor. Indication of cesarean section. Warfarin plus labor. Indication of cesarean section. But then it's a relative indication. Can attempt vaginal delivery as well. Yeah, indication of cesarean section is there for sure, but can attempt vaginal delivery. Give vitamin K. That would be antidote of warfarin. Okay, guys, I said warfarin plus labor. Do cesarean section as a relative indication, but can attempt vaginal delivery. Give vitamin K. You have to reverse the action of warfarin. If there is warfarin plus PPH, then you have to give fresh frozen plasma. So add fresh frozen plasma in treatment. Add fresh frozen plasma in the treatment plan. Okay? Give me 1 second. You write down till this point. Hello? Yes? Yeah. I hope everyone is clear. Factor 10A. Give me 1 second. APTT. Hope you have written APTT for heparin and PT-INR for warfarin. Okay. PT is prothrombin time. International normalized ratio. Okay. Guys. Remember, you have to maintain the value as double the normal if you want to do anticoagulation in heart disease. Maintain the value 2 times normal. Okay, in pregnancy, maintain the values 2 times normal. Okay, got it? Warfarin plus labor, warfarin plus TPH. What if patient has heparin therapy going on and she has come in labor, active labor? Heparin plus labor, you just have to stop heparin. I am giving you clinical scenarios, guys. This is what you are going to do if patient is there in your labor ward and she has come in labor and she is on heparin therapy, you will do nothing. You just have to stop heparin. If she has heparin therapy going on and she has also developed PPH, then you will have to give or add protamine sulfate. Yeah? Warfarin plus labor, give vitamin K. Warfarin plus PPH, give FFP. Heparin plus labor, just stop heparin, nothing else. Heparin plus PPH, give protamine sulfate. Yeah, guys, so this is what is to be done in a patient who is already on anticoagulation therapy with these scenarios, clinical scenarios. Alright? Okay, now I want you people to write down labor management in heart disease patient. Labor management in a patient who has heart disease. 2 times normal means there is, guys, a question which is asked on app is 2 times normal. See, there is a ratio which has to be maintained as 2 times of INR. Okay, normal ratio. Okay, so to maintain the value as 2 times normal. Okay, fine. Labor management, come on. Number 1, if you have seen heart disease patients in labor, you will never forget that you will see these patients always having a recliner given to them. They are never lying supine. They are given recliner. Okay, so propped up position. Okay. Because they have orthopnea risk, they have breathlessness on lying down, so we will give them propped up position. We will give them O2 inhalation. Yeah, we have to stop warfarin in labor. Oh guys, those who have written warfarin plus labor, you have to give vitamin K. That doesn't mean you continue warfarin. You have to stop anticoagulation. I have already dictated to you, no anticoagulation in active labor. As simple as that. Yeah, got it? INR is to maintain twice the normal. Okay, fine, I will continue. Okay, so O2 inhalation 4 to 6 liters per minute. Fine. Third, fluid restriction. How much fluid is to be given? 75 ml per hour. This is the restriction. 75 ml per hour. Number 4, after fluid restriction, give them painless labor. Madam has done this topic called painless labor already. Epidural analgesia. Yeah, this has to be given. This is epidural is best for heart disease patients. Remember this thing. If pain is reduced, tachycardia would be reduced, adrenergic activity would be reduced, chance of CCF would be reduced. Yeah, painless labor is to be given to these patients. Number 5 would be you have to avoid ergot derivatives. Don't give ergot derivatives. Number 6, guys, understand this thing that there are some heart disease patients who require antibiotic therapy for prevention of infective endocarditis. Not in all patients. Infective endocarditis is to be prevented only in special cases which are high risk for infective endocarditis, like cyanotic heart disease. She is a case of cyanotic heart disease. She is in labor. You give antibiotic prophylaxis. Then wall replacement in past. Then rupture of membranes. It's an invitation to infection if there is premature rupture of membranes. We give antibiotic therapy. Yeah. And then pelvic infection. These are the patients who would require antibiotic therapy in labor. Okay, so you have to give antibiotic therapy in these patients. Can I give oxytocin? Yes, oxytocin is allowed, but in concentrated drip. Yeah, generally we give oxytocin 5 international unit in 500 ml of crystalloids. Here we give 5 international unit in 250 ml of crystalloids. You must be knowing, you must have heard in labor ward that patient is on 8 drops per minute, 16 drops per minute, 24 drops per minute. We have to gradually increase oxytocin drip. Yeah, so here the dose is concentrated. Instead of 500 ml, we give 250 ml. We give concentrated dose so that the fluid going inside would be less. Okay, then cut short second stage of labor. You have to cut short second stage of labor. How? Remember, forceps are better than vacuum. Guys, we have already covered, Madam has already covered instrumental delivery. I request you to cover instrumental delivery from the eMedicos app. Yes, forceps are better than vacuum. Why? Because if you have seen forceps, you must be knowing that when you apply forceps, you tell the patient not to push down. You pull the baby on your own. For vacuum, it's not the case. Vacuum applied, after that you tell the patient, madam, push, yeah, push, and after that baby comes out. That bearing down effort is to be prevented, and forceps do wonderful thing. Forceps do not require bearing down efforts for delivering the baby out. So remember, forceps are better than vacuum. In Indian book it is wrongly written as vacuum better than forceps, but rightly said forceps are better than vacuum. We apply forceps, and yes, forceps are better because they cause immediate delivery. Vacuum takes time. Okay, then don't forget, after you have conducted the delivery, you have to give injection furosemide 40 mg IV after delivery. This will reduce the chance of cardiac failure. I know you people know by now that highest risk of cardiac failure is in immediate postpartum period. So injection furosemide 40 mg IV will prevent congestive cardiac failure. Alright? Okay. So this is about the heart disease patient, and we have covered the topic called heart disease. Okay. After covering the topic called heart disease, let us now talk about the next topic called as metabolic system. All good, guys and girls? Hopefully everyone is able to. Yeah, forceps will be done, I guess. Yeah, don't worry. Yeah, instrumental delivery would be covered. In fact, instrumental delivery is already covered. It's there. Okay, we'll talk about it. Right now, let's talk about metabolic system. Metabolic system and metabolic system disorder. We will talk about diabetes in this topic. So metabolic system, first thing first, remember pregnancy is anabolic condition. Okay, 2:30 break. 2:30 is a break time, guys. 2:30 is a break time. Yeah, pregnancy is anabolic. Yeah, BMR, basic metabolic rate, is increased by 20% to 30%. Yeah, O2 consumption is also increased by 20 to 30%. Yeah, anabolic condition, BMR increased, O2 consumption increased. Then what happens? total proteins are increased. Total proteins are increased. Yeah. I hope you remember 1 kg protein retention is there in body. Yeah. So yes, total proteins are indeed increased in blood. But total protein concentration, total protein levels are increased in the whole body. Total protein concentration in blood, it is decreased. Why? Because of hemodilution effect. So concentration falls. I'll give you 2 arrows over here, non-pregnant, pregnant. Total protein concentration in blood 7 gram%. Your and mine is 7 gram%. And in pregnancy it is 6 gram%. Yeah. I don't know about those people who are pregnant and listening to the lecture. But yeah, pregnancy 6 gram%. Non-pregnant 7 gram%. Albumin 4.3. Globulin 2.7. Okay. Here albumin 3, globulin 3. Okay, so total protein concentration, as you can see, has fallen. There is hypoalbuminemia. Due to hemodilution, and hyperglobulinemia due to estrogen. Estrogens are known to increase globulins from liver. So hyperglobulinemia would be there. Yeah. I told you hypoalbuminemia is a reason for edema in pregnancy. That's physiological edema in pregnancy. Okay, guys, girls. So yes, pressure effect can cause edema. Hypoalbuminemia can cause edema. Physiological edema. All right. So hopefully you have written this about proteins. Then about iron. Write down total iron. This is metabolic system. Total iron requirement. That was one calculation which I told you as 2.3 into weight in kg into HP deficit. That was for anemic patient. I am now telling you about pregnancy overall. Total iron requirement in pregnancy. The answer is 1000 milligram. Yeah, 1000 milligram total iron requirement. Out of this 1000, 500 milligram is for RBC formation in mother. Okay, 500 RBC formation. 200 milligram is lost through urine, sweat and stool. 200 is lost through urine, sweat and stool. And 300 milligram is for fetus. So values over here are to be remembered. They have come in exam. 300 had come in exam, 1000 had come in exam. So yes, you remember these figures. They'll be asked in one or the other way. 1000, 500, 200, 300. Iron required in pregnancy 1000. Yeah. Iron absorption is increased. Yeah, iron absorption is increased. Guys, iron absorption is increased. Remember, 10% iron absorption is there in normal patients. It can be increased to 30%. When I'm talking on normal patient, I'm talking on non-pregnant patient. 10% can be increased as high as to 30%. So iron absorption is definitely increased. Okay. So this is about iron. Then about calcium metabolism. I hope you have written 1000, 500, 200, 300. Let me see. This iron requirement is for whole pregnancy. Okay. Yeah. Alright guys, so yes, iron absorption is increased. Okay, written, clear. Guys, calcium. Remember, total serum calcium levels will decrease. Yeah, baby requires 30 gram of calcium from mother. So total serum calcium is bound to decrease, but thankfully serum ionic calcium is constant. 2 lines I have written. Total serum calcium falls, ionic calcium remains constant. Thankfully ionic calcium remains constant. If ionic calcium was decreased, then patient would have come to us. Every pregnant patient would have carpopedal spasm. Yeah, that doesn't happen. You don't see antenatal OPD full of patients having carpopedal spasm. Never, because ionic calcium remains constant. Okay, total serum calcium falls, ionic calcium remains constant. Then you write down vitamin D levels are increased, calcitonin increased, parathyroid hormone is increased only in late pregnancy, not in early pregnancy. PTH increase only in late pregnancy. PTH gland size remains constant. Yeah, so yes, parathyroid gland size constant. Parathyroid levels wrongly given in some books as normal parathyroidism. Right? No, normal parathyroid levels, no, not at all. In fact, parathyroid hormone levels are increased, but in late pregnancy. Okay, yeah. So this is about calcium metabolism. These are important facts about calcium metabolism, and then we will talk about carbohydrate metabolism. Guys and girls, hopefully you have written these things about calcium. Let's talk about carbohydrate. Carbohydrate metabolism. Remember, pregnancy is diabetogenic. Yeah, pregnancy is a diabetogenic condition. Estrogen, progesterone, human placental lactogen, then testosterone, cortisol, all these hormones are causing hyperglycemia in pregnancy. Yeah, even an enzyme called insulinase, all these things are responsible for hyperglycemia in pregnancy. Good or bad? Good. Baby will get more glucose. So pregnancy is diabetogenic condition. Hyperglycemia happens. In order to fight this hyperglycemia, there is physiological hyperinsulinemia. Yeah, hyperglycemia and physiological hyperinsulinemia. All good? Yeah. So what will this hyperinsulinemia do? If patient doesn't eat for a long time, then there will be fasting hypoglycemia. Yeah, there is fasting hypoglycemia and postprandial hyperglycemia. Okay, fasting status, there will be hypoglycemia, baby will take its own glucose. Yeah, there is, I hope you remember facilitated diffusion, and there is glucose transport across placenta. And because of all these hormones, there will be postprandial hyperglycemia. So let us revise. Pregnancy is diabetogenic. Good or bad? Good. Baby gets its own glucose because of diabetogenic condition. The hormones like estrogen, progesterone, HPL, testo, cortisol, insulinase. Insulinase is an enzyme. All these things cause hyperglycemia. Most diabetogenic hormone is HPL. Endocrinology is pending. We will talk about HPL, human placental lactogen, most diabetogenic. Any patient who has excess amount of HPL is at risk of developing gestational diabetes mellitus. Yeah. So take home message, HPL is most diabetogenic hormone. Okay. Human placental lactogen, most diabetogenic hormone. Now, do we see glucose in urine of non-pregnant patients? The answer is no. Normal healthy patients do not throw out glucose from their urine. But in pregnancy there is physiological glycosuria. Yeah? That is why urine glucose assessment is not done in pregnancy. Yeah? Guys and girls, remember, urine glucose assessment is not done in pregnancy because there is already physiological glycosuria, glucose in your and my body. The threshold is 180 milligram percentage. If we cross 180 milligram percentage, then we throw glucose in our urine. Glycosuria would happen, marker of diabetes. But then remember, in pregnancy there is physiological glycosuria. Even at the levels of more than 135, glucose can be seen in urine. Okay? So this is about physiological glycosuria. Okay? Remember, glycosuria is physiological, proteinuria is pathological. Lactosuria is seen in PNC, postnatal care, lactating mother. This is normal. So glucose in ANC, lactose in PNC, that's normal. Okay, proteinuria is pathological. Could be infection, could be preeclampsia. Yeah, so proteinuria is pathological. Why postprandial hyperglycemia? I told you, because of these hormones which are causing hyperglycemia. All these things, they impair the glucose tolerance. Yeah, estrogen, progesterone, HPL, testosterone, cortisol, insulinase, these all things impair glucose tolerance. They cause hyperglycemia. These are hyperglycemic hormones. Yeah. Alright. Guys and girls, so we have completed the carbohydrate metabolism. Before going to break, I will just introduce you to this. We will take a break at 2:30. So it's still there is time. We will talk about the pathology. Pathology is diabetes in pregnancy. Diabetes in pregnancy. My dear friends, diabetes in pregnancy is of two types. One is a patient who is a case of gestational diabetes mellitus. I'll write it is due to pregnancy. She has become diabetic due to pregnancy. Yeah. And gestation, and another type of diabetes in pregnancy is overt diabetes mellitus. Overt diabetes mellitus, also called as pre-gestational diabetes mellitus. So, don't you think diabetic patient becoming pregnant will not be diabetic because of pregnancy? So, she is a case of pre-gestational diabetes mellitus. Yeah. And a patient who has become diabetic due to pregnancy, that patient is not over diabetes mellitus case. She is a case of gestational diabetes mellitus. GDM is due to pregnancy, overt DM is due to pre-gestational condition. Either it could be type 1 or type 2 DM, diabetes mellitus. Yeah? Guys, girls, gestational diabetes mellitus, I'll write that formula again. T3 more than T2, not in T1. T3 more than T2, not in T1. It will be commonly seen in third trimester rather than second trimester, but not seen in first trimester. Yeah? Overt diabetes mellitus throughout pregnancy. What? Throughout pregnancy? It is there before pregnancy also and after pregnancy also. Yeah? So overt diabetes mellitus is present throughout pregnancy. Of course. Now, you know organogenesis. Organogenesis happens in first trimester. Embryogenesis, organogenesis. So if the disease called GDM does not happen in first trimester, it is not a high risk. Not a high risk for congenital anomalies. Yeah? I said GDM patient is not a high, GDM condition is not a high risk for congenital anomaly development. Overt diabetes, very high risk for congenital anomalies. This question has been repeatedly asked clinically. If patient has come to you and she is a case of gestational diabetes mellitus, which thing would not be there as high risk in this patient? Yeah, the answer would be congenital anomalies. Congenital anomalies are same as that of normal population because GDM does not happen in first trimester. Okay. Now, ideal time to detect GDM. See, why not first trimester? The question is, why not first trimester? My answer to this is, hormonal levels are very, very less in first trimester. You know HPL, most diabetogenic hormone, is so less in first trimester. It is very high in third trimester, maximum in third trimester. We will talk about the hormones, then you will understand. Remember HPL, estrogen, progesterone, they are very low in first trimester as compared to third trimester. Yeah? There is no role of HCG over here. I am not talking about HCG. HPL. Yeah? Ideal time to detect GDM I was writing. The answer is 24 to 28 weeks. This is an ideal time for detection of GDM. Ideal time to detect, if she is not already detected as a case of diabetes mellitus, then ideal time is first visit. Yeah? Guys and girls, we live in India and India is high risk for diabetes. Indians are at high risk for development of diabetes. We have diabetes in our genes. Yeah. Being Indian is a risk factor for developing diabetes. Yes, that's true. That's why we, the obstetricians, have to carry out blood sugar evaluation 2 times. First visit also and 24 to 28 week visit also. Now, ADA also says the same thing. If they have asked you American Diabetes Association definition of overt diabetes mellitus. American Diabetes Association definition of overt diabetes mellitus, the answer would be fasting more than or equal to 126 milligram percentage. Fasting 126 milligram percentage or more. Random blood sugar more than or equal to 200 milligram percentage. RBS 200. Or HbA1c more than or equal to 6.5%. Either this or this or this would be a case of overt diabetes mellitus. Okay. Guys, so yes, overt diabetes mellitus would be either fasting 126, random 200 or HbA1c 6.5. Okay. Now, guys and girls, after you have written this, needless to say this, yeah, you know this, that GDM is because of pregnancy, so it will resolve. GDM will resolve within 6 weeks of delivery. In fact, in most of the patients, once placenta is out, she will become fine. She will become normal. Will resolve within 6 weeks of delivery. And needless to say, will not resolve. Over diabetes mellitus will not resolve even after delivery. Yeah? It's a chronic condition. It will not resolve even after delivery. Guys and girls, after you have written this, then I want you people to write down diagnosis of GDM. Diagnosis of GDM. How do you diagnose GDM? We in India followed DIPSI criteria, full formed as diabetes in pregnancy study group. Diabetes in pregnancy study group of India. Yeah? DIPSI criteria. DIPSI criteria says give 75 gram oral glucose. Yeah? Guys, I am talking about diabetes diagnosis, GDM diagnosis. I hope you are on track. I said give 75 gram oral glucose. So patient has come to your OPD. Let's say 32-week pregnant patient has come to you for the first time. You give her, because ideal time was 24 to 28 weeks for GDM diagnosis, and for over diagnosis first visit in first trimester. Yeah. So yes, patient has come to your clinic. You give her 75 gram oral glucose. Fasting is not necessary. Yeah, fasting is not necessary for diagnosis of DIPSI criteria. Yeah, check blood sugar level at the end of 2 hours. Yeah, once she has taken 75 gram oral glucose, check blood sugar level at the end of 2 hours. If it is 140 milligram percentage or more, then she is a case of gestational diabetes mellitus. So I have written 75, fasting not needed. 2 hours later on you have to check for blood sugar levels, and yes, if it is 140 milligram percentage or more, she is a case of what? Gestational diabetes mellitus. Okay, this is how we diagnose GDM in India. Okay guys, so yes, this is what is diagnosis. We will talk about treatment for sure. Most of you have become hypoglycemic till now, so yes, take a break. I can understand that you people are hypoglycemic now. I can feel it. Break. So 40 minutes and we will be back. Now it's 2:30, 3:10 p.m. Okay. All right. Thank you. Okay guys, so we are back, and we will be finishing off this topic called gestational diabetes mellitus. We were talking about how to diagnose gestational diabetes mellitus, and yes, you have written DIPSI criteria for diagnosis of gestational diabetes mellitus. Fasting is not needed. Patient may have come fasting or may not be fasting. That is not necessary, because DIPSI criteria is based like that. DIPSI is for low resource setup. DIPSI is for a population where diabetic patients are there, and yes, so resources are less. So we are doing this simple test, 75 gram test. Patient may or may not be fasting, and just one blood sugar evaluation can tell us whether she is diabetic or not. Okay. Now after we have known that yes, she is a case of diabetes, then we will talk about the treatment of diabetes. Treatment of choice. Is insulin therapy. Insulin does not cross placenta and insulin is best. Insulin therapy has to be started. Okay. Oral hypoglycemic agents are contraindicated in pregnancy except metformin and one more, glyburide. Yeah, I said oral hypoglycemic agents are contraindicated except metformin and glyburide. These two things are allowed, others are not allowed. Yeah. Now, what is the indication of giving oral hypoglycemic agent? Oral hypoglycemic agents are given only when patient refuses insulin therapy. Yeah, if she denies insulin, if she does not allow insulin therapy, then we have to resort to oral hypoglycemic agents. Yeah. Now, target blood sugar levels. Target blood sugar levels should be fasting less than 95, less than or equal to 95, 1 hour less than or equal to 140, 2 hour less than or equal to 120. This is our target. Okay, this has to be maintained. Now there is one catch. If patient has mild GDM, which means fasting less than 105, then attempt diabetic diet therapy alone. No medication at all. Attempt diabetic diet therapy alone. Target achieved? Great. Target achieved. You continue diabetic diet therapy only. But if target is not achieved, then you are supposed to do insulin therapy. Yeah, target achieved, target not achieved. So you are supposed to do insulin therapy. Okay, so this is what is to be done in a case of gestational diabetes mellitus. I'll give you one example. Patient is GDM case. Yeah, 32 weeks gestation. Patient is a case of GDM, 32 weeks gestation. She has fasting levels of, let's say, 98 milligram percentage. Next line of management, diabetic diet therapy. That's the answer for this patient. Diabetic diet therapy is to be started. If you achieve the target called less than 95, less than or equal to 95, 1 hour less than or equal to 140, 2 hour less than or equal to 120, great, congratulations, you have done well. Yeah, diabetic diet therapy has succeeded. Let's suppose this diabetic diet therapy did not succeed. You have checked her blood sugar levels again, and in 3 days you will recheck. 3 day time we will recheck. Yeah, if blood sugar levels are not achieved, then you are supposed to start her on insulin therapy. Okay, so right answer for this patient is diabetic diet therapy. What if patient has fasting of, let's say, 135? Yeah, compulsorily insulin. Yeah, obviously diet therapy has to be given to all diabetic patients, but diet therapy alone cannot be the answer for this patient. You have to give compulsorily insulin therapy. Yeah, overt DM patients require only insulin therapy. No oral hypoglycemic agents. They have no option. They cannot deny, they cannot refuse insulin therapy, because in them insulin is the only treatment. Overt DM patient, insulin therapy is the only treatment. no OHA, no diabetic diet alone. You have to give insulin therapy. Yeah, insulin dose is 0.7 to 1 international unit per kg. That's the insulin dose. Yeah. Termination of pregnancy. Remember, never terminate in early term. Never terminate in early term. If you remember, early term figure was 37 to 38 plus 6. Never ever terminate in early term. Remember, lung maturity in infants of diabetic mother would be less than normal. Yeah. So lung maturity would be affected. We don't want to deliver early term babies. Yeah. So 39 and beyond would be the termination. Yeah. 39 and beyond would be the time of termination. Okay. Guys, girls, 39 and beyond would be the time of termination for GDM patients. Never cross EDD. So 40 weeks is the deadline. By 40 weeks, you terminate pregnancy. So patient has well controlled blood sugar levels. Yeah. Patient has well controlled either by diet therapy or by medication, well controlled. 40 weeks would be the deadline. Yeah. Unless there is any fetal distress, if there is fetal distress or any other, abnormality which requires immediate termination, then the answers would change. Otherwise, 40 weeks is the deadline. Okay. Am I clear about this, guys? So, never term in early term and 40 weeks is the deadline. Okay. Then, write down complications of diabetes in pregnancy. And I'm not talking about medical complications, I'm talking about obstetrical complications. So I will give 4 arrows. Antenatal, intranatal, postnatal and neonatal. Antenatal, intranatal, postnatal and neonatal. Antenatal complications. I told you polyhydramnios, and somebody asked also why polyhydramnios will be there in diabetes. Remember, diabetic patients will have hyperglycemia, and hyperglycemia can pass into the baby. Baby will have hyperglycemia, so increased urine output would be there. And yes, babies are macrosomic, so more urine output because of macrosomia. Yeah. And yes, remember placenta is also large, so placental transudation is also more. So more urine output, large baby, placental transudation increased. All these things are responsible for polyhydramnios. Then preterm labor. Yeah, preterm labor. Because there is polyhydramnios, there is over distension of uterus, and that's why preterm labor. Over distended uterus can cause contractions earlier than normal. Yeah. Preeclampsia. It is said that diabetic patients have abnormal placentation, and there is a possibility of preeclampsia in these patients. Yeah. Diabetes and hypertension, they go hand in hand. Preeclampsia would be commoner than others. Then again I will write macrosomia. Macrosomia is more common in male babies. Remember this line, huh? Macrosomia is more common in male babies. I hope you remember anencephaly is more common in female babies. Macrosomia is more common in male babies. Okay. Then after macrosomia, then candidiasis, UTI are more common in diabetics. Then abortions. Yeah, abortions, because hyperglycemia is fetotoxic. It can cause abortion because of fetotoxic effect. Okay, so early pregnancy loss. This will be typically seen in overt diabetes mellitus. Then congenital anomalies, but only in overt diabetes mellitus. Yeah. Then abruptio placenta. Huge uterus, lots and lots of fluid. Sudden gush of fluid can cause abruptio placenta. Okay. So poly is a risk factor for abruptio also. Okay. Yeah. So antenatal complications are there in front of you, right from polyhydramnios to abruptio placenta. Then let's talk about intranatal complications. What are intranatal complications? Intranatal complications would be uterine inertia. Madam has covered already power pathology, uterine inertia, less power. Yeah, uterine inertia can be there because of over distended uterus, actin myosin filaments will be far apart and contraction will get affected. Yeah, so uterine inertia, less power. Then shoulder dystocia. Okay, uterine inertia, shoulder dystocia. Shoulders do not come out after head delivery. Shoulder dystocia. Cord prolapse. Again abruptio placenta. Then there is chance of instrumental delivery more than others. Then cesarean section chances are increased. Yeah, so these are the things which are seen in intranatal. Yeah, traumatic deliveries. Okay, traumatic deliveries are more common here. Intranatal complications. Okay. Then postnatal complications. Postnatal complications. Nothing can beat this most common postnatal complication called postpartum hemorrhage. Postnatal complication, postpartum hemorrhage. Okay. I will maintain this slide. You continue writing and yes, finish off the complications till this point. Abruptio placenta, because uterus is distended with fluid, polyhydramnios, and then when there is sudden gush of fluid, imagine uterus getting collapsed, uterus size getting reduced, the placenta will be thrown into folds and blood may get accumulated behind. So artificial rupture of membrane can cause sudden gush of fluid, can cause abruptio placenta. Okay. Yeah. So yes, abruptio placenta is common in polyhydramnios cases. Okay. Uterine inertia is less power. Imagine uterus is not contracting properly. Power is less. Yeah. Large baby is there, over distended uterus is there, uterus might not be able to throw the baby properly. So uterine inertia is there. So this is about antenatal, internatal, postnatal I was writing. Postnatal, PPH, then subinvolution. Subinvolution. Okay. Subinvolution. Slows. Okay, fine. Got it. Don't spam. Yeah. So guys, girls, I said postnatal would be postpartum hemorrhage, then subinvolution, then there is a chance of puerperal sepsis, lactational failure. These things are more common than others, but PPH is the most common complication in them. Yeah. Then comes neonatal. Baby is also at risk. Mother has diabetes, but baby will have risk. What risk? I'll tell you. Neonatal complication. Most common neonatal complication would be hypoglycemia. Most common neonatal complication, hypoglycemia. Then there will be hypocalcemia, hypomagnesemia. Why hypoglycemia? Try to understand that glucose comes from mother through facilitated diffusion. Mother will give glucose to baby. Insulin cannot come from mother to baby. Okay? Once the baby is out, cord is clamped, glucose will stop coming. Baby will have to deal with its own insulin excess. Yeah? So earlier glucose was high, that's why insulin was high in the baby. Now cord is clamped, glucose supply is stopped, but baby's insulin is very high. That insulinemia of baby causes hypoglycemia. Okay? So there is hyperinsulinemia, that's why hypoglycemia. Okay? Then hypocalcemia, hypomagnesemia, then respiratory distress syndrome, respiratory distress syndrome. Surfactant deficiency causes respiratory distress syndrome. Okay, I have told you that insulin has negative effect on surfactant production. Yes, that's why respiratory distress syndrome is more common in these babies. Okay, then there is hypoxia. Because of respiratory distress syndrome, there is neonatal hypoxia. Okay, then if there is hypoxia, that hypoxia means less oxygen level will be there all throughout the body. So there may be necrotizing enterocolitis. Intraventricular hemorrhage will be more common. Intraventricular hemorrhage, same, hypoxia causes intraventricular hemorrhage. Oh. Yeah, hypoxia causes intraventricular hemorrhage. Okay, yeah, so neonatal hypoxia, necrotizing enterocolitis, IVH, RDS, these are connected to each other. Okay, and yes, when intestines get necrosed, there will be neonatal sepsis. Neonatal sepsis. Yeah, so there is high mortality, morbidity in these babies. Depending upon how large the baby is, how uncontrolled diabetes was. Don't forget, these babies have high risk of dislocations and fractures. Large babies, shoulder dystocia, fractures, dislocation, brachial plexus injuries, they are very common. Yeah, dislocation, most common would be shoulder. Yeah. And fracture, most common bone would be clavicle. Yeah, most common bone to get fractured would be clavicle. Okay, forceful traumatic vaginal delivery, if it happens, then humerus is the winner. Yeah, so humerus fractures are also there. Forceful delivery, traumatic delivery, the answer would be humerus. If you get a question, most common bone to get fractured in baby, your answer should be clavicle. But in traumatic or forceful vaginal delivery, the answer is humerus. I think more of it would be covered in orthopedics. Okay. Then don't forget, neonatologists will also have to do one, deal with one more thing called congenital anomalies. Congenital anomalies. Now, congenital anomalies, they are directly proportional to HbA1c levels. More the HbA1c levels, more would be the risk of congenital anomalies. Yeah. Most common congenital anomaly would be CVS anomaly, cardiovascular system anomaly. Okay. Most common CVS anomaly would be VSD, ventricular septal defect. Okay. Most common CVS anomaly, ventricular septal defect. Most specific CVS anomaly would be transposition of great arteries. Yeah, that's most specific CVS anomaly, transposition of great arteries. Most specific anomaly, not CVS anomaly, anomaly would be sacral agenesis. Yeah, most specific anomaly in infants of diabetic mother would be sacral agenesis. Yeah, also called caudal regression syndrome. Yeah. So guys, if a patient has come to your clinic, she is already diabetic, tell her to bring the HbA1c level down before attempting pregnancy. So ideal HbA1c before pregnancy is less than 6.5. Ideal HbA1c during pregnancy would be less than 6. I've written two important values. If patient is pregnant, already she has become pregnant, tell her to maintain her HbA1c less than 6. Yeah. Congenital anomalies are seen only and only in over diabetes mellitus patient, not in a case of gestational diabetes mellitus patients. Okay, hopefully you understood this, because GDM is not there in first trimester. Why it's not there in first trimester? Because hormonal levels are less. So impaired glucose tolerance would not be there in first trimester because of pregnancy. Okay, so GDM is a property of pregnancy, doesn't happen in first trimester. Over DM happens before pregnancy, so it can cause organogenesis defect and congenital anomalies. Okay. Alright guys, we have covered diabetes. I hope you have understood these things about diabetes. Now after the topic called diabetes, we will talk about next topic called as hypertension in pregnancy. Hypertension in pregnancy is the next topic. Now here, let me tell you that there is a classification of hypertensive disorders. There is nothing called PIH nowadays. Pregnancy induced hypertension is an old terminology. Now the classification says that there is a gestational hypertension. When will you label someone as a case of gestational hypertension? What are the requirements? Number 1, hypertension of 140/90. Two times, 4 hours apart. Hypertension of 140/90, 2 times, 4 hours apart. Number 2, no proteinuria. There should not be proteinuria. Number 3, it occurs after 20 weeks of gestation. Okay, it occurs after 20 weeks of gestation. Number 4, it resolves within 12 weeks of delivery. Okay. Yes, the figure is 20 weeks. It resolves within 12 weeks of delivery. Then the patient is labeled as a case of gestational hypertension. Okay. 4 points I told you. She should have hypertension of 140/90 or more 2 times, 4 hours apart. No proteinuria. Yeah. It occurs after 20 weeks of gestation. It is not a property of first trimester. Yeah. It occurs after 20 weeks of gestation. It resolves within 12 weeks of delivery. That's gestational hypertension for you. If I add proteinuria to this, then the case changes. The next case is a case of preeclampsia. Preeclampsia. Now preeclampsia, number 1, same hypertension 140/90, 2 readings, ... same. Number 2, proteinuria or end organ damage. Yeah, proteinuria or end organ damage. Number 3 and number 4 rules are same. Yeah. So technically speaking, gestational hypertension plus proteinuria or end organ damage would be preeclampsia. Okay. Now what things are included in proteinuria, what things are included in end organ damage, I'll write over here. Now proteinuria, here it has to be more than or equal to 300 milligram of proteinuria in 24 hours. Or protein creatinine ratio of more than 0.3, or urine albumin dipstick, urine albumin sticks are available, urine albumin of more than +1. If any time urine albumin is more than +1, we label this patient as a case of preeclampsia. Either this 300 or 0.3 or urine albumin plus more than +1. So in your hospitals, you must have seen urine albumin sticks. There is something called trace, 1+, 2+, 3+, 4+. Trace would be 100 milligram per liter. That's trace urine albumin. Okay. Then 1+ would be 300 milligram per liter. Yeah. Devu's question is, if number 4 rule is seen after delivery, so how do we diagnose during pregnancy? Understand this thing, that it's the diagnosis made in pregnancy for sure, but if it is present even after 12 weeks of delivery, then our retrospective diagnosis would change and it will become a case of chronic hypertension. So therefore you are right. 4th rule which is there, it resolves within 12 weeks of delivery. It has to be seen in a case of proven case of gestational hypertension or preeclampsia. You won't find gestational hypertension at 25 weeks after delivery. No, not at all. Yeah. So yes. So urine albumin trace I was talking about. Dipstick method. Yeah, there is dipstick method available. Trace 100 milligram per liter. 1+ 300 milligram per liter. 2+ is 1 gram per liter. 3+ is 5 gram per liter. And 4+ is 10 gram per liter. Yeah. So trace is 100, 1 plus is 300, 2 plus is 1 to 2 gram, yeah, 1 gram per liter. 3 plus is 5 gram per liter and 4 plus is astonishingly high, 10 gram per liter. So much of proteinuria. Okay. Yes, urine albumin stick more than, urine albumin dipstick showing more than +1. That means +2, +3, +4 is surely a case of preeclampsia. Yes, the figure is, the unit is milligram per liter. Okay, alright. Guys, this is the story of proteinuria. What about end organ damage? I have written end organ damage as well. What are the things included in end organ damage? End organ damage. So I am writing here SGOT, SGPT more than 2 times normal. Yeah, that means there is liver damage. Then pulmonary edema. Yeah, guys, pulmonary edema. Then serum creatinine more than 1.1 milligram percentage. That means kidney damage. So liver damage, lung damage, kidney damage. Then platelet count less than 1 lakh. Yeah, I'll tell you Shreya, listen, I told you about the diagnosis of preeclampsia. What is the first thing? Hypertension. When you get a patient in OPD, you check her BP. Her BP is 140/90. You don't label her as a case of hypertension. You have to check the BP again after 4 hours. If second reading is also high, then she is a case of hypertensive disorder in pregnancy. Could be preeclampsia, could be gestational hypertension. So you have to take 2 readings. Okay? Okay. So 2 readings would mean checking twice. Alright. Platelet count less than 1 lakh. Then cerebral or retinal symptoms. Cerebral or retinal symptoms. Imagine a patient having blurring of vision or blindness. Yeah, that is possible in hypertensive disorder. Either occipital or retinal cause can be there. Yeah. Cerebral, that means she might be having headache. She might be having increased intracranial tension. So yes, cerebral symptom, retinal symptoms would qualify as end organ damage. So yes, the definition is proteinuria or end organ damage should be there in a case of preeclampsia. If it is proteinuria or end organ damage, then she is a case of preeclampsia. Okay? Anurag Ganguly, your question is amazing. So the patient is made to wait for 4 hours? The answer is no. Remember this thing, that patient is not made to wait for 4 hours. BP monitoring is advised to the patient. Patient does what? Patient goes back home and yes, nearby clinic or somewhere nearby, the patient will chart the BP on a rough paper and she will come back and show us the BP chart. So BP charting is to be done. You don't have to, keep the patient for 4 hours. Guys, remember this thing, the figure is 140/90. Okay? What if her first reading, this is an exceptional thing, if first reading is more than or equal to 160, 110, this is severe case, very high BP raised. Don't wait for second reading. I hope you got this clinical scenario. Yeah? Guys, girls, don't wait for second reading if first reading is 160, 110 or more. Okay? Guys, now question is, why these things are happening? Why end organ damage? Why proteinuria? Proteinuria is also kind of end organ damage. Proteinuria means there is damage to the glomerular system. There is glomerular endotheliosis. Remember this thing. Kidney damage will cause proteinuria. Why all these things are happening? Because of vasospasm. Why vasospasm? Because the problem is in placenta. If you remember, I told you abnormal invasion of cytotrophoblast. Abnormal invasion by cytotrophoblast will cause narrowing of vessels. This disease is not limited to placenta, it is spread to the whole body. The whole body undergoes vasospasm and then she has clinical manifestations. Okay, guys? Right now you understand that diagnosis, retrospective diagnosis is made if BP is checked after 12 weeks of delivery, and if the BP is normal, then my patient was a case of gestational hypertension and preeclampsia. My treatment has already happened. We treat the patients as a case of gestational hypertension, preeclampsia based on the above 3 rules. Yeah. The 4th rule which you have written as resolves within 12 weeks of delivery. That would be just for confirmation that the patient was not a case of chronic hypertension. You, first of all, understand that I will finish the classification of hypertensive disorders in pregnancy. There are 5 cases which I will be covering. Once I will cover 5 cases, I will give you clinical scenarios, then you will understand for sure. Okay, so we have covered gestational hypertension, we have covered preeclampsia, end organ, any criteria, or, yeah, any one is sufficient to label someone as a case of preeclampsia. Third case is a case of eclampsia. This is our third case, eclampsia. Very simple to understand. Eclampsia means A, there should be hypertension, 140/90, 2 readings, 4 hours apart, but yes, there is convulsion. Hypertension plus convulsion is sufficient to label someone as eclampsia. Hypertension plus convulsion. C and D rules are same. Eclampsia occurs after 20 weeks of gestation. And yes, resolution would happen. That means there will be no convulsion after 12 weeks of delivery. If she is having convulsion even after 12 weeks of delivery, believe me, she was not a case of eclampsia. Okay, am I clear about this, guys? So hopefully you have written this about eclampsia. Convulsion plus hypertension, eclampsia. Most important thing is seizure, convulsion. Yeah. Number 4 is a very, very simple case called chronic hypertension. Yeah. So I said A was gestational hypertension, B preeclampsia, C eclampsia, D chronic hypertension. Chronic hypertension, number 1, hypertension of 140/90, same thing, 2 readings, 4 hours apart. Why 12 weeks? Because understand this thing, earlier it was 6 weeks, but there were cases after 6 weeks also. They used to resolve after 12 weeks. So latest time which can take for resolution was 12 weeks. That's why they changed to 12 weeks. Earlier it was 6 weeks. Okay, hypertension plus second rule is it occurs before 20 weeks of gestation. It occurs before 20 weeks of gestation. Proteinuria and eclampsia may be there, may not be there. That is not important. What is important is convulsion. Proteinuria may or may not be there in eclampsia. I will tell you. Guys, understand this thing. Eclampsia means end organ damage affecting the brain, obviously. Yeah, proteinuria may or may not be there. Okay, got it? Very clear. Okay. Chronic hypertension, hypertension of 140/90 occurs before 20 weeks of gestation and it will not resolve. Yeah, this is the point. It will not resolve. even after 12 weeks of delivery. Okay? It will not resolve even after 12 weeks of delivery. You have realized this, that eclampsia and chronic hypertension, proteinuria may or may not be there. That's not necessary for labeling someone as chronic hypertension. Yeah? Proteinuria may or may not be there in eclampsia as well. What if proteinuria is not there? Will you not label her as a case of eclampsia? You will. Proteinuria is not necessary for eclampsia diagnosis. I'm not telling you proteinuria is not there. In most of the cases it will be there. But that's not the criteria for diagnosis of eclampsia. Yeah, I'm right now telling you the classification and the diagnosis. Let's talk about fifth case. Superimposition. Superimposition. Now superimposition means she already has one disease and she develops another disease. So it's of two types. Either she is a case of pre-eclampsia, superimposed on chronic hypertension, or she is a case of eclampsia superimposed on chronic hypertension. Yeah? So pre-eclampsia superimposed on chronic or eclampsia superimposed on chronic. Okay? Yeah. Here is eclampsia. What is the most important thing to label someone as eclampsia? Convulsion. Seizures. What is the most important thing to label someone as chronic hypertension? It occurs before 20 weeks of gestation. It's a chronic disease. It's a pre-existing disease. Suppose if a patient already has a pre-existing disease called chronic hypertension, now she develops convulsion. Then she is no longer labeled as chronic hypertension alone. She is eclampsia superimposed on chronic hypertension. Okay? Guys, girls, pre-eclampsia superimposed on chronic hypertension would be new proteinuria or worsening proteinuria. So a patient who had chronic hypertension but now she fulfills the proteinuria criteria that you remember, 300 milligram in 24 hours. Earlier it was not there, now it is there. New proteinuria. Worsening proteinuria or worsening hypertension or end organ damage. Yeah. Then the patient is labeled as pre-eclampsia superimposed on chronic. Yeah. There has to be fulfillment of diagnosis of pre-eclampsia in an existing case of chronic hypertension. Okay. And you already know the criteria for labeling someone as pre-eclamptic case. Proteinuria or end organ damage. Yeah. Guys, why are there seizures in eclampsia? Seizures are due to vasospasm. We will talk about eclampsia. Vasospasm is the culprit for all the abnormalities, all the clinical manifestations. Let us give clinical cases. Let's talk clinically. Let's talk about OPD. So you are sitting in OPD, you are seeing cases, let's say Primi gravida has come, 32 weeks of gestation, BP is 140/90. Case number 1, I am writing case number 1. First case, Primi gravida, 32 weeks gestation, BP 140/90, no proteinuria, no other symptom or sign. Chalo, diagnosis. Anyone? What's your diagnosis? I will not give you option, you tell me. What's your diagnosis? Guys, the diagnosis is she is not a case of hypertension yet. She is yet not a case of hypertension. Yeah? She is not a case of hypertension, yes, yet. Why? Why she is not yet a case of hypertension? Because we are missing something. What are we missing? We are missing that we have not taken the second reading. So, second reading is necessary. I hope you got my point. This was a googly to you. Guys, I have given you BP of 140/90. I did not tell you repeat BP is also 140/90. So guys, she is not a case at all yet. You need to check her BP second time. It should be 4 hours later on. At least 4 hours later on. Okay? 10 hours is also fine, but second BP reading is important. Okay? Got it very clear? Yes, reading is necessary. What if, same question, BP 140/90 twice. That's it. Tell me your diagnosis. This is case number 2. Case number 2. Everything same except that BP is 140/90 twice. Okay. Tell me the diagnosis. Yes, very simple now. She is a case of, okay, gestational hypertension, but why can't it be chronic hypertension? Just now you people were telling me, na, sir, diagnosis will be after 12 weeks, so what will we do right now? Guys, girls, if she has come for the first time, her BP is taken for the first time, there is no way to know whether the patient is a case of gestational hypertension or chronic hypertension. It will be diagnosed only afterwards. Afterward means after 12 weeks of delivery. But then our treatment won't change. Treatment wise, we will talk about treatment. But right now you understand there are 2 possibilities. There are 2 possibilities in this case. She is gestational hypertension or chronic hypertension. I'll check BP 140/90. That has become 140. It is 140/90 2 times. She is either gestational hypertension or chronic hypertension. Why? Because of the figure 32 week. Understand that she has not come to us in early pregnancy to know what was the BP before. Yeah, good. Take history. Okay, but remember, there are most of the chronic hypertensive patients in such young age might not know that they are chronic hypertensive patients. So you have 2 possibilities in this case. Case number 3. Okay. Case number 3. Primi gravida. Primi gravida. 12 weeks gestation. BP 140/90. 2 times. Yeah? Primi, 12 weeks gestation, BP 140/90, 2 times. Diagnosis, please. What is the answer for case number 3? Very simple question. Urine albumin, I'm writing nil, but that doesn't matter. Yeah? Guys, third question, primi gravida, 12 weeks gestation, BP 140/90, urine albumin, whatever. It's nil written over here, but whatever. The answer would not change. The answer would be, yes, anyone? Yes, chronic hypertension. Why not gestational hypertension? Because the BP is abnormal before 20 weeks of gestation. Great, you have understood this. I will give you another case. Same patient. Same as case 3. Yeah, same as case 3, plus at 32 weeks, she has BP of 160/110. Urine albumin is 4 plus. Same as case 3, same patient, my dear friends. But now at 32 weeks, her BP has changed. Urine albumin 4 plus. What is your diagnosis? Double. Okay. Yeah. Question number 2. Okay. Case number 2, I said BP 140/90 twice. There is no mention of proteinuria. This case number 1, there is no mention of proteinuria, no protein. In fact, proteinuria is not there, which is written. Yeah, same question. BP twice. Is gestational hypertension or chronic hypertension? Let me jump on to case number 4. Come on, tell me case 4. Superimposed. Correct. This is superimposition. I hope you have understood this. This is a case of clear-cut case of superimposition. Okay. Now, case 5. Primi gravida. Case 5. Primi gravida plus 40 weeks of gestation plus conversion. Urine albumin negative. Really? Yeah, negative. I'm writing negative. Yes, this is the case. Yeah. BP is 148 by 100. BP is 148 by 100. Come on. This is very simple. 40 weeks, conversion. What else do you want? Understand, she is a case of eclampsia. Okay, this is very simple. This is eclampsia, conversion. You understood that urine albumin does not change the diagnosis. In the previous case also, chronic hypertension, urine albumin did not change the diagnosis. Case 3, urine albumin nil. That's okay. It did not change the diagnosis. Okay. Great. So after you have written the cases, let's talk about who all are at risk. Risk factors. Guys, it's a disease of primi gravida. 10% primi gravidae have this disease. Yeah. So out of 10 girls sitting over there, okay, audience, 10 girls, 1 will get this disease. Alright. Don't worry. I'll be there. Call me. Then, it's a disease of teenagers. Got it? Disease of teenagers. Girls, don't worry. Your age is gone. It's a disease of elderlies. Girls, worry. Elderly and medico. High risk. Who is elderly, by the way? Elderly is a patient who is more than 35 years. And she is pregnant. Of course, I am talking about obstetrics. Guys, girls. So yes, teenager, elderly. Number 3, high HCG conditions. High HCG conditions. What are high HCG conditions? Molar pregnancy, multifetal gestation, then Down syndrome, RH incompatibility, yeah, molar pregnancy, multifetal pregnancy, Down syndrome, RH incompatibility are high HCG condition. Word of caution, word of caution, word of caution. Molar pregnancy can cause preeclampsia, eclampsia, even before 20 weeks. Yeah, I just now told you rules and you have understood the rules very well that preeclampsia doesn't happen before 20 weeks. But then I am breaking the rule for molar pregnancy. So remember, if patient has preeclampsia before 20 weeks of gestation, the answer would be molar pregnancy. Okay, it breaks the rule of 20 weeks. So preeclampsia, eclampsia, even before 20 weeks, you are dealing with molar pregnancy. Okay, guys. Another thing which you have to remember, RH incompatibility. RH incompatibility, here you understand that patient has hydrops fetalis baby. So, edematous fetus. Yeah, fetal edema is there, hydrops fetalis. And mother is preeclamptic. So, edema in mother. This is called as maternal mirror syndrome. Yeah, maternal mirror syndrome. Mother and baby will mimic each other. Baby is edematous, mother is also edematous. It's said that hydros fetalis will have large placenta, and that is, if you remember placentomegaly topic, I told you large placenta would be there, and large placenta may lead to abnormal placental cytotrophoblastic invasion, and that is why there is a chance of preeclampsia. So, one statement for all, maternal mirror syndrome is edematous mother and baby seen in RH incompatibility. Okay? Yeah. So guys, what am I talking about right now? I'm talking about risk factors. Primary gravida, age-related, teenager, elderly, high HCG conditions. Number 4, high estrogen conditions. High estrogen conditions. Acha, question is, kiske risk factor? Wow, I love you. Who is that person? Shubham Dhawan. Kiske risk factor is your question. Risk factor, great question, amazing, I love you. Risk factor for hypertensive disorders in pregnancy. Okay? Yeah, high estrogen conditions would be risk factor for development of hypertension in pregnancy. High estrogen conditions would be, yes, PCOS, yes to obesity, yeah. Then family history. Okay, yeah. High estrogen condition. You know, obesity runs in family because nobody runs in family. Alright, everyone is obese. So yes, family history is there. It is associated with preeclampsia, eclampsia also, hypertensive disorders also. Okay, alright. High estrogen conditions, then large placentae conditions. Large placenta conditions. Number 6 would be vasospastic conditions. Vasospastic conditions would be, example as renal disorders. Vasospastic conditions, renal disorders. Then vasospastic condition could be, you know, peripheral vascular disease. Yes, vasospasm all around would be there. Peripheral also there, central also there. Possible preeclampsia, hypertensive disorders are common. Yeah. Then hypercoagulable conditions. Hypercoagulable conditions. So hypercoagulable conditions would be SLE, protein C, S deficiency, Usmle syndrome. Why large placentae condition? Question is why large placentae condition? Large placenta, as I told you, large placenta will have abnormal placentation. Cytotrophoblastic invasion will be faulty. Not in all cases, but in some cases. Yeah, that's why large placentae conditions like twin gestation, like diabetes, these conditions have large placentae, so there is very high chance of development of preeclampsia, eclampsia, hypertensive disorders in pregnancy. Okay. Alright. So SLE, protein C, protein S deficiency, Usmle syndrome. Maharashtrian people. Yeah. Usmle म्हणजे आपला नाही. Usmle means anti-phospholipid antibody syndrome. In Marathi, Usmle is mine, hamara. Yeah. Yes. Anti-phospholipid antibody syndrome. Okay. Guys, girls, so yes, hypercoagulable conditions can indeed cause, hypercoagulable conditions can indeed trigger hypertension in pregnancy. Clots will reduce the lumen vasospasm. Any clot in the body, there is chance of vasospasm over there. Upler syndrome causes clots, and clots will cause vasospasm. That's the logic behind hypercoagulable condition. Then IVF pregnancy. In vitro fertilization pregnancy. Any artificially produced pregnancy. ART techniques, they have inbuilt risk of hypertensive disorders. Yeah, guys and girls. So hopefully you have written it well about the risk factors. Now I want you people to write down classification. Which classification we have covered just now? This is another classification. This is classification of preeclampsia. Now preeclamptics should also be classified. We don't want just the classification and the diagnosis. We want to treat the patients. And the treatment of severe preeclampsia would obviously be different than treatment of non-severe preeclampsia. So classification is important. Clinically, we need to classify. I am very sure you people must have attended rounds, not now, yes, obviously lockdown and all. But then whenever you were on rounds and you were seeing patients, there were patients in labor ward with hypertension and there were patients in antenatal ward with hypertension. So some patients were monitored for continuation of pregnancy and some patients were for termination of pregnancy. So you need to know the protocols. Protocols are important. So let's talk about classification as non-severe, severe preeclampsia. Severe preeclampsia, a patient who has, let's say, uncontrolled BP of more than or equal to 160, 110. The word is or 110. Yeah? Yeah. So uncontrolled BP 160 or by 110, 160 or 110 is labeled as severe. Then there are many more things like pulmonary edema. Pulmonary edema present, she is a case of severe. You can't label her as non-severe. Then HELP syndrome. HELP syndrome, full formed as hemolysis, elevated liver enzymes, and low platelet count. Yeah? Hemolysis, elevated liver enzymes, low platelet count, HELP syndrome. Now hemolysis would happen, elevated liver enzymes would happen, and low platelet count would happen. If all three things happen, then she is HELP syndrome case. It's a severe preeclampsia. Okay? Yeah. Platelet count less than 1 lakh. Yeah. Elevated liver enzymes, SGOT, SGPT, more than 2 times normal. Yeah, I said SGOT, SGPT more than 2 times normal. And signs of hemolysis on peripheral smear like schistocytes. I'm writing schistocyte. Marker of hemolysis. Okay, so hemolysis, elevated liver enzymes, low platelet count would be considered as HELP syndrome. It will be a case of severe preeclampsia. Okay, yeah, the story is not yet over. After HELP syndrome, then disseminated intravascular coagulopathy. If it is there, then she is a case of severe preeclampsia. Then premonitory symptoms. premonitory symptoms. Guys, girls, premonitory symptoms would be headache, blurring, headache, blurring vision, then epigastric pain. I am writing oliguria and cutting it out. Isolated oliguria is no longer a premonitory symptom. It has to have a combination of others. So I am writing oliguria and cutting it out so that you remember isolated oliguria is no longer considered as severe preeclampsia. Okay, headache because of cerebral artery vasospasm. Yeah, blurring vision, retinal artery spasm. Epigastric pain is due to hematoma in liver capsule. Hematoma in liver capsule. PP rays vessels may get ruptured and hematoma in liver capsule, or gastric bleeding can cause epigastric pain. Okay, so these are the premonitory symptoms, guys. So yes, if patient has premonitory symptoms, you will no longer label her as non-severe. She is a case of severe preeclampsia. Okay, now then, after premonitory symptoms, I am writing IUGR and I am cutting it out. IUGR is no longer a differentiating factor between severe and non-severe. Yeah. Guys, girls, whatever I am writing in severe preeclampsia, any one would be sufficient to label someone as a case of severe preeclampsia. Okay, got it? Very clear? Alright. Urine albumin assessment. I am writing it down and I am cutting it out. That is also no longer in the diagnostic classification of non-severe and severe. Okay, guys? Alright, guys. So you have written a table of severe preeclampsia. What will you write in non-severe? Very easy. In non-severe, you just have to write no, no, no. No BP is bad thing. Controlled BP is good thing. Controlled BP. It should be less than 160 and 110. It should be less than 160 and 110. No pulmonary edema. No ELP syndrome. Vomiting, guys, vomiting is removed from the premonitory symptoms. Though projectile vomiting is a kind of raised intracranial tension, but vomiting is no longer a premonitory symptom. Vomiting is so non-specific. It is there in pregnancy, but projectile vomiting was considered as premonitory symptom earlier. Now it is not there in the list. Yeah. DIC, no. Premonitory symptom, no. Okay. Everything, no, 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 no. Then she is a case of non-severe. See, urine albumin, whatever, will not define non-severe and severe. Okay. May it be urine albumin 2 plus or may it be urine albumin 4 plus. She could still be a case of non-severe. She could still be a case of severe, depending upon any other finding. Alright. All good? Good to go? Yes. After a diagnosis, we have made a diagnosis of non-severe and severe for a reason. We want to know what has to be done for the patient. Remember, non-severe preeclampsia, you have to continue pregnancy till 37 weeks. Yeah? Non-severe preeclampsia. There is nothing called mild preeclampsia nowadays because the terminology got abolished. There was something called mild and severe. Then people said, where is moderate? There is nothing called mild. It's now non-severe and severe. Okay. So continue till 37 weeks. Induction of labor at 37 weeks. Continue till 37, induction of labor at 37 weeks. Yes, any one would be sufficient for labeling some as severe preeclampsia. Okay, guys, girls, you have written about non-severe preeclampsia. Is there any role of antihypertensive drugs? Yes, antihypertensive drugs are given only when BP is more than or equal to 150 by 100. I'm writing or. Yeah, guys, antihypertensives are to be given, yeah, but only when BP is 150 by 100. Antihypertensives are double-edged sword, guys. Hypertensive drugs are double-edged swords. If you give antihypertensive drug, BP will fall further. The blood flowing to placenta will reduce further. So there is a chance of uteroplacental insufficiency if BP is, let's say, 140/90 and you have given antihypertensive. Don't bring it to 90 by 60. It will be more dangerous if you bring it to 90 by 60 than to keep it at 140/90. Okay, so antihypertensives are given if BP is more than or equal to 150 by 100. Drug of choice is none other than labetalol. Yes, you heard it right. Drug of choice, labetalol. Okay, drug of choice, labetalol. Then for severe preeclampsia, what for severe preeclampsia? Can we continue pregnancy? Yes, nowadays we can continue pregnancy till 34 weeks. I told you lung maturation 34 weeks is the answer. Continue till 34 weeks. Yeah, but you have to do something along with it. You will have to give anticonvulsant therapy. Anticonvulsant. Here drug of choice is none other than MgSO4, magnesium sulfate. You will have to give antihypertensive if BP is more than or equal to 150, more than or equal to 150 systolic, 100 diastolic, antihypertensive. Same, drug of choice, labetalol. Okay. Guys, girls, what is your question? Unattended or in loose? I did not understand that. Okay. So guys, I have said continue pregnancy till 34, anticonvulsant drug of choice magnesium sulfate, antihypertensive drug of choice labetalol. Yeah. Continue till 34 weeks. Induction of labor at 34 weeks. You try to terminate pregnancy at 34 weeks. Okay. Reach 34 weeks. Steroids are must in less than 34 week cases. Yeah, I told you even steroids are nowadays given beyond 34, but in severe preeclampsia, who is going beyond 34? Yeah, so we are terminating pregnancy at 34 weeks of gestation in severe preeclampsia. As simple as that. Okay. All right, guys. Management of gestational hypertension. Management of gestational hypertension. Same thing. Non-severe, severe. So I'm writing same as preeclampsia. You understood? Management of gestational hypertension would be same as preeclampsia. If she is a case of non-severe gestational hypertension, reach 37 weeks, induction of labor has to be done. If she is a case of severe gestational hypertension, reach 34 weeks, induction of labor at 34 weeks. Okay. This is what we do for gestational hypertension. We try to reach 34 and 37 weeks. Word of caution for chronic hypertension. First thing first, drug of choice is not labetalol. No. Drug of choice is alpha methyl dopa. Alpha methyl dopa, because it is slow acting, long acting drug. That's why for chronic hypertensive patients we prefer alpha methyl dopa. That's your answer for chronic hypertensive patients. Okay, and continue till 38 weeks. Induction of labor at 38 weeks. Induction of labor at 38 weeks. That is what has to be done for chronic hypertension. Alright? Chronic hypertension, 38 weeks, induction of labor. Okay. So after this, let us talk about eclampsia. Eclampsia is a generalized tonic clonic convulsion. It is due to CNS hypoxia due to hypoxia caused by vasospasm. So central nervous system has hypoxia. Hypoxia leads to hyperirritability and there is cerebral edema. Cerebral edema may be seen. So guys, eclampsia, it lasts. In eclampsia, the convulsion will last for 60 to 90 seconds. Okay. Eclampsia can be antenatal, more common than intranatal, more common than postnatal. Postnatal eclampsia, patient has delivered the baby, delivered the placenta, and after that she is convulsing. That means protocol. What is the management protocol of eclampsia? In eclampsia, we do first thing, we stabilize the patient with airway maintenance. In any resuscitation protocol, airway is the first thing which comes. Stabilize the patient with airway maintenance. This has to be done. Okay. How do you stabilize the patient? You give supine plus left lateral position. So make a light supine and left lateral tilt is to be given to the head or to the whole body. Left lateral tilt. What will be the advantage of giving left lateral tilt? Left lateral tilt will lead to drainage of secretions. There will be drainage of secretions. Tongue will not fall back. So it will not block the glottis. So airway would be maintained. Yeah. You have to prevent injury. Position is given, prevention of injury. Yeah. Guys, there is a possibility that she might have a tongue bite. So you have to maintain airway. You have to put a tongue depressor, mouth gag. Yeah, anything for maintenance of airway. You won't find a laryngoscope in your hand when she is convulsing in front of you. Understand this thing, whatever is there in your hand, tongue depressor, mouth gag, you put in the mouth and that would prevent the tongue bite. Yeah, believe me, tongue bleeds a lot and bleeding can block the glottis. So stabilize the patient, give stability and airway maintenance is to be done as a first step. Okay. Second thing is magnesium sulfate anticonvulsant therapy. We have to give anticonvulsant therapy. And we give magnesium sulfate by most common regime as Pritchard regime. Most common regime, Pritchard's regime. Now, Pritchard regime is made up of two parts: loading dose, maintenance dose. Loading and maintenance. Loading would be 4 gram IV plus 5 gram IM in each buttock. So 4 plus 5 plus 5, 14 gram is the loading dose. Yeah, 4 gram IV plus 5 gram in each buttock. Maintenance dose is 5 gram IM 4 hourly. Okay, 5 gram IM 4 hourly. Now, you know, if you worked in hospitals, if you have seen patients, you must have seen that ampule of magnesium sulfate could be of 5 ml or 2 ml. Yeah, let's say 2 ml ampule is there. Yeah, MgSO4. This 2 ml ampule is in the concentration of 50%. This is what is provided by pharmacy. Yeah, magnesium sulfate. 50% concentration fluid is there. That simply means 2 ml 50%. That means 1 gram ampule is there. Right? So there is 1 gram ampule present if it is 2 ml. 5 ml 2.5 gram is there. So 50% concentration ampule is there. So how many ampules would you pick up for IV? 4 ampules. And 10 for IM. 10 ampules you will pick up for IM injection. So 4 gram IV has to be given, but in 20% dilution. Yeah, 5 gram IM has to be given, but in 50% dilution, and thank God we already have 50% dilution. So for 10 ampules for IM, 5 for each buttock. No further dilution is needed by normal saline. You take 5 ampule, you have got 5 gram in 10 ml solution. Take a syringe, 5 gram in 10 ml, that means you have taken 5 ampules, and inject intramuscularly, deep intramuscular in gluteal region. Yeah, that you can't do in IV, because IV you need 20% dilution. How do you make a 20% dilution solution? If you have worked in hospital, you will be knowing this. You have to take 4 ampules. I am talking about 2 ml ampules. How much fluid you have achieved from 4 ampules? 8 ml. And there is how much magnesium sulfate in it? 4 gram. But then this is 50% dilution. I would add 12 ml of normal saline. Add 12 ml of normal saline. Wow, I have just now created a new solution of 20 ml, 8 plus 12, 20. And in this 20 ml, 4 gram magnesium sulfate is there. 4 gram in 20 ml. Congratulations, you have made a 20% dilution. Okay, so totally 20 ml solution is prepared. 8 plus 12 is equal to 20 ml. Give IV in 20 minutes. Slowly. Yeah, we have to give intravenous injection in 20 minutes. Alright? It sounds complicated, but it's very simple. Let me prepare the solution again, guys. I told you that Pritchard regime. Listen carefully, everyone. I will repeat it. Take a deep breath. Take a deep breath. Yes, baby is at station +5, about to deliver out. Push. Yeah, push. Madam, push. Yeah. Good. You have delivered the baby. Listen carefully. In Pritchard regime, listen, Pritchard regime, loading dose 4 gram intravenous. I will take a syringe, I will give 4 gram intravenous. But what should be the concentration? 20%. Simple maths. 4 gram concentration in 20%. 4 gram in 20% concentration means 4 gram in 20 ml. 4 gram in 20 ml is 20%. 4 of 20 is 20%. Yeah. So I have to make, ultimately I have to make a solution of 20 ml. How much solution did I get from ampules? That's why I have drawn ampule. Ampule has 2 ml. In each ampule there is 2 ml. So of 4 ampules I will get 8 ml. I will have to add 12 ml of normal saline. Congratulations. 8 ml from ampules and 12 ml from normal saline. I have created a 20 ml solution. And this 20 ml solution will get 20% dilution. Okay, those who have written just now that for preparing this thing, patient will get another conversion in this preparation, I would kill you, but I loved your sense of humor. Yeah, great. But this is just for your understanding. When you are in labor ward, when you are in emergency ward, all these things are known to you. You do so rapidly. Yeah, you must have seen your emergency ward. आओ कभी हवेली पे पता चलेगा. Come to KM Hospital Mumbai where I was assistant professor. Come to Sion Hospital Mumbai. You will realize. Yeah, delivery is nahi. आम गिरते आम पका पक. Babies, they deliver out anywhere, everywhere. Yeah, and at that time your rapid action is very, very important. Yeah, there are so many convulsing patients, and yes, you have to manage these patients. You have to save their lives. You have to create your protocol, which is obviously evidence based, and whatever I'm teaching you is a protocol for anticonvulsant therapy. Guys, girls, so do you think sister prepares it? Okay, somebody has written sister will prepare it. First and foremost, don't tell them sisters. Yeah, staff nurse is a better terminology for them. Oh, sister, please prepare. Why? What wrong she has done? She could be a potential whatever. Don't tell her sister. Otherwise you will become ignore. Somebody wrote sister over here. Alright. Take a deep breath. Magnesium sulfate, Pritchard regime. Jokes apart. I am stopping the jokes. Listen carefully. Very important. Had come in AIMS exam also. Guys, you should know this. 4 gram IV. 4 gram IV in 20% dilution. That means 8 ml from the ampule plus 12 ml. 12 ml from normal, 12 ml of normal saline. You have just now created a 20 ml solution. Okay? Yeah. 20 ml solution prepared. Congratulations. You have to give what? 20 ml in 20 minutes. You have to give very slowly. Is there need of diluting it more for IM injection? The answer is no. We already have 50% dilution from the ampule. You don't have to create more dilution. Yeah. So 5 gram IM. 5 gram IM is not to be diluted. It has to be given without dilution. I mean to say it's already 50% diluted. Okay, this is loading dose. Alright. Yeah, that's true. Somebody has written AB de Villers. Thank you. I love you. Yeah. Yeah, so maintenance dose 5 gram IM 4 hourly is to be continued. Now same protocol, 5 gram IM is in 50% dilution. Yeah, 5 gram IM, 50% dilution. And those who have suddenly realized that sir has become hyperactive now, my wife went to my mother-in-law's place, so I'm very happy. Okay, guys. So yes, 5 gram IM 4 hourly, 50% dilution is to be given maintenance dose till 24 hours. Till 24 hours post delivery, or conversion. Till 24 hours post delivery or conversion. Guys, stop typing. You people are becoming crazy. फरहान अख्तर की आवाज निकाल रहे हैं. Guys, stop typing. Yeah, thank you so much. Okay, these people will not stop typing. I said maintenance dose 5 gram till 24 hours post delivery or conversion, whichever is later, whichever episode is later. What do I mean by this? See, you have to understand that magnesium sulfate would be necessary even after delivery. For how many hours? 24 hours. But suppose if she has a conversion even after delivery, don't you think you will require more cover? And that more cover would be of 24 hours. Okay? So this protocol is called Pritchard regime. This is the most commonly used protocol in your hospital, in my hospital, everywhere. Second protocol is called Usmle regime or Mbbs regime. Usmle regime, Mbbs regime is just like Pritchard, just both the things are for same protocol. The names are same for same protocol. Loading dose 4 gram IV. Maintenance dose 1 gram per hour IV. So IV 1 gram per hour IV. How do you give IV? You know 1 pint of normal saline. One pint of normal saline is there. You add 5 ampules, which means 5 gram. Yeah, 5 gram is added in this and 100 ml per hour is to be given. Simple. No IM injection much, no IM injection jig. You just have to give IV for Usmle and Mbbs. But then remember this thing, that most commonly used regime is Pritchard. Okay? Alright. After you have written this, if you're wondering why not IV as most common, IV has to be, titrated and monitored. 100 ml per hour should go. If it is going very fast, then magnesium sulfate can cause toxicity. Remember, MgSO4. Yeah, MgSO4 is very toxic. What do I mean by very toxic? Small therapeutic window. Magnesium sulfate is having small therapeutic window. It is a window between 4 to 7 milliequivalents per liter. This is the window. This is the window where you have to work. Less than 4 doesn't work. More than 7 is toxic. Yeah. MgSO4 acts on NMDA receptors. Neurology, above umbilicus. For you and for me, NMDA receptors. Yeah. It is not acting as antihypertensive. It does not have antihypertensive role. No. It is responsible for increasing cerebral perfusion. Yeah. Yes, it's not acting as antihypertensive, but cerebral perfusion will improve. Okay. I said therapeutic window is 4 to 7 milliequivalent per liter. So that's why you need to monitor patients well. Monitor 3 things: DTR, urine output, and respiratory rate. Now some people will write, what is DTR? Yeah, for them. Deep tendon reflex. UO is urine output and respiratory rate. DTR, urine output, respiratory rate are to be monitored. Remember, DTR, blunt or absent, would be earliest sign of toxicity. I said DTR, blunt or absent, earliest sign of toxicity. You have to stop giving magnesium sulfate if there is absent DTR, blunt DTR, you have to stop. Urine output has to be more than or equal to 100 cc per 4 hours. Yeah? Urine output. Magnesium gets out of the body only through the way of urine. So if urine output is less, you cannot give maintenance dose. No, you can't. Give me 1 second. So urine output is less, you can't give magnesium sulfate. There will be toxicity for sure. So it has to be 100 cc, drainage has to be there, urine output should be there to give maintenance dose. Respiratory rate, remember, respiratory depression. Respiratory depression would mean RR less than 12. Yes, magnesium sulfate can cause depression of central nervous system, respiratory depression can be there, pontine paralysis can be there. So if you have reached this level called respiratory depression, you already missed out deep tendon reflex and urine output. Yeah, RR would change later on. Yeah, respiratory rate will fall down to less than 12 in respiratory depression. That means toxicity has happened. Give antidote. If there is respiratory depression, give antidote. And that antidote would be injection calcium gluconate. That antidote would be injection calcium gluconate. It has to be 1 gram IV, 10% dilution. Slowly, rapid calcium is also bad for heart. So remember, respiratory depression, give antidote, calcium gluconate. Blunt or absent DTR, omit further dose of magnesium sulfate. Yeah, once you omit it, the magnesium sulfate levels would become normal, and then you can again give it after 4 hours. Yeah, so that is why maintenance dose is every 4 hourly. Okay, got it? Very clear, guys. For your kindest information, we were talking about the management of eclampsia, and in management of eclampsia I was talking about protocol. And if you forgot, I will tell you again. Protocol started with step number 1, airway maintenance, stabilizing the patient. Step number 2 was what I wrote just now in details, anticonvulsant therapy. Then step number 3 is antihypertensive therapy. Antihypertensive therapy. Yeah, antihypertensive drugs are given. IV labetalol, IV hydralazine, IV nitroglycerin, IV sodium nitroprusside. Yeah, can be given in hypertensive emergencies. Mark my words, these things can be given in hypertensive emergencies. I will still pick up IV labetalol. Yeah, but labetalol, hydralazine, these are wonderful drugs. They control the BP very fast, very well. Yeah, remember, sublingual nifedipine is banned. Nobody gives sublingual nifedipine. IV diazoxide is not given, contraindicated. Then I have already told you ACE inhibitors are contraindicated in pregnancy. ACE inhibitors are never given. Yeah, and yes, diuretics are not given. Why? Because in eclampsia and hypertension already there is vasospasm and intravascular dehydration. Diuretics will reduce the fluid content of intravascular compartment and there will be further dehydration. Yeah, so diuretics are also not given. Okay, guys, this is step number 3, and the last step in the management of eclampsia is definitive line of management. Definitive line of management. Sodium nitroprusside, guys, it can cause, somebody has written, is it contraindicated in pregnancy? Sodium nitroprusside generally is not used routinely, but it's not contraindicated. It can cause, cyanide toxicity in very rare cases, but understand the values, the drug given should be given in very high levels. So sodium nitroprusside can be given, it's not contraindicated. Okay. Alright, definitive line of management is termination of pregnancy. Okay, I'll do one thing. I'll finish off definitive line of management, then I will summarize this. Okay, all good? Okay, definitive line of management, termination of pregnancy. Termination of pregnancy, remember that if patient is far away from labor, far away from delivery process. How do I know she is far away from delivery process? She has poor Bishop's score. There is one scoring system which we will cover in I'll be slow first. I'll cover this and then I will do the revision. Guys, poor Bishop's score, you do cesarean section. If patient is having good Bishop's score, you do induction of labor and vaginal delivery. I'll show you, don't worry. People have not written it, I guess. Induction of labor and vaginal delivery. First you finish off this thing. I'll finish off. Yeah, I'll complete this thing. Yeah, induction of labor and vaginal delivery would be done. Remember, epidural is must. Epidural analgesia is must. Okay, while you are inducing labor, epidural is to be given. Catheterization is must. When I say catheterization, obviously it's a urethral catheterization. You have to put Foley's catheter. Yeah, you have to put Foley's catheter. Continuous urine output and monitoring and management would be done. Then cut short second stage by instrumental delivery. Okay, I will go slowly, just write down this thing and then I will jump onto the summary, then you can finish off. Cut short second stage of labor by instrumental delivery and ergot derivatives are contraindicated. Okay, ergot derivatives are contraindicated. I'll for sure slow down. First you finish off this and then I will write. Okay. Don't pull my leg here. Somebody has written, please speed up, sir. We are getting bored. It's very slow. Yeah? Pulling my leg. Guys, I will now show you the summary of what I said. The revision, fast forward revision. Fast forward? Don't use the word fast. Okay. Tadan. Are you ready, guys? Listen carefully. Yesterday the speed was, I will be talking like this. And you are today feeling the speed is very fast. Probably that is the reason. Okay. Guys, listen. Step number one. Stabilize the patient with airway maintenance. That's the first thing you are going to do. I said stabilize the patient with airway maintenance. So supine position, left lateral tilt. Now instead of typing so fast, you can write fast. Stop typing, guys. Yeah, stabilize the patient, left lateral tilt, tongue depressor, mouth gag. You have to prevent injuries. Yeah, so she should be in secure cot with railings. You must have seen this in your labor ward. Patient is in secure cot with railings. So prevent injuries. She might fall down when she is having convulsion. Anti-convulsant therapy. I hope you have written Pritchard regime, which I wrote in details. Yeah. Pritchard regime. Loading dose 4 gram, 5 gram, 5 gram. Total 14 gram loading dose and maintenance dose 5 gram IM 4 hourly. Hopefully you have written this as well. Okay. Maintenance dose 5 gram IM 4 hourly till the time 24 hours are over after delivery or convulsion plus 24 hours. Yeah. Then I said there is another regime called Usmle or Mbbs regime, where loading dose is 4 gram IV, same protocol, same principle, 20% dilution, and the maintenance dose is this what I have drawn, 1 gram per hour IV. Okay, this is maintenance dose. Yeah, guys, magnesium sulfate is very toxic. I said small therapeutic window 4 to 7 milliequivalents per liter. That's why you monitor 3 things: deep tendon reflex, urine output, and respiratory rate. 3 things are to be monitored. If DTRs become blunt or absent, stop giving further magnesium sulfate. That's early a sign of toxicity. And yes, if urine output is less than 100 cc in 4 hours, stop giving further magnesium sulfate because it is getting accumulated in the body. Okay. DTR, urine output, respiratory rate. Respiratory rate less than 12 is a marker of respiratory depression. Okay, respiratory rate less than 12 is a marker of respiratory depression. So you have to give antidote called calcium gluconate. Antidote is calcium gluconate. 1 gram IV, 10% dilution. Okay. Then step number 3, antihypertensive therapy. Here again, labetalol is a drug of choice. Sometimes we need to give antihypertensive in IV regime, IV protocol, IV format, and those conditions would be hypertensive emergencies. And step 4, sorry. Step 4 is definitive line of management, which is termination of pregnancy. So poor bishop score, do cesarean section. Good bishop score, do induction of labor and vaginal delivery. Epidural is must. Catheterization is must. Instrumental delivery is must. Contraindicated would be ergot derivatives. Okay, got it? Chalo. After you have written these things, let us jump on to the next system. We have covered lot many medical disorders. Yeah. Okay. So the next system coming your way is respiratory system. Then we'll talk about urinary system and others. So let's talk about respiratory system now. This laptop has heated up, I guess. Okay. Guys, respiratory system, first thing first, I will write a formula over here. TLC is equal to RV plus ERV plus TV plus IRV. TLC is total lung capacity. RV is residual volume. ERV is expiratory reserve volume. TV is tidal volume. And IRV is inspiratory reserve volume. Yeah. So this is the formula for, where it is gone. This is the formula for respiratory system. Have a look at this. See, our lungs are made up of 4 volumes. What we are doing right now is inspiration and expiration. That is called a tidal volume. If I throw all the air from my lungs, that would be expiratory reserve volume. What will be left behind is residual volume. And if I do exercise, if I do deep breathing, then the answer would be inspiratory reserve volume. I use inspiratory reserve volume when I do vigorous exercise, IRV. Yeah. So I will draw one diagram. So this is non-pregnant patient, thoracic cage, pregnant patient. See the subcostal angle. Yeah, subcostal angle has changed because of the diaphragmatic pressure. Now diaphragmatic pressure will change the subcostal angle to obtuse. Yeah, it was acute, it has become obtuse. Chest diameter has also increased. There is a pressure effect on the diaphragm. So what should happen to total lung capacity? TLC would fall down. Because there is pressure effect, TLC reduces by 200 ml. Okay. So total lung capacity reduces. Now, thankfully this 200 ml is going from residual volume. Residual volume reduces by 200 ml. Yeah. So, not great loss has happened. Residual volume has fallen down by 200 ml. If you see pregnant patients, they have deep breathing. So tidal volume is increased by 150 ml. Yeah, it's an effect of progesterone. This is progesteronic effect. Tidal volume is increased in pregnancy. I will write below TLC and RV pressure on diaphragm. Pressure on diaphragm will reduce total lung capacity and residual volume. Tidal volume will increase by 150 ml. And yes, this 150 ml will be taken up from expiratory reserve volume. Expiratory reserve volume will fall by 150 ml. And last volume called IRV is constant. Yeah, IRV remains constant. So this is what is the ultimate change in respiratory system. All the volumes in front of you, all the changes in front of you. Total lung capacity falls, residual volume falls, tidal volume increases. One volume which doesn't change is inspiratory reserve volume. Yeah, guys, I have written these things. Now I will combine these things in a different way. What is combination of tidal volume and inspiratory reserve volume called as? TV plus IRV. Let me see in chats. Yes, TV plus IRV. What is it called as? Guys, TV plus IRV is called as what? Okay. TV plus IRV is called as inspiratory capacity. Yeah, I see. Yes, fantastic. Inspiratory capacity. What should happen to inspiratory capacity? Inspiratory capacity increases by 150 ml. Okay. Now I will combine one more thing. What is ERV plus TV plus IRV? Oh, come on, this is very simple. ERV, TV, IRV. What should be the combination called? ERV, TV, IRV. It's called, yes, vital capacity. Vital capacity. VC. Okay, vital capacity should remain constant. You can see ERV is falling by 150, TV is increasing by 150, and IRV is constant. So vital capacity should remain constant in pregnancy. Okay. What is combination of RV plus ERV? RV plus ERV is called, yes, RV plus ERV. This is called as functional residual capacity, FRC. FRC decreases a lot. It decreases by 350 ml. Yeah, guys, functional residual capacity decreases by 350 ml. So hopefully you understood this. TLC, residual volume, ERV, TV, IRV. Okay, functional residual capacity decreases dramatically. Now see, imagine functional residual capacity is high in asthmatics. It is low in pregnancy. So carbon dioxide levels will be high or low in pregnancy. Blood carbon dioxide levels would be less in pregnancy. The air entrapped inside lungs would be less. So blood CO2 levels would be decreased. Tidal volume is increased. So obviously blood oxygen is increased. Blood O2 is increased. Okay. Question is, why do all these things happen? This is a question by a person who is highly frustrated. Why do all these things happen at first place? Wow, I love you. Yeah, guys, girls, these are the physiological changes in pregnancy. Okay. Yes, I am telling you the facts which are asked in exam. You take up papers, you will see these questions are asked, and you always tend to forget because you have not understood the concepts. So functional residual capacity decreases by 350 ml. Okay. Yes, blood CO2 falls, blood O2 increases in pregnancy. So guys, blood oxygen levels increase, blood CO2 levels decrease. Whenever blood carbon dioxide levels are decreased because of respiratory effort, this would lead to what? Respiratory alkalosis. There will be respiratory alkalosis. Yeah, but then because of this respiratory alkalosis, kidneys will take revenge. Kidneys will try to throw out bicarbonates. So blood HCO3, serum bicarbonate levels will reduce. This is called as compensatory. Okay, I'll give you a break. Don't worry. Just now we took break 1 hour back. Compensatory metabolic acidosis. Yeah. So my dear friends, there is respiratory alkalosis and compensatory metabolic acidosis. So pH remains in normal range. pH is maintained in normal range. Blood CO2 is increased. Blood CO2 is decreased because air entrapped into lungs is less. Less air entrapped in lungs would be less carbon dioxide in lungs. Blood carbon dioxide levels would be less. Carbon dioxide would be thrown out. Respiratory washout, carbon dioxide is thrown out. Oxygen levels are increased, carbon dioxide levels are thrown out. Yeah? Respiratory rate remains constant. It doesn't change in pregnancy. One of the very few things which do not change in pregnancy. Yeah? Respiratory rate remains constant. But respiratory rate into tidal volume is something called as minute ventilation. Minute ventilation is increased in pregnancy. Okay? Minute ventilation increased because tidal volume is more. Alright? Guys, girls? So, you have written about the bicarbonate levels, you have written about alkalosis, you have written about acidosis, you have written about pH in normal range. When HCO3 levels decrease, then there is something called Bohr's effect. Because of that, oxygen binding capacity increases. Carbon dioxide levels will fall because of, there is deep breathing, so oxygenation is more, air entrapment is less, so carbon dioxide levels would be less. Bohr's effect would occur and oxygen binding capacity would increase. The word is binding. Earlier I told you something about oxygen carrying capacity. Oxygen carrying capacity is decreased because oxygen carrying capacity is dependent on hemoglobin concentration, and hemoglobin concentration falls in pregnancy. Alright? Okay. Somebody is asking weird question. I'll kill you, Abhishek. Yeah. Binding capacity increases. Okay, all these good things are happening in pregnancy. These are respiratory changes in pregnancy. Alright, guys. So, after you have written about respiratory changes, I'll take one system and then we will proceed to break. Guys, the system is urinary system. Urinary system. Yeah. Urinary system, you write down. Renal blood flow. Renal blood flow is increased by 80%. Obviously, cardiac output is increased, so renal blood flow has to increase. Glomerular filtration rate is also increased because renal blood flow is increased. Yeah? Because of this, all bad products will get out of the body. So, serum creatinine, blood urea will decrease. Okay. Then because of progesterone, there will be bilateral hydronephrosis. Progesterone is a smooth muscle relaxant. So there is hydronephrosis on both sides. Smooth muscle relaxant action of progesterone. Yeah. Progesterone causes bilateral hydronephrosis. Right hydronephrosis is more than left hydronephrosis. Now, why this direction preference, right hydronephrosis more than left? Because uterus is dextro-rotated. So distended, enlarged uterus, dextro-rotated uterus, it will shift to the right hand side and it would put pressure on right ureter. Right ureter pressure. Yeah. So there will be pressure on right ureter That is why there will be right hydronephrosis more common than left hydronephrosis. Okay, so if you get a question, cause of bilateral hydronephrosis, the answer would be progesterone. Cause of right hydronephrosis, the answer would be pressure. Okay, then understand that most common UTI in pregnancy is E. coli infection, and most common organ involved is bladder. Cystitis by E. coli. Most common UTI in pregnancy is by E. coli. Most common organ involved is bladder. Yeah, bladder muscular hypertrophy is normal in pregnancy. Bladder muscular hypertrophy is normal in pregnancy. Okay, why uterus is dextro-rotated? Come on guys, you must have seen pregnant patients. I'm very sure you must have examined the patients. If you're not, listen to me. Uterus is increased in size and it falls on the right side because there is a colon on left side. Colon does not provide space over there, so it falls on the right side. Distended uterus falls on the right side and it puts pressure on the right side. Okay, that is why you always correct the dextro rotation before examining the patient. Okay, so you written most common UTI E. coli, most common organ involved bladder. Then you write down antibiotics. Antibiotics safe in pregnancy. Number 1, nitrofurantoin, 100 mg BD for 7 days is the treatment of choice. Nitrofurantoin for UTI cases. Number 2, penicillins. Number 3, cephalosporins. Number 4, macrolides. Yeah, penicillin, cephalosporins, macrolides. Nitrofurantoin is the preferred drug for UTIs in pregnancies. Yeah. If you are dealing with chlamydial infection, if you get a question about chlamydia, drug of choice for chlamydia in pregnancy, the answer would be azithromycin. So chlamydial infection, you give azithromycin. Drug of choice for Neisseria gonorrhea. Neisseria gonorrhea. Gonorrhea. No. Gonorrhea. Drug of choice for Neisseria gonorrhea would be cefixime or ceftriaxone. Cefixime in your hospital you will see monocef drug, ceftriaxone. Yeah, cefixime, Zephy, brand names. Okay, you remember cefixime and ceftriaxone for Neisseria gonorrhea. Yeah, drug of choice for anaerobic infection. Drug of choice for anaerobic infection is none other than metronidazole. Metronidazole. Safe in pregnancy? Yes, safe in pregnancy. Example, bacterial vaginosis. Bacterial vaginosis, you give metronidazole in pregnancy, no problem. Yeah, guys, so bacterial vaginosis, metronidazole, safe in pregnancy. Alright, this is about the UTI. Remember, asymptomatic bacteriuria, that means more than 10⁵ count, should always be treated by antibiotics. What I have written? Asymptomatic bacteriuria, always be treated by antibiotics. You give nitrofurantoin, be safe, be secure. Asymptomatic bacteriuria, if untreated, can cause preterm labor, pyelonephritis. So we don't want those things. We have to give antibiotics because patient is pregnant. Asymptomatic bacteria will also require antibiotic therapy. Alright guys, so yes, we have covered urinary tract. I'll now take a break. I'll come back in 15 minutes. (17:55 p.m.) And don't ask further breaks after that. 9 o'clock, till 9 o'clock we will continue. Okay, we have to cover 1 hour more from yesterday's lag. So 17:55, come back fast. Thank you. Okay, fine, thank you. Yeah, so guys, we have covered quite a few topics. We have just now covered respiratory and urinary system and UTI and pregnancy. Then I will talk about the gastrointestinal system. Yeah. No more break, yeah, no more break, yes. But I can't help it, yeah. There's an issue with booting and rebooting. Yeah, finally. Okay, so guys, yes, I'm back. Okay, so my dear friends, we have covered a system called respiratory system, urinary system. Then we'll talk about gastrointestinal system, and there'll be so many clinical cases. Related with gastrointestinal system. Please write down that gastric motility is decreased but only in labor, not in antenatal care, not in ANC. Yes, I know which topics are pending. I know the topics. Yes, we will cover all the topics, don't worry. We will try to manage today and tomorrow, and we will definitely cover it, my promise to you. So guys, nothing will be missed out, don't worry. Gastric motility is reduced only in labor, not in ANC. Lower esophageal sphincter is relaxed. Everyone write down please. Lower esophageal sphincter is relaxed due to progesterone effect. Okay. LES, relaxed due to progesterone effect. Gastric motility is reduced only in labor, not in ANC. No change in antenatal care. Then gallbladder motility is also reduced, again due to progesteronic effect. Yes, gallbladder motility is reduced due to progesteronic effect. Then gallbladder stones would be increased, or chances would be increased due to estrogenic effect. Yeah, gallbladder stones increased, or chances are increased due to progesteronic effect. Guys, vomitings are increased. Vomitings are common in the first trimester. Most emetogenic hormone is HCG. human chorionic gonadotropin. Write down. Sincere students, please write down. Most emetogenic hormone is HCG. Now, with this knowledge in mind about lower esophageal sphincter, gallbladder and vomitings, let us talk about case number 1 in GI system, emesis gravidorum. Now, what is emesis gravidorum? It's physiological vomiting. Yeah, physiological vomiting. It is seen in first trimester. Yeah, maximum at 10 weeks. Emesis gravidorum seen in first trimester, maximum at 10 weeks. Primigravida more than multipara. Primi more than multi. Okay. Emesis gravidorum. It is a condition where patient doesn't tolerate liquids. So if liquids are not tolerated, no problem. We will give dry diet therapy. Dry diet therapy. Okay. If necessary, then doxylamine plus pyridoxine or hyoscine. I said you give dry diet therapy because liquids are not tolerated. She will be a patient in OPD. She will not be admitted. She is having vomiting in pregnancy. It's such a common symptom in pregnancy. It's called, it's such a common thing that it is called symptom in pregnancy and symptom of pregnancy. Yeah. So doxylamine plus pyridoxine can be given, hyoscine can be given as treatment modalities, but dry diet therapy usually is sufficient treatment. Emesis gravidorum. Yeah. You remember doxylamine, antihistaminic drug. It is very useful in vomitings in pregnancy. Yeah. Anticholinergic drugs are also useful. Okay. So this is the treatment modality for emesis gravidorum. Then is another case called as hyperemesis gravidorum. Hyperemesis gravidorum, which means excessive vomitings affecting vitals. Excessive vomitings affecting vitals. Her pulse is affected, her BP is affected. Can you hear me, guys? Can you hear me? Visible, audible? Yes, finally. Mwah. Love you all. Guys, so I was talking about the topic called emesis and hyperemesis, and I was reading your chats, and yes, some interesting chats that why dry diet therapy in vomitings in pregnancy, why not liquids? Patient is vomiting, so she should get more liquids. I told you lower esophageal sphincter is relaxed. Yeah, when lower esophageal sphincter is relaxed, liquids are not tolerated, liquids are thrown out. She will drink water and everything out. But when dry diet therapy is given, that will be retained by her stomach. And this is called a morning sickness. Yeah, emesis gravidorum is called morning sickness. Once there is morning sickness, there is vomiting in morning. After that, she is all fine throughout the day. Yeah, so avoiding liquids, not throughout the day, but avoiding liquids in the morning. That's the plan of action for a case called as emesis gravidorum. Then I was talking about hyperemesis gravidorum, excessive vomitings affecting vitals. Who all are at risk of developing hyperemesis gravidorum? It's a disease of primigravida again. Multifetal gestation. Molar pregnancy. Multifetal fetal gestation, yes, things will be covered in postpartum period. That would be covered. Peripartum cardiomyopathy will be covered in postpartum chapter. Yeah. Multifetal pregnancy, primigravida, multifetal pregnancy, molar pregnancy, Down syndrome, then RH incompatibility, yeah, these are the risk factors for developing hyperemesis gravidorum. Okay, she has so much of vomiting that she has become dehydrated. So clinically, how will you get this patient? You will get this patient, she is dehydrated. She has ketoacidotic breath. Okay. Number 3 would be, there will be electrolyte imbalance, so potassium deficiency may be there. Multivitamin deficiency, that means vitamin B and C deficiency will be there. Water soluble vitamins are less in body. She is having chronic vomiting, she is having vomiting which is causing water soluble vitamin deficiency. Then very rare cases, liver, renal damage would be there. Rare, very rare. Yeah. So these are the things related with clinical features of hyperemesis gravidorum. Okay. Treatment wise, you have to admit these patients. Admit. Surprisingly, admission itself can cure this because of change in environment. So admit these patients. Give IV fluids. Yeah. Keep them nil by mouth. Nothing per oral. Nil by mouth. Whatever they are taking, they are throwing out. So don't give them orally. Give them IV fluids. Give them potassium supplement. Give them antihistaminic. So promethazine, silamine, pyridoxine, all these things are given. If nothing works, then ondansetron. Okay? Yeah. Guys, this is about hyperemesis gravidorum. Then there is another case called as intrahepatic cholestasis of pregnancy. IHCP, intrahepatic cholestasis of pregnancy, IHCP. Now, intrahepatic cholestasis of pregnancy is second most common cause of jaundice in pregnancy. Okay, second most common cause of jaundice in pregnancy, IHCP. It is due to decreased bile flow caused by dilated biliary canaliculi. Dilated biliary canalicular system would be there and decreased bile flow would be there. Okay, because of decreased bile flow, there would be increased alkaline phosphatase. You know, alkaline phosphatase is directly related with congestion. If the flow of bile is affected, then alkaline phosphatase will be very high. But this is non-specific marker. Okay. SGOT, SGPT are increased mildly. It's not a case of liver damage. So SGOT, SGPT will be increased mildly, but never more than 250 international unit per liter. Yeah, I have written reduced bile flow. That's why it is called intrahepatic cholestasis. Alkaline phosphatase is raised, SGOT, SGPT minimally raised. Bilirubin is increased but never more than 5. Bilirubin is increased but never more than 5. So yes, icterus, mild icterus can be there. Yes, remember this thing, it's second most common cause of jaundice, but it's not more than 5 ever. Okay, bilirubin is mildly raised. Then most common symptom. Most common symptom would be itching. That's why this is called as pruritus of pregnancy. Yeah, I said bilirubin is mildly raised, SGPT mildly raised. Most common symptom is itching. Why is she itching? Why is she having itch? Serum bile acids are increased. Yeah, serum bile acids are increased. Now serum bile acids are increased, agreed. This serum bile acid test is most specific test for IHCP. Okay. Serum bile acids are increased. Bile will get deposited below the skin and then there will be histamine release and itching. Okay. Pruritus of pregnancy. Now, guys, drug of choice is ursodeoxycholic acid. This is the drug of choice, UDC. Ursodeoxycholic acid, UDC. This is well known that ursodeoxycholic acid will reduce the bile acids and the symptoms would reduce and the complications would reduce. Okay. Now, IHCP can itself cause meconium stained amniotic fluid. IHCP can cause fetal distress. So it's better if there is IHCP patient, you do termination of pregnancy by 37-38 weeks. Underline 37. Terminate pregnancy by 37-38 weeks. Don't go beyond that. We don't want fetal distress unnecessarily. So if there is IHCP, 37-38 week would be the deadline for termination of pregnancy in IHCP. Okay. This is our case number 3. Then is case number 4. Case number 4 is AFLP. What is AFLP? Acute fatty liver of pregnancy. Acute fatty liver of pregnancy. It is most common cause of liver failure in pregnancy. Yeah, acute fatty liver of pregnancy is the most common cause of liver failure in pregnancy. What is this condition actually? Acute fatty liver of pregnancy is also called yellow necrosis. AFLP is called yellow necrosis of liver. Why yellow necrosis of liver? There is collection of fatty acids in liver because of defect in metabolism of long chain fatty acids. So there is a defect in metabolism of long chain fatty acid. There is one enzyme called LCHAD. Yeah, LCHAD enzyme defect. Yeah, defect in metabolism. Now, long chain fatty acid metabolism defect is there, and yes, there is accumulation of long chain fatty acid in the liver causing yellow necrosis of liver. So if there is yellow necrosis, remember there is liver damage. So SGOT, SGPT would be very highly raised, more than 250 international unit per liter. Bilirubin will be very high. Which bilirubin? Conjugated plus unconjugated. Because there is liver damage, conjugated and unconjugated both. As compared to our previous case, where bilirubin was high, but this was conjugated bilirubin. Guys, we have talked about 3 cases. Now we are talking about 4th case, acute fatty liver of pregnancy. Listen carefully. So there is enzyme defect of long chain fatty acid metabolism, and there is accumulation of long chain fatty acid in liver, and that's why there is yellow necrosis of liver. Okay, when there is yellow necrosis of liver, there will be liver damage. Liver damage will lead to raised bilirubin, raised SGOT, SGPT. This condition is seen most commonly between 30 to 38 weeks. Remember, liver disorder is commonest in 3rd trimester. Liver disorder is commonest in 3rd trimester. Now understand this thing, that the culprit is pregnancy. This is caused by pregnancy. Yeah, the long chain defect, it is said that long chain fatty acid defect is in the fetus, and the byproduct will get accumulated in mother. This is one theory. And once the baby is delivered out, mother becomes normal. Okay, so seen most commonly between 30 to 38 weeks. Then remember that immediate termination is must. Immediate termination of pregnancy is must. We cannot continue pregnancy. It is a threat to mother's life. Mother is more important than baby. So immediate termination of pregnancy is must. Alright? You have to give liver support. My dear friends, when liver is not working well, you have to do the job of liver. So high carbohydrate diet, low proteins, low fat, injection vitamin K, high carbs, low proteins, low fats, injection vitamin K, lactulose or neomycin enema. Remember that we want to prevent something called as hepatic encephalopathy. If liver is not working well, ammonia will get increased. When ammonia increases, there will be hepatic encephalopathy. Lactulose neomycin enema will decrease ammonia levels in body. And it prevents, this enema prevents hepatic encephalopathy. Okay, so yes, you have written about liver support. I'll revise. Guys, what am I talking about? A topic called as acute fatty liver of pregnancy. Most common cause of liver failure in pregnancy. It's a very rare disease. Very rare. 1 in 30,000 pregnancies. Very rare. Yellow necrosis of liver would be there. It's a defect in enzyme defect in long chain fatty acid metabolism. Liver is damaged, so bilirubin is raised. Commonly seen between 30 and 38, and no chance of wait and watch policy. At least in IHCP, intrahepatic cholestasis, we waited till 37 to 38 weeks. Here there is no chance of waiting and watching. We have to terminate pregnancy. Okay, don't forget, liver support is must. High carbs. Why high carbs? Because patient has hypoglycemia, so carbohydrate should be more. Proteins form ammonia, so low proteins would reduce ammonia formation. Fat, understand, when liver is not working well, fat should be less in diet. Yeah, fat soluble vitamins. Understand, fat absorption is affected if liver damage is there. Injection vitamin K deficiency is there, and then bleeding disorders can be there. So yes, we should give injection vitamin K intramuscularly to these patients. This is what is a case of acute fatty liver of pregnancy. Alright, guys and girls, I would now like you people to write down case number 5, viral hepatitis in pregnancy. Viral hepatitis in pregnancy. Viral hepatitis. Most common viral hepatitis would be hepatitis B. This is most common viral hepatitis. Understand this thing? Then it is chronic hepatitis. We know that. Most common hepatitis B in pregnancy. That's why all pregnant patients are screened for hepatitis B. Then after hepatitis B, then worst viral hepatitis would be hepatitis E in pregnancy, because it causes fulminant hepatitis. Fulminant hepatitis. I am talking about obstetrics, not medicine. In medicine, the answer may be different. It could be D or a combination of B and D. The answer here is hepatitis E. Yeah, pregnancy, worst viral hepatitis, fulminant hepatitis is most commonly seen in hepatitis E. Yeah. Hepatitis B, hepatitis C, hepatitis D can cross placenta. Yeah, Hep B, Hep C, Hep D can cross placenta. Now, is HBsAg vaccine safe in pregnancy? Yes, HBsAg vaccine is given to exposed patients. Yeah, in pregnancy. So HBsAg vaccine is safe in pregnancy. 0, 1 month and 6 month protocol, same as in non-pregnant patient. Yeah, guys, girls, HBsAg vaccine is safe in pregnancy. Virus can cross placenta. If she gets infected, then there is no need of HBsAg vaccine. If patient is HBsAg positive already, she is having chronic hepatitis B, then do HBeAg. We have to do hepatitis B envelope antigen test. This is HBeAg, envelope antigen. Yeah, HBeAg, envelope antigen. And yes, it's marker of infectivity. Marker of infectivity and transmission. Yeah, HBeAg, marker of infectivity and transmission. Now, patient is hepatitis positive, HBsAg positive. Can she breastfeed her baby? Yes, breastfeeding is not contraindicated in any viral hepatitis. Breastfeeding is not contraindicated in any viral hepatitis case. So I said, if HBsAg is already positive, do HBeAg. It's marker of infectivity and transmission. Yeah, breastfeeding is not contraindicated. What drug should be given for a patient who is HBsAg positive, HBeAg positive? Drug of choice for hepatitis B. Earlier the answer was lamivudine, now the answer is tenofovir. Yeah, the answer has been changed to tenofovir now. Okay. Yes, drug of choice is tenofovir. Breastfeeding is not contraindicated in any viral hepatitis. Baby should receive active plus passive immunity. So baby should be given active immunity and passive immunity. So HBsAg vaccine plus HBIG, hepatitis B immunoglobulin. Okay, drug of choice is tenofovir. Okay, so yes, this is about hepatitis. Guys and girls, we have written down this as case number 5, viral hepatitis. I hope you have written down instead of typing down. Worst one is hepatitis E in pregnancy. I am talking about pregnancy, hepatitis E. Worst one. Yeah, most fulminant hepatitis will be seen in hepatitis E in pregnancy. Medicine people have different answer for non-pregnant patient, but in pregnancy 20% mortality is seen with hepatitis E. Yeah, so for most fulminant hepatitis E. Hopefully you have got this, guys. So after you have written this as case number 5, let's talk about case number 6. HIV in pregnancy. Yeah, mode of delivery won't change. Cesarean section would not be done for the sake of hepatitis B. Guys, so those who have asked, mode of delivery in hepatitis B, it's not an indication of cesarean section. We can conduct vaginal delivery for sure in hepatitis B. Let's talk about HIV now. Yeah, HIV. First thing first. Recently, the protocol has been changed. All HIV patients, all pregnant HIV patients should be given ART. Yeah, all pregnant HIV positive patients are given ART. Okay, slow, I am going slowly, no problem. In already exposed patient, the question is already exposed patient, hepatitis B question. Give me 1 second, I'll go to hepatitis B. I said if patient is exposed doesn't mean she is having hepatitis B. Some blood contact has happened, that is exposure. When there is a needle stick, you are exposed. Understand this thing, that doesn't mean you have become a hepatitis B positive patient. Okay, so remember, vaccination is important. Vaccination is not necessary if patient is already a known proven case of hepatitis B, HBsAg positive. Okay, come back. Hopefully your doubts are clear. Yeah, HIV in pregnancy, all HIV positive patients give ART. Yeah, those who are thinking why HIV is going on in GIT, I was talking about viral hepatitis, that's why I am finishing HIV, then we will talk about another topic. GIT is already over. This is HIV in pregnancy. All HIV positive patients give ART. ART to be given is TLE. Tenofovir, lamivudine, efavirenz. Tenofovir, lamivudine, efavirenz. TLE. Okay, I hope you are on track. Tenofovir, lamivudine, efavirenz to be given to all pregnant HIV positive patients. From when? From first visit. For how long? Lifelong. Yeah, this is what is the latest update protocol for ART in pregnancy. All HIV positive patients give ART. Okay. Yeah. So first visit onward, yes, you have to give ART lifelong. Okay. Yeah. Right, guys, girls. So from first visit, give lifelong ART. Then understand this thing that HIV is not an indication of cesarean section in India. Indian guideline, as per National AIDS Control Organization, HIV is not an indication of cesarean section in India. This is proven fact that cesarean section has less chance of maternal to child transmission. Mother to child transmission is less with cesarean section. This is known fact. But then we are giving ART right from the first visit, and yes, we are giving lifelong, right? So viral load, we are already bringing it down. Why are we giving ART? Why cesarean section? As cesarean is not the plan of action for HIV positive. Try to understand this. If patient is on ART, risk of parent to child transmission, mother to child or parent to child transmission is 1 to 2% only. Remember these lines, Risk of parent to child transmission 1 to 2% only if patient is already on ART. And 1% and 2% are also important. 1% if patient has given, in fact, if patient has not given breastfeeding, and 2% if patient has given breastfeeding. So understand, there is not much difference between breastfeeding and no breastfeeding. That's why in India, breastfeeding is not contraindicated in HIV positive patients. Yeah, so she can breastfeed her baby. The risk is technically nearly the same. 1 to 2% is the risk when patient is already on ART. Okay, so we have to give ART from first visit, and yes, the viral load will come down to very less. Remember, in developed countries, viral load more than 1000 copies per ml is an indication of elective C-section. HIV is not an indication of MTP also. HIV is not an indication of cesarean also. In developed countries, viral load more than 1000 copies per ml is an indication of elective cesarean section at 38 weeks. This is for developed countries. Okay? Guys, girls, so in developed countries, viral load more than 1000 copies, indication of elective cesarean section at 38 weeks. Okay. Now, we are conducting vaginal delivery. So, vaginal delivery protocol, remember, artificial rupture of membranes, is contraindicated. Yeah, artificial rupture of membranes contraindicated. Instrumental delivery contraindicated. Invasive fetal monitoring contraindicated. Yeah. Somebody has asked, sir, what about rich people in India? Understand this thing, that we are giving ART for rich, poor, middle class, everyone. Yeah. We don't do cesarean section for rich and vaginal delivery for poor people. Not at all. It's not dependent on that. So our protocols are based on NACO guidelines. Okay. Yeah. Artificial rupture of membranes, contraindicated. Instrumental delivery, contraindicated. Invasive fetal monitoring, contraindicated. Episiotomy is to be avoided. Avoid giving episiotomy, because if you give episiotomy, the blood which will come out will be in contact with baby's mucosa, eye, etc. So that may cause transmission of HIV. So episiotomy is to be avoided. Yeah. Oxytocin is given to increase speed of labor. Okay, oxytocin is given to increase speed of labor, so that time duration of labor is reduced and risk of transmission is reduced. If you get a question, maximum risk of transmission is during labor. Maximum risk of transmission is during labor. Okay, guys, girls, baby should receive nevirapine prophylaxis. Yeah, breastfeeding is allowed, but baby should receive protection, nevirapine prophylaxis, for 6 weeks. Yeah. Invasive fetal monitoring. Have you heard about fetal scalp blood monitoring? We don't do it in India, but remember this thing, any invasive procedure which can cause mixing of fetal and mother's blood is not allowed. Okay, I hope your question is solved. Okay. Baby should receive nevirapine prophylaxis for 6 weeks. The dose is 2 mg per kg. Okay. Now there are 2 exceptions over here. Exception, or it can say exceptional treatment. So if patient has already taken nevirapine in past, so don't you think her HIV virus will be resistant to nevirapine? Yeah. HIV will be resistant to nevirapine. Baby will not receive protection by nevirapine. So you will have to replace nevirapine by zidovudine. Replace nevirapine by zidovudine. This is to be given to the baby for 6 weeks. Baby should receive zidovudine prophylaxis for 6 weeks. This is one exception. Okay? Yeah. Then second exception, is if patient has taken ART, antiretroviral therapy, in antenatal period. If patient has taken ART in antenatal period for less than 4 weeks. So this is a special scenario when patient came late in our clinic. We did HIV testing and she was found HIV positive. ART was given, but she delivered in, let's say, 2 weeks. ART was given and she delivered in less than 4 weeks. Then don't you think viral load will be very high? Then baby should receive more protection. You will have to replace 6 weeks. Replace 6-week treatment by 12-week treatment. So treatment would remain same, nevirapine, but protocol would be for 12 weeks. The treatment would be for 12 weeks. Baby should receive protection for 12 weeks. Is HIV testing compulsory for pregnant patient? Are you supposed to do HIV for all pregnant patients? What if they say no? Do they have right? Do they have right to say no? Yes. it is done only if patient agrees. It is called as opt-out method. What do I mean by opt-out method? Opt-out method says if patient disagrees, don't force testing. She can opt out of the testing. Yeah. We will manage the patient as all other patients, but understand she will be told that testing would improve the chance of prevention of parent to child transmission. Yeah, if she is HIV positive. So yes guys, universal safety precautions are taken for all patients, not only for HIV, for all patients we have to have protection for ourselves while we are conducting delivery. Okay, so opt-out method is followed. Patient has full legal right to say no, we don't force HIV testing. Alright guys, so this is all about the topic called HIV in pregnancy. Okay, let us now talk about next topic called as antenatal care. The next topic is antenatal care, ANC. Yeah. So my dear friends, big topic coming your way, antenatal care. Okay, give me 1 second. Okay, the topic is antenatal care. So we will start with antenatal visits. Antenatal visits. Antenatal visits. How many visits are considered as minimum antenatal visits? The answer is 4 in India. But as per WHO, the answer is 8. Yeah, minimum antenatal visits are 4 in India and 8 as per WHO. Okay. Yeah. Now, ideal antenatal visits. Ideal antenatal visits should be roughly 10 to 14. Yeah. 4 in India, 8 as per WHO. I hope you got my point. 10 to 14 would be ideal figure, which would be monthly till 7 months, twice a month till 36 weeks. So till 28 weeks you have to call her up monthly, twice a month till 36 weeks, weekly after 36 weeks. Yeah, guys and girls, so monthly till 7 months, twice a month till 36 weeks, weekly after 36 weeks. So 6 visits over here, 4 over here, 4 over here. Monthly till 7 months will be 6 visits. She won't come to you when she has had LMP. She will come to you when she has missed period. So 6, 4, 4, 14. Okay, guys, girls, this is how ideal is calculated. The patient may deliver at 37 week, 38 week, 39 weeks. So figures would change, but the best answer for ideal is 14. Okay. Now, after you have written antenatal visits, then you write down Naegeli's formula, also called Naegeli's rule. What is Naegeli's formula, Naegeli's rule? First day of last menstrual period, plus 9 months 7 days would be equal to EDD. I'll draw a timeline. Again, same timeline, 1st January, Kulumulu on 14th January. She became pregnant on 14th January. There was fertilization. So when will be her EDD? Expected due date or expected date of confinement, expected date of delivery. Yeah, that's what is written in textbook. It would be 9 months 7 days to 1st January. It would be 8th of October. Yeah, I will tell you trimesters. First you write down Negley's formula, guys. 1st January to 14th January. This is the 14th January. This is the day of fertilization, and then 38 weeks more would fetch you 8th of October, which is 40 weeks. So LMP plus 9 months 7 days is actually 40 weeks. How 40 weeks? 9 months 7 days would be 9 English months and 7 days. 40 weeks would be 10 lunar months. Yeah, 10 lunar months, which would be 280 days. 40 weeks, 280 days, 10 lunar months would be EDD. Yeah, guys and girls, what if I ask you calculate 280 days in months and English month calendar? The answer would be 9 English months plus 7 days, because 9 English months would fetch you 39 weeks and 7 more days would fetch you 1 more week, 40 weeks. Yeah. So if I ask you EDD is how many weeks from fertilization, the answer would be 38 weeks. EDD is 38 weeks from fertilization. But don't you think patient might not ovulate on 14th of January? A patient whose cycles are longer cycles, they will ovulate later on. Patients whose cycles are shorter cycles, they will ovulate earlier. Remember the rule. Length of cycle, length of menstrual cycle, minus 14 is the day of ovulation. Try to understand this slowly, gradually. Let's say patient has come to my OPD. She is telling me, doctor, I had last menstrual period first day on 1st of January. Then I will ask her second question. How frequent were your cycles? If a question's answer is, doctor, I used to get periods after every 33 days. Now, when she has cycles of every 33 days, don't expect her to ovulate on 14th of January. She will ovulate, 33 minus 14 would be 19. Yes, she will ovulate not on 14th, but she will ovulate on 19th of January. Why? Why later? Because her cycles are longer. Yeah? So understand this thing. Longer the cycles, later is ovulation. Shorter the cycle, earlier would be the ovulation. So, remember, we can apply a modified Negley's rule in these patients. Which says LMP plus 9 months 7 days plus or minus X is EDD, where X is deviation from 28. X is deviation from 28. She used to have cycles of 24 days. The value of X would be minus 4. You have to subtract 4. So her answer would be not 8th of October as EDD. Her EDD would be 4th of October. Yeah? Longer cycles, subtract X. Shorter, longer cycles, add X. Shorter cycles, subtract X. Okay? Irregular cycles. Yeah, irregular cycles. You have to understand, take average of last 3 cycles. If she remembers, you take average of last 3 cycles and find the value of X. X is very valuable. Yeah? Find value of X and that would fetch you the genuine EDD. Alright? If question is how many patients deliver on EDD, the answer is surprisingly 4% only. So why are we crazy about EDD calculations? EDD helps us in doing many things. EDD tells us about preterm, term, post-term. I hope you remember preterm, term, post-term classification and early preterm, late preterm, etc. So EDD is important. EDD can tell us many things. So only 4% patients deliver on EDD, but plus or minus 1 week would be the time when 50% patients would have delivery. 50% patients would deliver. 50% patients would deliver in plus or minus 1 week. Okay. Now, this is about Negley's formula. Now, guys, one slightly difficult case for calculating the gestational age. Listen carefully. Patient had in vitro fertilization cycle, IVF cycle. Her day 3 embryo was transferred in uterus on 24th of January. This is the information given to you. Let me see how many of you are able to get the EDD. I will not give you option. I will give you this very, very difficult case. Day 3 embryo is transferred on 24th of January. Yeah? Can anyone? Acha, people are asking me about modified Negley's rule. Guys, first try to understand Negley's. Negley's is 9 months 7 days. EDD is got. EDD is attained. EDD is obtained. But if patient has cycles of more than 28 days, her ovulation would be delayed. It will not be on 14th of January, it will be delayed. So obviously her EDD will shift. Why it will shift? Because fertilization would be late. So you have to add those many days. That is modified Negley's rule. Right now I have given you very difficult case. 24th of January is her day 3 embryo transfer day. What will be her EDD? Let's see. Let's see. I will not give you option for sure. Okay. Let me draw a timeline. And let me put a query in LMP. I don't know LMP. I don't know EDD. But I know the day of fertilization. Day of fertilization, 24th was day 3. You remember this thing. Day 3 embryo, 24 January. Subtract 16 days to get LMP. Yeah? Subtract 16 days to get LMP. How 16? I will tell you that also. So she had 24th January transfer day. But the baby was already day 3. Try to understand this. Baby was already day 3. It was not a day of fertilization. Baby was a day 3 of fertilization. Okay. That means 2 days were already over. Baby was in day 3. When 2 days were already over, that means tentative ovulation day was 2 days prior. Yeah, just theoretically 2 days prior was her ovulation day. Okay, and before ovulation 14 days more would be LMP. Yeah, so 14 plus 2, 16. 24 January is day of transfer. You have to subtract 16 from it. So it will be 8th of January as her LMP. Congratulations, you have obtained 8th of January. So her EDD would be 8th of January plus 9 months 7 days. It would be 15th of October. Those who got 15th of October, congratulations. You people are correct. This is very difficult case. Try to understand. Take a deep breath. See, when I say day 3 embryo transfer, let's say day 3 embryo transfer was done on XYZ any day. Yeah. The baby was already 3 days into life from fertilization. 3rd day was going on. So 2 days prior was a day of fertilization. Okay. And yes, understand, you have to add 38 weeks from fertilization to get EDD. In other words, add 40 weeks from LMP to get EDD. So if fertilization happened 2 days prior, so LMP happened 16 days prior. So by knowing the date of transfer, you can get the date of LMP, and with LMP date you can calculate EDD. Okay. So 2 days from day 3 embryo transfer, so 2 days were over and 14 days more. Hopefully you understood this difficult concept of calculating the EDD if patient's day of transfer is given. Okay. Question is, what is IVF? I'll kill you if you ask me what is IVF. In vitro fertilization. Guys, my God, dangerous question. What is IVF? Okay. In vitro fertilization, when egg is taken out and the baby is made in the dish and the embryo is transferred into uterus. This answer would be 15th of October. Okay. Got it? Very clear. 24 minus 16, 8th of January. You have to add 9 months 7 days. That would be, yes, 15th of October. Those who are saying, why not 3? Why not 3 minus subtract 3 for fertilization? Because 3rd day is going on, no? Okay. Day 3 embryo transfer means 3rd day baby is there. 3rd day embryo is there. Okay. Take it from me. Subtract 16 from the day of transfer. You will get LMP. And after LMP, you know how to calculate EDD. Okay. Got it? Very clear? Yeah. After this. There is something called obstetric formula. Those who are asking me, sir, what about her length of cycle? Length of cycle will not matter in IVF. You are knowing better answer than length of cycle. You are knowing the day of fertilization, and yes, you are knowing the day of transfer. You don't care about the length of cycle in that case. Length of cycle is just to know the day of fertilization in normal patients. Okay. Hopefully you understood this. Yeah, obstetric formula. Obstetric formula is a way how we discuss the case with our fellow colleagues. We write it's in a systematic way. There is one formula called GPAL formula. Gravida is total number. Yes, your question is, what if day of transfer is different? Then obviously your 24th January will not be there. Day of transfer, acha, you are talking about day of transfer at day 5. Then you don't have to subtract 16, then you have to subtract 18. Okay. Acha, more examples. Alright. Okay, let me see how many of you have picked up. Okay, cases. Before we jump on to obstetric formula, let me give you one case as per the demand. Okay. There is one patient who has LMP of 2nd of April 2020. Yeah, lockdown में कुछ तो हुआ. Yeah, 2nd of April 2020. Length of cycle 33 days. Tell me the EDD. This is case number, let's say 5. Okay, I am giving a random figure, case number 5. Tell me the answer of case number 5. Calculate the EDD. Acha, GPAL is done by Dipti madam? Okay, fine. Thank you so much. GPAL is done by madam. Alright, thank you. Virat Kohli, nahi, ignore. 2nd April 2020, length of cycle 33 days. What are you supposed to do? What is her EDD? Calculate, tell me. Hello? Yes? Can you talk to me after some time because I'm in lecture? Yeah, tell me. 2nd April 2/4/2020. What will be her EDD? 9 months 7 days. 9 months 7 days to 2nd of April. 9th of January 2020. Yeah, but don't you think that her cycles are longer? So this will not be the right answer. You will have to add 5 more days. So 9 plus 5, 14th January. My God, Makar Sankrant. This time something else on Makar Sankrant. Okay. 9th of January will not be the right answer. The answer will be 14th of January because her cycles are of 33 days. You have to add 5 more days. Okay, got it. Yeah, 14th January. Good. Chalo. I'll give you another case, another difficult case. Let me see. Somebody asked me, what if the day of transfer embryo day is different? Sometimes we do day 5 embryo transfer. Let me give you case number 6. Example, case number 6. Patient had embryo transfer. The embryo was day 5 embryo. Mark my word, embryo transfer, day 5 embryo. It was done on 19th of January. Day 5 embryo transfer, 19th of January. Tell me the right answer. Yeah. Day 5 embryo transfer. Case number 6. Case number 6, please. Yeah, 2020. My God. You people are amazing. Did I write 14 January 2020? Yeah, 2021. Thank you so much. Yeah, but you got my point. 2021, but 14th of January. What about this case? Next case, come on, tell me. Case number 6, day 5 embryo transfer done on 19th of January. The correct answer is EDD 8th of October. 19th January, but embryo day is 5th. So you have to subtract 18 from it. 18 would be 1st of January. 1st of January, again Makar Sankrant Kulumulu. No, guys, this is embryo transfer. IVF was done. So yes, 19th January, her EDD would come as 8th of October. Okay, thank you so much. I hope you understood this. Guys, we were talking about obstetric formula and I heard that madam has already covered this. Guys, was GPL covered or TPAL covered? This is also this was also supposed to be taught by me, but if madam has covered this, I will not teach again. So GPL is already covered, TPL is also covered. Okay. Gapla, GPAL. G is gravida. I will not write the definition, total number of pregnancies and all. But then the GPAL would have parity, T as parity. Number of pregnancies in past. Number of pregnancies in past which had crossed period of viability. Okay, I got it. Okay. If you understood it, Dipti ma'am has covered it. I will not repeat it. Don't worry. Don't spam it. Okay, not. Let me give you one example. In fact, this example would also have been covered. Example, patient is pregnant for, let's see. Acha, example, I can give you example. Okay, tell me the answer. Fifth pregnancy. First pregnancy, full term, normal delivery. I'm asking you question. Yeah. Let's say case number 7. Fifth pregnancy. She is fifth time pregnant. Full term normal delivery. Alive baby. Second pregnancy. Preterm. Twins. Preterm twins. Both the babies are alive and alive. Both the babies are alive. Third pregnancy. Ectopic pregnancy. I will just take your test. Don't worry, don't worry. Third pregnancy, ectopic pregnancy. Ruptured at 8 weeks. Fourth pregnancy, abortion at 10 weeks. I will teach, I am teaching. Those who are typing, please teach, please teach. Stop typing. I am actually teaching. So my dear friends, I am teaching. Please stop typing. I will go into the landscape mode. Okay. I am teaching. My job is to teach you all. You are all my students, madam students. We all are family. Love you all. Guys, I have given you one case. Instead of typing teach, not teach, teach, not teach, I will tell you and teach you in another way. Yeah? She is pregnant fifth time. She is pregnant fifth time. Okay, she is pregnant fifth time, but she has triplets this time. And she is 30 week pregnant. Present pregnancy, triplets at 30 weeks. All the babies are alive, alive, alive. She is still pregnant. Mark my words. They are alive, intrauterine. My dear students, I will write G block, T block, A block, L block. Give me the correct answer for G, P, A and L for this case. What will be G? G would be phi. I don't think there is anyone who has not written properly. G would be phi for sure. Yeah? What will be parity? Parity would be how much? How many past pregnancies had crossed period of viability? The word is past pregnancy. Number 1 pregnancy, full term pregnancy. Number 2 pregnancy, preterm pregnancy. These are the 2 pregnancies which had crossed period of viability. So I will write parity as 2. Yeah. Parity would be 2, my dear friends. Why not 3? That's my point. Parity is not 3. Parity is 2. Number of past pregnancies which had crossed period of viability. I am writing here for those who are uninitiated. Parity is number of past pregnancies which had crossed period of viability. Correct? So parity would be 2. How many abortions? Now she has technically 2 abortions. One is ectopic pregnancy which got ruptured at 8 weeks and abortion at 10 weeks. So A also 2. Even though ectopic is not abortion, but you will write A as 2 because it is termination before 20 weeks. Yeah? And how many living babies at present? How many living babies at present? 1 from the first pregnancy, 2 from the second pregnancy. The answer would be 3. Those who are writing, sir, what about this pregnancy, the 5th one? She has triplets and 30 weeks, alive, alive, alive. My answer to this is she is still pregnant. She has not delivered the babies. So your parity figure will not include this pregnancy. Okay, you will not count this pregnancy, and yes, you will not count live babies L for this because babies are not yet delivered. So take home message, present pregnancy you will not count in L. I hope you got my point. L would be 3. This is GPAL formula. Gravida, para, abortion, living. Present pregnancy is not counted in parity, not at all. Yeah. Once she delivers the babies, then story would be different. Of course. She has delivered, so she has one more past pregnancy which had crossed period of viability. Okay. Got my point? Let me tell you Tupal formula, which madam must have told you. There is another way of writing it as T plus P plus A plus L, where T stands for term deliveries, P for preterm deliveries, A for abortions, L for living. Those who are asking me what if ectopic is not ruptured, ectopic would be treated now, my dear friend. Whether it is a ruptured or unruptured, it will be counted as abortion. Ectopic is counted as abortion. Okay. Term, preterm, abortion, living. Term is 37 or more. Preterm is less than 37. From 20 to less than 37. Abortion is less than 20 weeks. Living would be alive babies at present. Yeah, alive babies at present. See, our GAPAL formula, GPAL formula had a problem. Those who remember, period of viability is 28 weeks, but in GAPAL formula, parity, period of viability, what about 20 to 28 weeks? That is unsolved. That is why TUPAL formula came, and that is better formula. TPAL, we always nowadays talk in TUPAL formula, TPAL, where everything is crystal clear. You just have to write number of term pregnancies in past, number of preterm pregnancies, where figures are 20 to less than 37, abortion would be less than 20 weeks, and ultimately the result, living babies. So there is no gray zone in TPAL. So can you tell me what will be her TUPAL formula of our previous case? How many term deliveries? First is G5 in bracket. How many term deliveries? 1. How many preterm? 1. How many abortions? 2. How many living? 3. Yeah. Here the answer was G5 P2 A2 L3. Here it will come as G5 1 plus 1 plus 2 plus 3. Yeah. Got it? See, period of viability in India is 28 weeks. But then TUPAL formula does not believe in that. TUPAL formula is TPAL, term 37 and beyond. Preterm 20 to less than 37. Abortion less than 20 weeks. And final result is living babies. Got it? 1, 1, 2, 3. This is how you and me will communicate. Patient is G5, 1, 1, 2, 3. That means I will understand she has 1 term delivery, 1 preterm delivery, and 3 living babies and 2 abortions. Though information of abortion is not clearly mentioned whether it was ectopic or not, but this will be the answer for TUPAL formula. Good question. What if baby died? Then you will subtract 1 from here, no? If one baby died, you subtract 1 from here. That's it. The question which you asked, what if one baby dies? You have to subtract 1 from here, but in bracket you have to mention 1 baby died at so and so months or years or decades or whatever. You have to mention these special things over here. Yeah. Because there will be a mismatch. Live babies will not be counted properly. You have to write special things in bracket and you have to subtract it from live. You cannot write live for that. Okay? Yes, remember this thing, even if it is preterm death. See, I'll give you example. She is second time pregnant. First time she had 30 weeks pregnancy and baby died at 6 months of, or I'll write 16 months of life just to avoid confusion. Yeah. So G2 P1 A0 L0 would be the answer for this patient. Yeah. May she be preterm term, she had crossed period of viability, but baby died at 16 months of life. Okay. Got it? Preterm twins, same thing. You have to write parity as number 1 for twins. Okay. What if present pregnancy cross period of viability? No problem. We will not count that in parity. Remember, parity is number of past pregnancies which had cross period of viability. Finish. Okay. Intrauterine fetal demise. The topic will come. Remember, it is after period of viability. So we will write parity, but we will not write live. Intrauterine fetal demise is after period of viability. We'll talk about it. So hopefully after this detailed discussion, everything is clear about obstetric formula. Then I want you people to next write down investigations in ANC. Investigations in antenatal care. Yeah. Question is, what if abortion after 20 weeks? Sir, in Tapal formula you'll have to write in P. That's it. No confusion. Okay? Guys, girls, investigations in ANC. HB. Blood group. HB. Blood group. Then urine analysis. To rule out infection. Yeah, guys, girls, HB, blood group, urine analysis to rule out infection. Then HIV after consent and pre-test counseling is must. Yeah. Then HBsAg. Then VDRL or RPR for syphilis. Then you do pap smear at first visit. Then you are supposed to do blood sugar evaluation. It has to be done 2 times. One at first visit, which should be ideally in the first trimester, and one at 24 to 28 week visit. We do DIPSI in both the scenarios. So we do DIPSI 2 times. Blood sugar evaluation, DIPSI is done 2 times. First visit and 24 to 28 week visit. We have covered the chapter of blood sugar evaluation, diabetes, gestational diabetes mellitus and overt diabetes mellitus. Yeah. Then we also do trisomy screening. This is universal screening. Everyone is allowed to do this testing irrespective of age of the patient. Universal, which means irrespective of patient's age. She is allowed to do trisomy. She is given this option of trisomy screening. But this test is offered. Yeah? It is offered. It is not compulsory. It's not a must test. You don't have to force this, that you have to get it done. It has to be offered. Okay? Trisomy screening is offered. So I will repeat. HB. This also has to be done 2 times. First visit and 28 week visit when we are expecting hemodilution. So HB, first visit and 28 week. Blood group evaluation is along with RH typing. Urine analysis, dipstick method is followed in every hospital in India. Dipstick evaluation. Yeah, urine analysis. And if there is infection, dipstick method will come as positive. Yeah, there will be proteinuria element along with infection. Yeah, then we subject her for culture sensitivity and whatnot. Okay, yeah. So yes, HIV after consent, HBsAg, VDRL, RPR, pap smear, blood sugar evaluation, trisomy screening. Then there is one test called group B. Streptococcal screening. This is a new thing which has to be done. GBS screening. It is done at 35 to 37 weeks. GBS screening. Recto-vaginal swab is taken. Yeah, you take recto-vaginal swab. Okay, and this recto-vaginal swab is sent for culture and sensitivity. Recto-vaginal swab is taken for culture and sensitivity. Question is why PAP? PAP, why PAP? Remember, Pap smear is exfoliator cytology. It can never be harmful. It is just an exfoliator cytology. And there is, a patient with dysplasia in pregnancy, the treatment is very, very different, and we have to, if there is a cancer in pregnancy, will you miss out this cancer? Never. Remember this thing, Pap smear has to be done first visit. If not done in past 3 years, Pap smear has to be done 3 yearly. Yeah. So remember, Pap is to be done in pregnancy. It is not harmful, not at all. PAP is just exfoliator cytology. So I said group B streptococcus screening, 35 to 37 weeks. Recto-vaginal swab is taken for culture sensitivity. And then remember, this test is for the sake of prevention of neonatal sepsis. Baby is going to come out from a vaginal route, and yes, that is why prophylactically we take swab at 35 to 37 weeks. Neonatal sepsis prevention is the plan of action. Yeah, that's why we take GBS screening. And yes, if screening is positive, then give drug of choice, penicillin G, IV, but at the time of active labor, not before that. You're done at 35 to 37 weeks doesn't mean you will treat immediately. Why we are not treating immediately? Because this patient may get infection again. It's a normal flora. It is colonization over there. It may get, patient may get infection again. We will be under false impression that patient is treated. So we have to give treatment at the time of active labor, not before that. Yeah. If patient is allergic to penicillin, then cefazolin can be given. If there is history of anaphylaxis to penicillin, then don't even give cefazolin. Then give vancomycin. So 3 drugs I have told you. Penicillin G is a drug of choice to be given during active labor. Cefazolin if allergic to penicillin. Vancomycin if history of anaphylaxis. Okay, guys. Group B streptococcus screening is to be done to prevent a neonatal sepsis. Okay, GBS screening. Alright, so yes, this is what is about GBS screening. The story is not yet over. We have to do one investigation which is like very, very crucial investigation. No obstetrician denies this investigation. Everyone is fond of this investigation, and that investigation is ultrasonography in antenatal care. USG in ANC. Ultrasonography in antenatal care. Yeah. USG in ANC, T1, T2, T3. Those who ask me what is T1? T1 is less than 14 weeks. T2 is less than 28 weeks. Yes, you heard it right. First trimester is less than 14 weeks as per obstetrics Williams. T2 is less than 28 weeks. T3 is 28 weeks or beyond. So sonographies are done In first trimester, second trimester, third trimester. If you do it in first trimester, it is called a dating scan. Yeah. If you do it in second trimester, it is called booking scan. If you do it in third trimester, yeah, that is for growth scan. That is called as growth scan. Yeah. Lecture till 9 o'clock. Yeah. Guys, girls, remember, see the sequence. Sequence is very important. First, you do dating. Then you do booking. And then you grow. Growth scan. Dating is compulsory before booking. If you book without dating, you will be in trouble. And I am not talking about only ultrasonography. I hope you understood. Dating is compulsory. Date many, then book. Yeah? Yeah. So remember this thing. Dating scan is for calculation of gestational age. Dating scan is for calculation of gestational age. Okay? Remember, crown rump length is best parameter for this. CRL. This Pikachu Pillu is an embryo of first trimester and you have to do crown rump length assessment. Yeah? Guys, girls, crown rump length assessment is the best parameter. See, dating scan, you have to scan right from top to bottom. In dating, don't leave any part. Right from top to bottom, everything has to be scanned. I hope you understood. Yeah. So for calculation of gestational age, crown rump length is the best parameter. The ideal time is 7 to 9 weeks for 7 to 9 weeks for doing crown rump length assessment. Error is very small. Error is just 5 days. The range is 3 to 5 days. Range is 3 to 5 days. And right answer is 5 days for error. Yeah. This is first trimester scan, dating scan. But there are other uses also. Other uses of first trimester scan, what do you think are the other uses? Firstly, to know whether the baby is alive. So I hope you remember gestational sac 25 millimeter, crown rump length 7 millimeter, critical cutoffs. I spent lots and lots of time on that. So other uses of first trimester scan would be to diagnose missed abortion. That means baby is alive or dead would be understood. Cardiac activity is so important thing to identify missed abortion. If cardiac activity is absent, the baby is dead. Yeah. Then ectopic gestation. Then, by the way, ectopic pregnancy is a topic in itself, but there is one appearance, very typical appearance seen in ectopic pregnancy. There would be a gestational sac in fallopian tube and it will be surrounded by increased vascularity area. This is called as, ring of fire appearance. Ring of fire appearance, ectopic pregnancy. Yeah. Missed abortion, ectopic pregnancy, then molar pregnancy. Molar pregnancy also can be diagnosed in first trimester. Why not? Molar pregnancy has a typical appearance where there are bubbles in sonography. And we will have a chapter called molar pregnancy. Hindi mein angur garbh, Marathi madhe draksha garbh. Molar pregnancy is grape-like pregnancy. Yeah. So yes, molar pregnancy, there would be snowstorm appearance. Ring of fire appearance, ectopic pregnancy, snowstorm appearance, molar pregnancy. Yeah. Then Anencephaly. I told you anencephaly can be diagnosed as early as 10 weeks. Remember, earliest congenital anomaly to be diagnosed. In ultrasonography is anencephaly, Mickey Mouse appearance, protruding eyeballs, frog-like appearance. Yeah, earliest congenital anomaly to be diagnosed in ultrasonography. राक्षस गर्भ नहीं, द्राक्ष गर्भ, राक्षस गर्भ नहीं. Why God, people are crazy. Yeah, molar pregnancy is draksh. Marathi में, in Marathi, grape is called draksh. Yeah, not rakshas. Crazy people. Yeah, right. So yes, we are talking about first trimester scan. Let us talk about second trimester scan, booking scan. It is done between 18 to 20 weeks. It is also called as level 2 scan. Yeah, that's an old name, by the way, level 2 scan. Nobody uses this terminology. So you can say it is congenital anomaly scan. We assess the baby right from top to bottom again, but this time every organ is assessed in congenital malformation scan, 18 to 20 weeks. Remember, fetal congenital malformations are best assessed at 22 to 24 weeks. And thank God our MTP law changed. Yeah, earlier fetal congenital anomalies detected after 20 weeks, we were tied, we were not able to do anything in these cases. We used to continue pregnancy in these poor patients having fetal congenital anomalies. So now we have option of terminating pregnancy. The pregnancies can be terminated till 24 weeks, and gross congenital anomaly, the figure is removed. You can terminate anytime. Okay. So yes, fetal congenital anomalies are best assessed at 22 to 24 weeks. Best parameter for gestational age assessment. Best parameter for gestational age assessment in second trimester would be biparietal diameter, BPD. Yeah. Alright. Best parameter for gestational age assessment in second trimester would be biparietal diameter. Alright. Yeah. Error is 14 days. 10 to 14 days is the range. 14 is the right answer for second trimester gestational age error. Okay. Then comes third trimester scan. Third trimester scan over here. Yeah, growth scan is the name. Growth scan. Growth scan is not compulsory in all pregnancies. It is done only when uterus does not match with period of gestation. Yeah, done only when uterus does not match with period of gestation. So if uterus is less than period of gestation, uterus is more than period of gestation, that means the size of baby is not matching, you will do growth scan. Best parameter for assessing growth, is abdominal circumference. AC, abdominal circumference. Okay, best parameter for assessing growth, abdominal circumference. But gestational age error is very, very high, 21 days. We don't rely on third trimester scan for gestational age. We rely on first trimester scan, and that's the best scan for gestational age. And crown rump length is the best parameter for gestational age. This is like error. So 21 days error. So guys, abdominal circumference is for growth, but gestational age error is 21 days. What if patient comes to you in third trimester for first time? So I'm writing here, best parameter for assessing gestational age in third trimester. This is done only when patient has come very late in pregnancy. Then we have to do third trimester scan. We have to take that error, but you have to do third trimester scan, and the answer would be femur length. So we rely on femur length assessment for gestational age in third trimester. I will repeat, guys, girls. First trimester scan, CRL. Second trimester scan, DPD. Third trimester scan, femur length. These are the markers for gestational age. Growth assessment is best by abdominal circumference, AC, abdominal circumference. Okay. If you are asked which is most accurate method of gestational age calculation, is it Negley's formula, modified Negley's formula? The answer is none of the above. The answer is gestational age by CRL is best parameter overall. Yeah, gestational age parameter is by CRL, best parameter overall. It is better than Negley's formula or Negley's rule, you can say. Error. What do you mean by error? Okay, good question. See, understand this thing. If I say first trimester sonography is telling me 11 weeks, 5 days. That doesn't mean the pregnancy is off 11 weeks, 5 days. It could be 11 weeks to 12 weeks. Error is 5 days. Error means plus or minus. Okay. So guys, CRL is always the best thing. Error is smallest, least, and that error is plus or minus 5 days. Okay. So whatever figure you get by sonography, you have to add plus or minus 5. You have to understand that error would be plus or minus 5 days. Okay. That is why we take gestational age by CRL as the most important marker for calculating gestational age. Okay. Hopefully you understood this. Alright. After sonography, those who were typing what about nuchal translucency and all, that is in fetal care topic, which is going to come soon. Yeah. We will talk about fetal care. And in fetal care, we will talk right from trisomy evaluations and non-stress test, cardiotocogram, and whatnot. So we will cover fetal care evaluations all for sure. Right now we are talking about antenatal care, maternal care. Mother is taken care of right now. Yeah. So we have covered USG. We have covered investigations. I want you people to write down immunization in ANC. Immunization in ANC. Guys, hopefully you have understood and written about level 2 scan and then growth scan. All good? Those who are repeatedly typing fetal circulation, I'll personally kill them. I will complete it, my dear friends. I have lots of time. I'll complete it. Don't worry. So yes, this is about sonography. I am now jumping on to the topic called immunization in ANC. Everyone concentrate. Immunization in ANC. Immunization in ANC, you give 3 arrows. Compulsory, safe, and contraindicated. Compulsory, safe, contra. Yeah? Guys, girls, compulsory immunization is TD now. Earlier it was TT, tetanus toxoid. Now it is diphtheria combination with tetanus toxoid. Yeah? 2 doses are to be given. 1 month apart. TD is to be selected, 2 doses, 1 month apart. first dose at first visit. Yeah, I have written T and D, tetanus, diphtheria. Combination is given nowadays. Recently it had been changed. First dose at first visit. Only one dose, what is called a booster dose, is to be given if patient is immunized in past 3 years. Only one dose is given if patient is immunized in past 3 years. Yeah, it will prevent mother also, it will prevent baby also. Yeah, maternal and fetal neonatal prevention is TD. Yeah, compulsory vaccination. Guys, safe vaccination would be hepatitis B, pneumococcal, meningococcal, flu vaccine. I can't talk about corona vaccine because it is not yet available. Yeah. So HBsAg, pneumococcal, meningococcal, flu vaccine, rabies. Yeah. Whenever indicated, these vaccines are given safely without any problem. They are not contraindicated vaccine. Contraindicated vaccines are measles, mumps, rubella, varicella zoster, polio. Yeah, measles, mumps, rubella, varicella zoster, polio, OPV, IPV both. Even though IPV is not a live vaccine, but IPV is contraindicated. Cholera. I have written measles, mumps, rubella, varicella zoster, polio, cholera. Then one very interesting vaccine, yellow fever. But then cholera, yellow fever and polio, these vaccines are given if patient is traveling to endemic zone. Yeah, these vaccines are given if patient is traveling to endemic zone. Otherwise they are not given. No, not needed. I am writing here, given only if patient is traveling to endemic zone. Yeah, got it? Very clear? Traveling, there is one MCQ, air travel is not allowed after, yes, how many weeks? You cannot give a certificate called fit to fly if patient has crossed how many weeks? Yes, answer please. Air traveling is not allowed if a patient has crossed how many weeks? Yeah, air traveling is not allowed. If not allowed after, not allowed after how many weeks? Nobody is answering. 28, no, 36, 32, 28, 36 weeks. Okay, got it. 36 is the answer. Yeah. HPV vaccine is not recommended in pregnancy. So you can write it in a list of contraindication as well. Human papilloma virus vaccine is not recommended in pregnancy. Alright, the answer is 36. 32 for twins, yes, 36 for normal singleton pregnancy. Air traveling is not allowed, not fit to fly. Okay. M&M is great, 48 weeks. I told you, Ascaris, unmentionable area. Yeah, guys, so we have covered the topic called immunization. Now, in this list of immunization, there are some viruses, there are some infections. I want you people to write down important points. Remember, rubella vaccine to pregnancy interval should be minimum 1 month. I have written vaccine is contraindicated. Rubella vaccine is contraindicated, and the gap between vaccine to pregnancy should be minimum 1 month. Okay. Rubella is most teratogenic infection in pregnancy. You should hear these things properly, guys. Okay. I have written few facts about rubella vaccine and rubella infection, two different things. I have written rubella vaccine to pregnancy interval minimum 1 month. Rubella is most teratogenic infection in pregnancy, 90% chance of congenital rubella syndrome if infection happens in first trimester. I have written 90% chance. Vaccine chart. Okay, I'll give you vaccine chart. Till the time I will have little bit of water. You finish this chart. Give me 1 second. I'll have a little bit of water. Yeah, I'm back. If patient is immunized in past 3 years, you give only 1 booster dose. TD has to be given 2 times. If patient is immunized in past 3 years, then only 1 dose. TD is tetanus diphtheria combination. Yeah? All good? Okay. Alright, fine. I was talking about important points. Yes, rubella vaccine to pregnancy interval minimum 1 month. Most teratogenic infection in pregnancy, rubella. 90% chance of congenital rubella syndrome if infection happens in first trimester. Yeah? All good? Guys, girls, remember this thing. Rubella plus pregnancy is equal to MTP, medical termination of pregnancy. So I'm writing case 1 over here. Rubella plus pregnancy. Patient has come to you and she has rubella infection in pregnancy. You advise her termination of pregnancy for the sake of congenital rubella syndrome. Yeah, there is high chance of congenital rubella syndrome. Okay, guys, case 2. Rubella vaccine taken in pregnancy. Patient has come to your clinic and she is telling you, doctor, another doctor gave me rubella vaccine. I forgot to tell him that I am pregnant. not because of the doctor, because of something else, someone else. So rubella vaccine taken in pregnancy is not an indication of MTP. Yes, surprise, 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 not an indication of MTP. Those who have taken by mistake, they have not got any problem with the baby. Yeah? I'm not telling you it is safe in pregnancy. I'm telling you it is contraindicated in pregnancy. But it is not an indication of MTP. Those who have taken it by mistake, nothing has happened to them. But there is no study available, yeah, to label rubella vaccine as safe. So nothing has happened, but still rubella vaccine is live vaccine. Theoretically, it can affect the baby. So remember, it is contraindicated. Okay? Yes, then measles and mumps are non-teratogenic infections in pregnancy. Yeah, important point. Measles and mumps are non-teratogenic infections in pregnancy. Yeah? But remember, measles, mumps can cause intrauterine growth restriction, intrauterine fetal death. So they don't give congenital anomaly, they will kill the baby. So understand this thing. Yes, they are risky infections. Viral infections are very bad in pregnancy. Measles and mumps can cause IUGR, fetal demise, placental calcification. Yeah, all these things are possible with measles and mumps. Okay, right. Then about a varicella zoster infection in pregnancy. Varicella zoster infection in pregnancy. See, many of us have already had chicken pox. Yeah, remember, chicken pox happened in childhood, and we are all fine. We are immune. If our immunity goes down, we will get herpes zoster reactivation. Okay, so remember, chicken pox in pregnancy is teratogenic. Chickenpox in pregnancy is teratogenic, but herpes zoster in pregnancy is non-teratogenic. You understood? When somebody gets herpes zoster, that means patient has already had infection in past. If you hear had infection in past, that means IgG would be positive, right? Can IgG cross placenta? Yes. IgG can indeed cross placenta and can provide immunity to the baby. Baby will get protection. But chickenpox is first time infection. Chickenpox, when it happens, then IgM will be positive. IgM is a large molecule, it cannot cross placenta. So what you should write right now, IgM and IgG. For chickenpox, IgM, and for herpes, IgG. IgG can cross placenta and save the baby. Immunoglobulins will save the baby. Virus can cross for sure. But along with virus, if immunoglobulins are also going, then baby will get protection. So herpes zoster is non-teratogenic. Yeah? Guys, girls? After you have written this, then suppose if there is one staff nurse, let's write case. There is one staff nurse who has come to your clinic. She is telling you, doctor, I am pregnant. You will say, congratulations, nice. Why have you come to me? Am I the culprit? No? No. So you are pregnant, okay, great, congratulations. But then she says, doctor, in my ward, there is one patient with chickenpox infection. I would say, there is chickenpox exposure. I will ask her first question. First question would be, did she ever get chickenpox in childhood? If her answer is yes, I will tell her, go home, don't worry, nothing will happen to you. If her answer is no, I will ask her second question, whether she has got immunized by vaccination. If answer is yes, go home, no problem. But if answer is no for both, then she is not immunized, not infected, she does not have IgG. If chickenpox exposure has happened, she has developed exposure and she is not having IgG in her body, you should give IgG. Yeah? You should give her protection. Don't allow chickenpox to happen in pregnancy. So I'm writing one very important, interesting statement. She is not a case of chickenpox. No, she has got exposure. That is what I was teaching you in hepatitis B also. She has got exposure. Plus, there is no past immunity. Neither from infection nor from vaccination. No past immunity. What will be your treatment in this case? You will give her Vzig. I don't want her to develop chickenpox in pregnancy at least. No, I don't want her to develop chickenpox. So we will give Vzig during pregnancy. Yes, she will get security from getting chickenpox. She will not get chickenpox and she will get saved. Remember this thing. Chickenpox is teratogenic. You have written this line. Remember, most risky time of chickenpox for congenital varicella syndrome. In other words, highest risk of developing congenital varicella syndrome. Correct answer is second trimester. Yeah? Second trimester is very dangerous time for chickenpox congenital varicella syndrome. This is strange. Otherwise, all infection, first trimester is most dangerous time. Here, the most dangerous time is 13 to 20 weeks. Highest risk is at 13 to 20 weeks, followed by 8 to 13 weeks. This would be correct answer. This is the highest risk time for congenital varicella syndrome. Okay? Guys, girls, stop fighting on the chat. I'm also focusing over here. You also focus over here, please. My dear friends, I told you Vzig is to be given to a patient who is exposed. If patient has developed chickenpox, this is another case. If patient has developed chickenpox around labor, patient has developed chickenpox but around labor. What do you mean by around labor? 5 days before delivery to 2 days after delivery. 5 days before to 2 days after delivery. This patient has developed chickenpox, so she has active lesions. These lesions can go to the baby by skin to skin contact. You have to understand that this is risk for neonatal varicella syndrome. Neonatal varicella syndrome. Okay? Chickenpox around labor, risk for neonatal varicella syndrome. Okay? How do you prevent it? Prevent it by Vzig. But to mother or baby? To baby. You have to give Vzig to the baby. This is how we prevent neonatal varicella syndrome. Okay, what about mother? Treatment of chickenpox. is acyclovir. This is the drug of choice, acyclovir. 800 mg 5 times a day for 7 to 10 days. Okay, so you understood when to give VZIG to the pregnant mother? When she has never had immunity and she is exposed. There is no use of giving VZIG if she has already developed chickenpox. Then you will give her acyclovir. What if she develops chickenpox around labor? Then you will give acyclovir to mother, but baby should receive VZIG. If we want to prevent infection in baby. So VZIG to neonate. Okay, got it? Very clear. So these are all the infections which you should know. We have done this ANC topic with infection. There is one part of ANC topic called as RH blood group. I am writing RH negative pregnancy now. RH negative pregnancy. RH neg preg. Okay. Guys, girls, focus. Everyone focus. RH negative pregnancy is the next topic. Yeah. Now, RH negative pregnancy. First and foremost, a person who has no D antigen, capital D, antigen is missing, then the person is labeled as RH negative. Yeah. If person is having D antigen, then the person is labeled as RH positive. This is very basic, simple thing. Yeah. Guys, why will we give acyclovir for that nurse patient? That nurse patient did not get chickenpox. Acyclovir is treatment of chickenpox. I gave VZIG for prevention of chickenpox. She has not developed chickenpox. We don't want her to develop chickenpox. Hopefully you understood. Next chapter is RH negative pregnancy. Small d. Yeah. And yes, RH positive person is called RH positive because of presence of capital D antigen. How many antigens are there? In rhesus blood group? How many antigens in rhesus blood group? Capital C, capital D, capital E, small c and small e. 5 antigens are there. There is nothing called small d. Small d antigen does not exist. Small d means absence of capital D. Small d means absence of capital D. Yeah? Guys, I know you people are pushing very hard. I know you people are tired. I know you people are sitting in front of your computer, in front of your mobile or tablet and writing notes. You are doing wonderful thing, guys, but please push a lot. I am there for you. I will conduct your delivery for sure, because we have this last topic and we will continue till 9 o'clock. So please, my dear friends, I have this last topic called RH negative for the day. We are thankfully on track for the day. We are lagging overall. Guys, so please bear with me. Here there are people who are very serious, sincere, and they are writing notes, and I dedicate this topic to them. Yeah. So those who are not interested, yes, guys, what can I tell you? Please don't spam the chat box. I will now focus on RH negative pregnancy, and my focus will be till 9 o'clock. Guys, focus for this chapter, one of the very difficult topic in obstetrics to understand. Treatment wise, modality wise, why to give, why not to give, concepts are very important. So please be attentive. I know you are pushing a lot, but push little bit more. Otherwise I will apply forceps or vacuum and then deliver the baby. Okay, baby? Okay, fine. Yeah, guys, out of the audience sitting over here, roughly 10% audience is RH negative. Girls, RH negative girls, hello, hi, RH negative girls. RH negative pregnancy is not a high risk pregnancy. Yeah, RH negative pregnancy is not a high risk pregnancy. Why? Understand this thing, RH negative pregnancy becomes high risk pregnancy if patient has antibodies developed in her body. What do I mean by this? I'll explain everything. First you understand C, D, E. C and E are the 5 antigens. D, small d is absence of capital D. Okay. Now, if RH negative female marries RH negative male, marries matlab kulu mulu, the baby will always be RH negative. Agreed? Yeah, baby will always be RH negative, no doubt about it. If baby is RH positive, then there is something mochi mochi. Yeah, partner is not the dad of this baby. Okay, because there is no capital D antigen at all. So baby will always be RH negative. So if you are RH positive and your parents are RH negatives, both are RH negatives, and you have come out as RH positive, God bless you. I hope you understood. Guys, girls, now look at this. This picture says it all. She is RH negative. Okay, I can understand she is RH negative. She has small d, she is written, this is written as minus, so she is RH negative. He is RH positive. Yeah, they are doing kulumulu. Then what? Baby. Wow, jackpot. One chance jackpot. Great, baby. Can baby be positive? Yes, baby has acquired capital D from father. So baby is positive. This RH negative patient has RH positive baby. Now first time, understand this thing, first line you understand this thing, that baby will be safe inside her. The mother will not harm the baby, no, because mother does not have anti-D. What is anti-D? This is antibody to D antigen. Anti-D is absent. Those who are RH negatives in the audience, understand you do not have anti-D in your circulation because you are not yet exposed to capital D. Exposure happens. Exposure is by pregnancy or blood transfusion. Don't worry, I will dictate all these things. Right now you look at this picture. If you don't want to write, don't write, but first look at this picture. I'll dictate everything. RH negative, RH positive. Okay, baby is RH positive. Patient will not destroy her baby because she does not have anti-D. But in third picture, something wrong has happened. Positive baby has thrown positive RBCs into maternal circulation. Yeah, this is exposure. The patient is exposed. Has she developed antibodies? No, not yet. She is exposed. In next picture you are seeing anti-D positive. Anti-D is present. But where is the baby? Baby is already gone. That's why we say, first pregnancy is never affected an RH blood group, RH negative pregnancy. Because patient does not have anti-D, first baby escapes out. Yeah? Even if antibodies are produced, IgM will be produced. Because first antibody is always IgM. IgGs will be produced later on. Till that time baby is already out. So first pregnancy is never affected. Okay? Unless she is exposed due to some other reason, due to many reasons prior to pregnancy, then story is different. Remember, if she is not exposed, then understand that she will not destroy her baby. Give me 1 second. Hello? 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 हेलो दीदी, दीदी मेरा लेक्चर चालू है ऑनलाइन, मैं थोड़ी देर में बोलूं? या Sorry. Yeah. So yes, anti-D is positive in this fourth picture. Now, if this patient becomes pregnant again with positive baby, now she is ready with antibodies, and antibodies are IgG nowadays. Now, because these antibodies are long-standing antibodies, they are chronic antibodies, they are present since like many years. Now these antibodies will cross the placenta because they are IgG and they will destroy the baby. So next pregnancy will get affected because antibodies attacked the RBCs, and there will be anemia and then cardiac failure in baby. Yeah. So all these things written on the slide, I will write down in the notes. Please write down. Hopefully you understood this slide, how the second baby gets affected. Okay. So guys, second baby is getting affected, but we can do many things to prevent this destruction. Let us go systematically. Let us write Rh negative pregnancy. First thing first, I wrote C, D, E, small c and small e. Small c and small e. 5 antigens. Determine 5 antigens are present in Rh blood group. Yeah, 5 antigens are present in Rh blood group. D determines Rh positive blood. So Rh positive status is because of D. Small d, with small d, the resultant baby will be always negative. So safe pregnancy. Nothing will happen in this pregnancy. Okay? Step number 1, first step in management protocol. Is to check partner's blood group. You have to check partner's blood group as a first step. Let us know what is the blood group of partner. Yeah? Indian textbooks are writing blood group of husband. Bakwas. You have to check the blood group of partner. Okay? Not necessarily husband. Yeah. So check partner's blood group. Apostrophe S. Don't miss apostrophe. Not partners as in partners. Many partners. No. Partner apostrophe S. If partner's blood group is negative, if partner's blood group is positive, the treatment modality would be different. Partner blood group negative, safe pregnancy, you have to understand that nothing will happen to the baby. Routine antenatal care. Nothing special to be done about this pregnancy. So I told you, Rh negative patients, don't worry. Nothing will happen. Even if partner is positive, nothing will happen because we are there now. If partner is positive, then we want to know whether she has developed antibodies or not, due to any reason whatsoever. This pregnancy, past pregnancy, whatever. We don't rely on her history that she is primi gravida. Yeah? Understand this thing is she is telling primi. Who knows? She might have had abortion in past. She is not revealing. So you have to do a test to check anti-D in her body. And that test is called indirect Coombs test. ICT is to be done. Indirect Coombs test. In female, you have to do ICT to detect anti-D, whether she is carrying anti-D or not. If ICT is negative, which will be there in most of the patients because anti-D is not by birth, then she is labeled as non-isoimmunized case. So patient is non-isoimmunized. If ICT is positive, sad, bad. This is isoimmunized pregnancy. Isoimmunized pregnancy. ICT positive. This is high risk pregnancy.
Okay, I found.
This is high risk pregnancy. ICT positive is high risk pregnancy. ICT negative, non-isoimmunized, congratulations, baby will be safe because NTD is absent. So, management of ICT negative patient. What are you supposed to do if patient is ICT negative? You are supposed to prevent. So do prevention of isoimmunization. Prevention of isoimmunization. You don't allow the antibodies to form. Have a look at this picture again. Guys, this is the picture. Third picture is the picture where there is exposure. Don't you think these RBCs are going towards the immune mechanism for development of antibodies? Yeah? If I can destroy these RBCs in the periphery, then these RBCs will get destroyed and no RBC will reach the immune mechanism. Immune system will be virgin. Immune system will not get exposed. So, kill these cells. How do you kill these cells? These are positive RBCs of baby coming in mother's circulation. They are very less in amount, very minute amount, but sufficient enough to cause isoimmunization. So kill these cells by injection NTD. I'll write on another page. I hope you understood this plan of action is to kill the cells over here. So prevention of isoimmunization. How do you prevent isoimmunization? By injection NTD. Injection NTD. How much? 300 microgram, 50 microgram, 300 microgram and KB test. I'll tell you what I've written. Ignore this part till this point. Give injection anti-D. Within how many hours? Within 72 hours of exposure. Yeah? Within 72 hours of exposure. I'll take this figure. I'll take these figures somewhere else. Give me 1 second. I'll write these figures again. Don't worry about that. So injection NTD within 72 hours of exposure is to be given. Injection NTD can be given till 28 days of exposure. You can give it till 28 days of exposure. Mark my words. Ideally given within 72 hours. But if 72 hours are over, it doesn't mean you will not give. You will still give. Can be given till 28 days of exposure. Okay. This injection NTD will destroy fetal RBCs in maternal circulation. They will not destroy fetal RBCs in fetal circulation. You are going to give NTD injection to mother and these RBCs will be destroyed, called fetal RBCs in mother circulation. Okay. Now question is how much? How much NTD has to be given? The answer is 300 microgram for second and third trimester exposure. But 50 microgram only for first trimester exposure. Okay? 50 microgram for first trimester exposure. What do you mean by exposure? Exposure means abortion, procedure or delivery. There will be exposure, there will be mixing of blood and there will be exposure. So if there is first trimester abortion, 50 microgram, second trimester, third trimester, 300 microgram. Exposure means abortion, procedure or delivery. Then compulsory, 300 microgram IM injection. This is also IM. This is also IM. At 28 weeks. Even if there is no exposure, you have to give 300 microgram at 28 weeks. This is for prevention. You do not know what is happening inside the uterus. There might be little bit of mixing of blood. This injection will prevent this isoimmunization. So compulsory 300 microgram at 28 weeks. Remember, 1 microgram is equal to 5 international unit. Small calculation, 1 microgram, 5 international unit. Okay. Now, D, you have written A, you have written B, you have written C, you are writing D. In case of severe exposure, when exposure is very severe, example, abruptio placenta, example, twin pregnancy, example, intrauterine fetal demise, example, manual removal of placenta. Yeah, abruptio, twins, fetal demise, manual removal of placenta, these are considered as severe exposure cases. Then your 300 microgram injection will be insufficient. You have to do KB test called as Klehor Betke test. KB test. Klehor Betke test. I will take you back to that test called APT test. If you remember APT, we took blood which was antepartum hemorrhage blood coming out from vagina, and we had put alkali at that time, and we saw for hemolysis. Fetal RBCs are acid and alkali resistant. This test is also based on similar principle, that fetal RBCs are acid resistant. Fetal RBCs are acid resistant RBCs. So guys, what do you want to do by doing KB test? Have a look at KB test and then you will understand what I am talking about. We want to know how many RBCs are present in mother circulation. How many fetal RBCs are present in mother circulation? More the RBCs, more the NTD dosage. As simple as that. Now, we will take mother's blood and we will put acid. What will happen to mother's cells? Hemolysis. What will happen to fetal cells? No hemolysis. So you do microscopy and see. Don't write, I'll tell you what to write. Microscopy and see and count the fetal RBCs in a high power field. Yeah? This box is 100 high power field box. And you will count the RBCs. More the RBCs, more will be the dose of anti-D. Okay? So I will write Klehor test. You just look at this picture. Klehor test. You are seeing a slide, high power field with pink colored fetal, bright pink colored fetal cells which are still present because they are acid resistant. Maternal RBCs have become ghost cells. Okay? So now I will write down what is to be done if there is severe exposure. I said do KB test. In case of severe exposure, do KB test. KB test is based on principle that fetal RBCs are acid resistant. Take maternal venous blood, add acid. So we put citric acid buffer. We put acid and we do microscopy. Yeah, if there are 20 RBCs in one box, 20 RBCs in one box. One box is of 100 high power field. Yeah, there are 20 RBCs. It means 1 ml fetal blood is present. In mother's circulation. 20 RBCs in one box would mean 1 ml fetal blood in mother's circulation. Okay? If there is 1 ml fetal blood in mother's circulation, remember 1 ml requires 10 microgram NTD. Yeah? 1 ml fetal blood requires 10 microgram NTD. Okay? Which means your 300 microgram dose can nullify 30 ml only, 30 ml fetal blood only. Okay? What if fetal blood is more? I'll give you case. KB test shows 50 ml fetal blood in maternal circulation. How much NTD should be given? 50 ml fetal blood, very simple calculation. You will have to give 50 multiplied by 10, 500 microgram NTD. What is sir teaching? Sir is teaching so simple thing. KB test 50 ml, so obviously 500 microgram has to be given. Let's see another case. KB test done. It shows 20 ml fetal blood is present in maternal circulation. 20 ml fetal blood is present. How much NTD will you give? I will label this case as case number 2 just to see how many of you people are alive and awake. Please tell me how much NTD has to be given for this case. Tell me, how much should I give? Ta-dan, ta-dan. So many things are not clear. Yeah, I'll revise. I'll summarize. Okay, your answer is 20 microgram. No, not at all. 20 microgram, not at all. 200 microgram, the answer is still no. The answer is 300 microgram. The answer is 300. Remember, minimum NTD dose has to be 300 microgram. May the result be anything. Minimum dose is 300 microgram. Just write down this. I'll come in 1 minute. Yeah, I'm back. Remember, minimum NTD dose is 300 microgram. May the answer of KB test be anything. Remember, minimum dose has to be 300 microgram. I hope you have understood. Guys, I know it is sounding difficult. I will revise what I told you. At least you understood that you have to give NTD. Correct? NTD has to be given. Understood this point? You have to prevent isoimmunization. NTD has to be given. NTD will destroy fetal RBCs in maternal circulation. How much NTD has to be given? 300 NTD, 300 microgram for second trimester or third trimester exposure. 50 microgram for first trimester exposure, because in first trimester the amount of blood mixing is very less. So we have to give 50 microgram. 300 microgram for second trimester, third trimester exposure, 50 microgram for first trimester exposure. Then I said compulsory 300 microgram at 28 weeks just for safety purpose. And in case of severe exposure, do KB test, Clehor Bedke test. And Klee or Bedke test, remember fetal RBCs are acid resistant, we will count the number of RBCs. So KB test is a quantitative test. Yeah? APT test was quality. KB is quantity. We are calculating the dose, so KB is a quantity test. Okay, guys. Then I said that 20 RBCs in high power field, 100 high power field, 1 ml fetal blood, and 1 ml requires 10 microgram NTD. 300 would be nullifying 30 ml, but minimum dose has to be 300. Even if the figure is 20, 200 microgram will not be the right answer. You have to give 300 microgram NTD. Okay. This is how we prevent isoimmunization. The topic was ICT negative. Management of ICT negative. Remember, terminate ICT negative pregnancy at 40 weeks. Terminate ICT negative at 40 weeks. Those who are asking me, sir, if we do KB test and do NTD injection, are we supposed to get 300 microgram NTD again at 28 weeks? My dear friends, it is for severe exposure like abruptio placenta or a case of IUFD or a case of manual removal of placenta. If a patient has such case, you are not expected to wait and watch. Obviously, you will not repeat. See, understand 28 week is for those patients who are never given NTD injection. Yeah. So remember 300 microgram NTD at 28 weeks, and 28 weeks you don't expect KB test. No. Okay. So management of ICT negative, terminate at 40 weeks. Got it? Then management of ICT positive. How do you manage ICT positive case? How do you manage ICT positive case? ICT positive is already iso-immunized. You have to prevent the damage. You have to prevent the damage means you have to check for the fetal well-being and you have to remove the baby at the right time. So what are you supposed to do? You are supposed to quantify NTD levels by titration. You have to titrate out ICT. This is patient who is already ICD positive. Patient's own NTD is there. We are not giving any injection to her. She is already having ICD positive status. Quantify NTD levels by titration. Low titers, high titers. Low titers would be 1/2, 1/4, 1/8. Strange. High titers are 1/16 and more and above. See, 1/16 technically is a smaller figure, but remember 1/16 is a dilution titer. So 1/16 has more antibodies than 1/8. 1/8 has more antibodies than 1/4. This is a dilution titer method. Yeah, 1/16 is also called critical cutoff. This is high risk pregnancy. Yes, it is high risk pregnancy with critical cutoff crossed. Baby will get anemia. Yeah, low titers. Even though patient has antibodies, low titers, you just have to monitor. ICT plus USG. ICT has to be done 2 to 4 weekly and USG has to be done 4 weekly, and terminate at 37 weeks. You are not supposed to go beyond 37 weeks. Termination is at 40 weeks for whom? ICT negative patient. Termination is at 37 weeks for mild positive patients. What about high titers? 1/16 critical cutoff. You are supposed to evaluate fetal anemia. Evaluate fetal anemia. By what? There is a wonderful investigation available. It is non-invasive investigation. It is called middle cerebral artery Doppler. MCA Doppler. Understand the concept. that if the baby is anemic, there will be hyperdynamic circulation and the blood flow and velocity would be more in the middle cerebral artery, which will be detected by Doppler. So evaluate anemia by middle cerebral artery Doppler. If MCA, peak systolic velocity, what did I write? Middle cerebral artery, peak systolic velocity, MCA PSV, is more than or equal to 1.5 times multiples of mean. So it has increased 1.5 times the normal. MOM means multiples of mean. Yeah? MOM, multiples of mean. Middle cerebral artery peak systolic volume has increased and it has become more than or equal to 1.5 times multiples of mean. It means moderate to severe anemia. Baby is going to die if you do not intervene. So what are you supposed to do? You are supposed to give intra-uterine blood transfusion. Intra-uterine blood transfusion. Guys, intra-uterine blood transfusion is done by putting a needle right into umbilical cord and giving blood. The procedure is called cordocentesis. Yeah? Moderate to severe anemia, cordocentesis, intrauterine blood transfusion, O negative packed cells are given. Fresh packed cells are given. And terminate at 34 weeks. Don't forget, steroids are must in less than 34. In these cases, because you are terminating at 34, give steroids. For lung maturation. Okay? Terminate at 34 weeks. Let me summarize. Patient came to my clinic. She is Rh negative. I did first step. First step is partner's blood group. Partner blood group negative. Do nothing. Nothing has to be done. She is negative. He is negative. No problem. If partner blood group is positive, do indirect Coombs test, ICT. If ICT is done, patient may either be ICT negative or ICT positive. If ICT is negative, she is non-isoimmunized, safe pregnancy. Antibodies are not there yet. If ICT is positive, then antibodies are there. Yeah? If ICT is negative, you have to give injection anti-D at the right moment, right time. You have written the amount also, dose also, timing also. And it will prevent isoimmunization. Termination has to be done at 40 weeks. Okay? Yes, it's safe pregnancy, 40 weeks is the time. It is said that if you go beyond 40 weeks, there is more chance of mixing of blood and unnecessarily patient will become isoimmunized. I am talking about ICT negative patient. Terminate at 40 weeks. Okay? ICT positive patient. What are you supposed to do? Titration. See, know how much antibodies are there in mother circulation. How much risk is there to the baby. Low titers, wait and watch. Monitor till 37 weeks by ICT and USG monitoring. What about high titers? Do middle cerebral artery, peak systolic velocity. If it is more than or equal to 1.5 times MOM, then give blood and terminate at 34 weeks. Okay? Got it? Very clear? Guys, so this is the plan of action for a patient who is Rh negative. There are few important points. Steroids for lung maturity. Yeah, steroids should be given for lung maturity. Yeah. Guys, important point. Number 1, hydrops fetalis would mean severe anemia. I told you, na? Antibodies will cross the placenta, will cause hemolysis, will cause CCF, congestive cardiac failure. severe anemia would be there, and you have to give intrauterine transfusion. Yeah, hydrops vitalis means severe anemia. Number 2, Buddha's position is seen in hydrops. Buddha's position is seen in hydrops vitalis. Is this immune hydrops vitalis? Yes, it is most common cause of immune hydrops vitalis. Most common cause of immune hydrops vitalis, Rh incompatibility. Okay, yeah. Buddha's position is basically baby looking like Buddha with scalp edema. Scalp edema, there will be halo around head. That looks like, Buddha's position in sonography. This is seen in hydrops in sonography, ultrasonography. Most common cause of immune hydrops vitalis is Rh incompatibility. Then, anti-D injection. Anti-D injection is not given in number 1, ICT positive patients. Anti-D injection not to be given in ICD positive. She is already isoimmunized, so no need of giving anti-D injection in ICD positives. Number 2, in a patient whose partner is negative. Partner is Rh negative, there is no need of giving anti-D injection. Third case, if baby which is born has come out as Rh negative, then you will not give, because negative blood, even if it mixes with negative blood of mother, there will be no isoimmunization. So if baby is negative, you don't give anti-D injection. Okay, so guys, this is all about anti-D injection, when to give and not to give. Yes, if we give at first trimester 50 microgram, we will have to give at 28 weeks again. Yeah, anti-D injection generally remains in the body for 12 weeks. So remember, 50 microgram in first trimester doesn't mean you will not give at 28 weeks, you will still give. Steroids are given when the patient is ICT positive at that same time. Okay, any question, any more question? Yeah, steroids are given if patient is ICT positive. You never know, you might have to terminate early, so ICD positive gives steroid. IUT is intrauterine transfusion. Intrauterine transfusion. ICT test is quantity test. ICT can be titrated. Thank you so much, guys. Tomorrow we are going to meet at 9 AM sharp, and we are going to cover the remaining topics. If not, then yes, we will have a buffer for sure. That would be arranged. Don't worry, nothing will be avoided. Every topic would be covered. Okay, I promise you that. Okay, guys. So yes, hopefully you have understood things. I know I was slightly faster, but then there is mixed batch. So some students will definitely think that it is fast. Some students will definitely think it is slow. So revise these notes. Yes, there will be video available, and yes, you will understand many more things tomorrow. See you sharp tomorrow at 9 o'clock. Bye bye. Thank you. See you. Love you.
Hello everyone, a very very good afternoon to all of you. Good afternoon. And so good afternoon everyone, and it's a pleasure to get back to all of you. है ना, I hope everybody is logged in. और आज खुश तो बहुत हो गए तुम, है ना? So क्या है आज खुशी का कारण? कि हम गायनी खत्म करने वाले हैं. right? So how's everybody doing? I hope everyone is doing good. Okay. So we are going to begin with endometrial cancer today, and we have to do a couple of short topics after that, which is what we are going to plan. We have planned for today, है ना? और सारे बच्चे मेरे साथ attention pay करेंगे to concepts again, right? So हमारा goal वही रहेगा to clear all concepts in class, have a good set of class notes, so that at least 70 to 80% of things you remember from the class, और बाकी हम revise करते चलेंगे. And I'm very glad to see कि आप लोग साथ-साथ you're also solving DQB, right? And you keep asking your doubts, which is absolutely great, right? So keep the momentum going. This is the time when we need to accelerate, yes, and this is the time when we need to stick to our path, right? So इस note पे we will start off, and we will talk about endometrial cancer today in at first place, okay? Now, when we talk about endometrial cancer, it is relatively shorter as compared to the other two cancers, and most of the concepts we've already done, but we'll be reapplying them here. Now, when we talk about endometrial cancer, and we have to talk about risk factors. On what concept are risk factors based? What are the concepts on which the risk factors are based? So concept is again the same. More the amount of estrogen, right? So whether it is excess estrogen or it is unopposed estrogen, right? So excess estrogen or unopposed estrogen for a long time, yes, it will be a risk factor for endometrial cancer. And on the same note, what else? More the number of menstrual cycles, yes, the higher will be the risk, right? So more the number of menstrual cycles, higher will be the risk, right? So we will see how we understand this. So I'm going to extrapolate these two concepts into the risk factors. So pehla risk factor, we will keep it as early menarche and लेट मीनोपॉज, ठीक है? क्योंकि with early menarche and late menopause, there are more number of menstrual cycles. So endometrium is shed off, rebuilt, right? So continuous trauma and proliferation would be a risk factor. Third, nulliparity, okay? Again, based on same concept. If the woman has never been pregnant, it means she's been continuously having the menstrual cycles, so the risk will be higher. So nulliparity, then very important. You know about polycystic ovarian syndrome. It is going to be a risk factor because of the prolonged, unopposed estrogen exposure. There are three things that I want you to understand, okay? Obesity, hypertension, and diabetes mellitus, right? So obesity, hypertension, and diabetes mellitus, these three together definitely increase the risk of endometrial cancer. Okay, so association of these three, obesity, diabetes, and hypertension, with endometrial cancer is what is called as corpus cancer syndrome, right? So this is what is called as corpus cancer syndrome. Okay, so you should know this name. Then if I talk about genetic associations, they are also very similar to ovarian cancer, right? So the genetic associations are BRCA1, BRCA2, and HNPCC, right? And I hope you remember what I told you. What is HNPCC? Hereditary non-polyposis colon cancer syndrome, right? So HNPCC, you all know, is also called as Lynch syndrome. Yes, it is also called as Lynch syndrome, right? And remember that genes that are most important here are MLH1 and MSH2, right? So MLH1 and MSH2 are the important genes when it comes to the Lynch syndrome. Then anywhere else, if there is a lot of exposure of the estrogen, for example, long-term tamoxifen therapy. Yes, so long-term tamoxifen therapy. I am sure आपको पता होगा that tamoxifen is a SERM, है ना? Selective estrogen receptor modulator, right? So it is a SERM and it is given for long periods to breast cancer patients. Yes. So when it is given for long period, this drug does increase the risk of endometrial cancer, right? A very important point I want you to recall here. I had earlier talked about this. I want you to recall, beta ji. Raloxifene. Raloxifene, please remember, is also a SERM, but it does not increase risk of endometrial cancer. Okay, raloxifene, remember, has no genitourinary actions, right? So it has no genitourinary actions. So it does not increase the risk of endometrial cancer. The risk is increased with tamoxifen. If your patient has estrogen secreting tumors, we did a tumor in the last class. You remember? Granulosa cell tumor of the ovary. Yes, and I told you that it is a estrogen secreting tumor, right? So this granulosa cell tumor definitely increases the risk of endometrial cancer as well. And if you recall, I told you, when you diagnose granulosa cell tumor in a lady, you must look at the endometrium as well for endometrial cancer. Okay, now, some very important things that I want you to understand. The first one, HRT, right? So, postmenopausal hormone replacement therapy. Yes. So, postmenopausal HRT, does it increase the risk? So, you have to be very careful. It will be a risk factor only if you are giving only E type of therapy to a woman. Yes. So if she has an intact uterus, which means she has not undergone hysterectomy, and now you are giving her only E therapy, then yes, it will increase the risk. But if we talk about E plus P beta G, then it does not increase the risk. So E plus P type of therapy does not increase the risk. Only E will increase the risk. Very important. Can you all recall and tell me, if you give E plus P type of HRT, ये हमने पहले किया था, right, in the second class when I did the physiology with you. If we give E plus P type of postmenopausal HRT, which cancer risk is increased? What will you answer? If you have to mark one cancer, which the risk of which is increasing with postmenopausal E plus P therapy, which cancer is it going to be? So, very good. Excellent. Yes, you are all revising and I am so very proud of all of you. Yes, then you have to mark it as breast cancer. Perfecto. Very good. Then, something which is very interesting here and I want you to know. So, now I'm going to talk about what is going to decrease the risk. Right? So, what is going to decrease the risk? Again, breastfeeding. The explanation is same. The longer the woman breastfeeds, she is likely to stay amenorrheic, right? So the number of menstrual cycles will reduce. So breastfeeding is protective, okay? OCPs, beta G, oral contraceptive pills, okay, are going to reduce the risk. If I ask you how, beta G, what will you tell me the why? They cause thinning of the endometrium. Yes, because thinning of the endometrium, that's also the mechanism how they reduce the bleeding. Okay, so OCPs reduce the risk, beta G. Breastfeeding reduces the risk. Very, very interesting. Something that I'm going to now write is smoking. Smoking is protective, beta G, for endometrial cancer, right? So this is very interesting. Normally we say that smoking is going to increase the risk of almost all malignancies, right? But when it comes to endometrial cancer, smoking is protective. Now, we do not know the exact proven mechanism, but what is the proposed mechanism is that smoking inhibits, or rather increases, okay, metabolism of estrogen, right? So smoking will increase the metabolism of estrogen, right? And that's how it is a protective factor, right? Now, please remember one thing. When we say smoking is increasing the metabolism of estrogen, what else can you tell me? All estrogen dependent disorders, right? All estrogen dependent disorders, smoking will be protective for them, right? So smoking will be protective for them. For example, do you remember which one did we in the last class? Example is endometriosis, right? Another example which we will do today in the class is fibroid uterus, right? So all the estrogen dependent disorders will, smoking will be protective for those disorders. Now, very important, if I now ask you, does that mean that Dr. Deepthi is going to ask all her female patients to go and start smoking? So no, that's not an advice. This is more of a theoretical question rather than a practical advice. So you always weigh the risk-benefit ratio, right? So smoking से शायद endometrial cancer protect हो जाए, मगर और बहुत कुछ होना शुरू हो जाएगा, right? So this is not an advice, but this is something which is theoretically important, right? So understand this. So smoking is protective, right? Then, yes, multiparity can also be protective because it is the same concept, bache. What is the concept of multiparity? Multiparity means she is going to be pregnant for a long time. 1 baby, 2 babies, 3 babies, which means the number of menstrual cycles will reduce, right? And the progesterone component will increase, right? So multiparity, yes, it is the reverse of nulliparity, and you can put it in the protective factors as well. Okay? Then, physical activity. And also something which is very interesting is green tea consumption, right? Now, I am not going to elaborate too much on these 2 points because we really don't know how much exactly of the physical activity or how much green tea consumption will reduce the risk. But yes, these are, proven protective factors. So physical activity and green tea are protective for endometrial cancer, right? So these are the protective factors for endometrial cancer that you should know. Is it clear to everyone? Right. Now, coming to, when it comes to endometrial cancer, there is something very, very important that we have to know about endometrial cancer, and that is histopathology. Okay? Right? So we will talk about something that you have to know about histopathology of endometrial cancers. Now, on the basis of histopath, we divide endometrial cancers into type 1 cancers and into type 2 cancers. Okay? Now you have to listen to me very carefully. All right? Type 1 cancer. All right? Type 1 cancer are called as endometrioid in histology. So if it is endometrioid, it is type 1. And generally we say that non-endometrioid will be type 2, right? Magar, if you remember this like this, which is a little superficial, right? Then you may do certain detailed MCQs wrong. What is the detailing now? So I'm going to give you the detailing now. Endometrioid histology with grade 1 and 2 tumors, right? Now, I'm sure you have done your pathology and you will tell me what is grade of a tumor. Can you tell me what is grade of a tumor? So grade is what? Grade is differentiation or maturation of the tumor tissue. So please understand, the more mature the tissue, will it be grade 1 or grade 3? So if they are very well differentiated, will it be grade 1 or grade 3? So grade 1 is actually well differentiated. Whereas grade 3 endometrioid, okay, grade 3 endometrioid means poorly differentiated. So now please understand this. The general classification was endometrioid and non-endometrioid. But if the MCQs ask you in detail, then this is what you have to know. In the endometrioid category as well, if it is grade 3 tumor, right? So if it is grade 3, then it becomes type 2. It is no longer going to be put as type 1. Samajh gaye bache? Right? So type 1 are only endometrioid grade 1 and 2, right? Whereas endometrioid grade 3 is put under type 2 histology. Is this clear to everyone? This is so that you don't get confused in two options in the exams. Now, when I say non-endometrioid is type 2, all other histologies will come under type 2. For example, serous, papillary, right? Clear cell. These will all come under type 2 histology. Now, if you are wondering, madam, why are we dividing it into type 1 and type 2? The most important reason why we are dividing it into type 1 and type 2 is because this is what is going to determine the prognosis in my patient. Type 1 tumors are the ones which have good prognosis, whereas type 2 have poor prognosis, right? So type 1 tumors have good prognosis and type 2 have poor prognosis. So this is why I really want to know what is the histology in my patient, right? Because this determines the prognosis. Now in the type 2 also, generally they have poor prognosis, but we will ask you which among the type 2 will have worst prognosis. So the worst prognosis is with clear cell cancer, right? So among type 2, the worst prognosis is with clear cell cancer. Yes? Do you know what is the classic histopath finding of clear cell cancers? So wherever clear cell can happen at a lot of places, it can happen in the tubes also. That's a histology, right? So it can happen in the uterus also. So what is the classic finding of a clear cell cancer? What is the finding? The finding in clear cell is a hobnail cell, right? So there is clearing of the cytoplasm and the nucleus is slightly pushed outside. Yes, and it's called as a hobnail cell. So the classic histopath finding of clear cell is hobnail cell, right? Now, let us look at more things that differentiate type 1 and type 2. Now, type 1 tumors, we call them as estrogen dependent. Okay, so they are estrogen dependent tumors. Whereas type 2 are estrogen independent. Okay, they are estrogen independent, which means these cancers, the type 2, can happen even when there is no excess estrogen, right? So these ones can happen even when there is no excess estrogen. So that is a type 2 cancer. Type 1 cancer, because they are estrogen dependent, right? They will be associated with obesity. Whereas if a thin lady, right? Whereas if a thin lady develops endometrial cancer, then it is likely going to be type 2 cancer, right? So if endometrial cancer happens in a thin woman, it is likely to be type 2. Also, when I say that type 1 are estrogen dependent, yes, these will also be associated with pre-invasive lesions, right? So they can be associated with pre-invasive lesions like endometrial hyperplasia, right? Whereas type 2 cancers, since they are not estrogen dependent, they are not having pre-invasive lesions. Okay? Then, which out of the two is more common? Which is more common? Are type 1 cancers more common or type 2 cancers more common? So, more common are type 1 cancers. 80% of cancers of the endometrium are going to be type 1, right? Whereas the 20% ratio is for type 2 cancers. So type 1 are actually more common. Now, also there is an association with age. Jitni zyada age hogi, right? Increasing age, it is the histology starts moving towards type 2, right? For example, if a 60-year lady develops endometrial cancer, it is likely to be type 1, okay? But if a 70, 75-year-old woman develops endometrial cancer, it is likely to be type 2. So both these cancers are seen in, post-menopausal women, both of them. But the more the age, the higher is the risk of type 2 cancers, right? So the higher will be the risk of type 2 cancers. Now, if I have already told you which of these has good prognosis and which of these has bad, let me see if you recall the little concept I gave you in the last class. High risk cancers will have which genetic mutations? मैंने बोला था सिर्फ एक ही चीज याद रखो और सारे कैंसर्स में आप आंसर कर पाओगे. हाई रिस्क कैंसर्स हैव व्हिच जेनेटिक म्यूटेशन? बताओ. व्हाट वाज द आंसर बच्चे? सो हाई रिस्क कैंसर्स आर एसोसिएटेड विद P53 mutations. So type 2 cancers are associated with P53. Okay? Whereas, what did I tell you about low risk cancers? P10 and KRAS mutations. Yes? So KRAS is usually associated with low risk. Now, among P10 and KRAS, okay, so among P10 and KRAS, remember, the P10 genetic mutation is, or P10 gene, I would say, right? The P10 gene is called as gatekeeper gene for endometrial cancer, right? So it is considered as gatekeeper gene for endometrial cancer. Remember this, can be asked as a one-liner. Now let me see if you remember your pathology. Which syndrome is associated with P10 mutations? Which syndrome is associated with P10 mutations? Very good. आप लोग बहुत ही super bright हो. So Cowden's syndrome. Okay, Cowden's syndrome. Yes, will also be having P10 mutations, which means in the exams, if they ask you Cowden syndrome, will they have higher risk of endometrial cancer? Yes or no? The answer is yes. Okay, so Cowden syndrome, also there is increased risk of endometrial cancer. Second, they might ask you, Cowden syndrome will have endometrial cancer. What is the likely histopathology? What will you say? Endometrioid, papillary, serous, or clear cell? Endometrioid. So in Cowden syndrome, you see type 1 endometrial cancers. Okay, so in Cowden's, you will see type 1 endometrial cancers, right? Also, now I have given you 4 genes or genetic mutations associated with endometrial cancer, right? I told you about BRCA1, BRCA2, then I told you about HNPCC, and then I told you today about Cowden's, right? We might want to ask, out of all the 3 genetic mutations, which of these has highest risk of endometrial cancer? What would be the answer? Which of these has highest risk of endometrial cancer? What would be the answer? The answer is HNPCC. Okay, the answer is HNPCC. So please remember that in HNPCC, the risk of endometrial cancer is up to 70 to 80%. Very high risk. Okay, they have very high risk of endometrial cancers. Cowden syndrome has increased risk of about 20 to 25%, right? So both these genes are associated with high risk, but the highest risk is with Lynch syndrome. Again, I would want to ask you on the same concept. Lynch syndrome, okay, will have which endometrial cancer? Lynch syndrome will have which endometrial cancer? So please remember that Lynch syndrome, okay, will also have type 1 cancers, okay? Lynch syndrome are also associated with type 1 endometrial cancers, okay? Don't worry, it'll be fine. There was a little blackout, but it's okay now, right? Okay, hold on. Let me see. Don't worry. ब्लैक हो गया पूरा. यहाँ से तो मेरे को देखना नहीं ना.
कुछ इंटरनेट से करो.
Okay, I think I'm going to be back soon with you. Are you able to hear me, guys, all of you? Yes, and see me as well? Okay, so I will just repeat what I was doing. I'm just going to repeat what I was doing. Yes, I'm back now. Okay, so I said I have talked about 3 genes or genetic mutations associated with endometrial cancer. So I said these could be BRCA1 and 2, HNPCC, or Cowden's. Then I said the highest risk is with HNPCC. The risk can be as high as 70 to 80%. In Cowden's, it is 20 to 25% risk of endometrial cancer. And then I was saying that in both these syndromes, whether it is Cowden's or it is Lynch, which type of endometrial cancer will happen? It will be type 1 cancer, right? So even in cowdens, it is obvious it is going to be type 1 cancer, right? So both for cowdens and Lynch, the association is with type 1 endometrial cancer. Yes, are you all with me? Okay, now once we know this, let's go on to some more details about endometrial CA, right? The first being, what is the most common presentation? Okay, so after the histology, I want to talk about presentation. So what is the most common presentation of endometrial cancer? Again, it will be irregular vaginal bleeding, right? It will be irregular vaginal bleeding. That is the most common one. What is the most specific complaint? So the most specific complaint is post-menopausal bleeding. Okay, post-menopausal bleeding. Again, I would just want to say this here, that although we are saying that it is most specific complaint, right, which is post-menopausal, it does not mean that all women with post-menopausal bleeding will have endometrial cancer, right? Please listen to me very carefully. Actually speaking, only 10% of women with post-menopausal bleeding have endometrial cancer. So actually only 10% of women have endometrial cancer. The other 90% don't have endometrial cancer. Yes? So then it comes to, what are other causes? Right? So what are other causes of PMB? Right? We should know that as well. But as a clinician, मेरी बात ध्यान से सुनो, as a clinician, yes, when we talk about post-menopausal bleeding, what is my duty? That I am, okay, that 90% don't have cancer, but my duty is to find out those 10% females who do have endometrial cancer, right? So to find out those 10% females who will have endometrial cancer, right? So, but I should know what are the other causes as well. So in fact, you have to know that the most common cause, okay, most common cause of PMB, post-menopausal bleeding, is atrophic endometritis. So we all know that the endometrium is going to undergo atrophy. It becomes very thin. And again, when it becomes very thin, it can break, right? And it may cause bleeding, right? So atrophic endometritis is the most common cause of post-menopausal bleeding, right? So the other causes that you should know are endometrial polyp, fibroid, right? So endometrial polyp, fibroid, then endometrial hyperplasia, okay? Endometrial hyperplasia. Then what else it can be? Adenomyosis. And it can also be cervical cancer. Because, you know, cervical cancer most commonly happens in younger women, but it can happen in older women as well. I told you it has a bimodal peak, right? So if it has a bimodal peak, the second peak is going to happen at, in a later age group, the 5th and the 6th decade of life, right? So please remember this, that most common cause of postmenopausal bleeding is atrophic endometritis. Also remember, atrophic endometritis is also called as, okay, it is also called as senile, means old, right? So it is also called as senile endometritis. Right? So it is also called as senile endometritis. Right? Now, since PMB becomes a very important, symptom, therefore, because when someone comes to me with PMB, I think that I have to rule out endometrial cancer. Yes, so I have to rule out endometrial cancer. So we will now talk about what are we going to follow approach if a lady comes to us with postmenopausal bleeding. Okay, so listen to me very carefully now. So if a woman comes to us with postmenopausal bleeding, what should we do with her? So सबसे पहले तो, how exactly do you define postmenopausal bleeding? Any bleeding that happens after a period of menopause. It's as simple as that. And you know what is the definition of menopause, right? So any bleeding, by any I mean, it could be spotting, it could be a little more than spotting, or it could be major bout of bleeding, right? So any bleeding after menopause is taken as postmenopausal bleeding, right? Is taken as postmenopausal bleeding. HNPCC में रिस्क होता है 70 to 80% for endometrial cancer, all right? And Cowden's में था 20 to 25% for endometrial cancer. That is the risk of cancer of the endometrium in these syndromes, all right? Now, once we talk about this, what are we going to follow as an approach if a lady comes to us with postmenopausal bleeding? Okay. Now, before I go on to the approach, what is the most common age group for endometrial cancer? The most common age group, right, for endometrial cancer is, again, the same time, it is from the 5th to the 7th decade. Okay, so from the 5th to the 7th decade, and that is why they are going to present in the same age. Okay, they are going to present as bleeding. So most common age group is 5th to 7th decade for endometrial cancer. And if we ask you peak age, right? So peak age incidence, this is going to happen at 60 years, right? So peak age incidence is at 60 years, right? So that's the age group. Also remember that the most common pattern of spread, okay, or route of spread is direct, right? So most common route of spread for endometrial cancer is also a direct spread. Just like we talked about cervical cancer. Now I'm going to give you the algorithmic approach that you should follow, right? If a lady comes to us with postmenopausal bleeding. So what should we do first? So if she comes to us with postmenopausal bleeding, we will first do a transvaginal ultrasound, right? So we will do a transvaginal ultrasound. Why? What will we look at in our TVS? So we want to look at two things. We want to look at endometrium and we want to look at anatomical causes of bleeding, right? Like a polyp, fibroid, adenomyosis, right? So we want to look for anatomical causes of bleeding as well as the endometrium on ultrasound. Now, what exactly are we going to look at in the endometrium? We are going to look at endometrial thickness, right? And we have some direct guidelines here. The guidelines say if the endometrial thickness is less than or equal to 4 mm. Okay, so if the endometrial thickness is less than or equal to 4 mm, then there is no increase in risk of cancer, right? So there is no increase in the risk of cancer, right? Whereas if the endometrial thickness is more than 4 mm, then my patient has increased risk of cancer, right? So then my patient has increased risk of cancer. Okay? Now, what is the problem with TVS or ultrasound? Ultrasound only tells us about risk. It does not tell us कि endometrial cancer है अभी या नहीं है, right? So it only tells you about risk. It does not tell us whether the cancer is present right now or not, right? Which means TVS is a good first investigation, but it is not the investigation of choice, right? So please remember, it is not investigation of choice. So transvaginal ultrasound is not IOC. It does not tell us whether cancer is present or not, right? It only tells us whether she is at high risk or not, right? Which means I must go ahead and do something if my patient is high risk to know whether the cancer is present or not, right? Now tell me this. If the endometrial thickness turns out to be more than 4 mm, yes, what are we going to do next? What should we do next? The next thing has to be the investigation of choice, right? So please remember, ET more than 4 mm as a high risk is only valid for which age group, beta ji? For which age group? This is a criteria only for postmenopausal women. In the reproductive age women, because of a lot of fluctuation in the endometrial thickness, we do not follow this cutoff. Okay, so this cutoff is only and only valid for postmenopausal women. All right, now the investigation of choice has to be something where we will do take a tissue sample from the endometrium. So the broad word is endometrial sampling. Please clear your concepts with me today. It is very important. Okay. So the broad term is endometrial sampling, which means I am going to take tissue from the endometrium and I will send it for histopathology. Yes. Now comes, how do I take the tissue? The tissue from the endometrium can be taken as an outpatient procedure and can be taken as a OT procedure. Yes, so I have to take a tissue. I can take it as an outpatient procedure or as an OT procedure. Now you will tell me, which one do you think should be the investigation of choice? The outpatient procedure or the OT procedure? Batao, dimag lagao and tell me, which out of the two should be preferred as a IOC? Which one should I prefer? The answer will be the outpatient procedure. When you can do something in the OPD itself without any anesthesia and it will still give you a tissue, then that is definitely better than taking her to OT, giving her a full anesthesia and then taking the sample. Yes, perfect. Good. So your concepts have to be clear. Wonderful. Now, once you are doing an outpatient procedure, what are the options we have? So one is called as endometrial biopsy, right? Where we use a biopsy forceps to take the sample, right? But there are other methods as well with which we can take the sample, right? Which is called as EAC. What is the full form of EAC? Endometrial aspiration cytology. Okay, endometrial aspiration cytology. Okay, which means I'm going to aspirate from the endometrial cavity, which is going to give me the cells. The exfoliated cells are picked up and they will be sent. So since you're picking up cells, we are calling it as a cytology, right? So endometrial aspiration cytology. This is less painful than even an endometrial biopsy. Okay, so EAC is even less painful than a aspiration endometrial biopsy, right? EAC किससे करते हैं? So in countries like India, where we do not have special equipments, yes, we will do what? We will take Carman's cannula. So to do the cytology, we can use a Carman's cannula. And if we were living in America, UK, and we had a lot of money, we can use special instruments as well, right? Those special instruments are called as pipel and a Vabra aspirator. Okay, a pipel or a Vabra aspirator. These are all methods of doing a aspiration cytology, right? But what are we going to see in our OPDs? We are mostly going to see Carman's cannula, right? So the Carman's cannula is also used for endometrial sampling. Is this part clear to anybody? Okay. Now, we have to know when we will do the OT based procedure. Yes. So now I will tell you what is the OT procedure and when will you do the OT procedure, right? So let's see, when do we do the OT procedure? Now, OT procedure is definitely going to be more invasive than an outpatient procedure. Yes, it's going to be more invasive than an outpatient procedure, and it will have the risk of anesthesia as well. So you have to be very sure when you want to do the same thing with more risks as compared to doing it in an OPD. First, since we are doing the endometrial sampling in a post-menopausal women, is it likely that the cervix of a post-menopausal woman can be stenosed? Yes? Yes. So sometimes the cervix or the cervical opening of a post-menopausal woman can be stenosed. So when the cervix is stenosed, okay, then I have to dilate the cervix first, and dilatation of cervix is going to cause pain, right? So the dilatation of cervix is going to cause pain, right? And since it is going to cause pain, you should do this procedure in the OT. So the first is cervix is stenosed. Second indication, if I have done an endometrial biopsy, right? Let's say I have done a biopsy, but the report says no endometrial tissue seen, which means I tried to take out tissue, but there was no sample obtained. So I have to repeat the procedure. Now, which procedure would you want to repeat? Is it a game that we can keep doing with the patient? Ek aur baar karte hain, chalo ek aur baar karte hain. No, right? So remember, you're dealing with patients. So if the first sampling did not give you any results in terms of tissue, then you should go ahead and do a what? You should do a OT based procedure. All right. Then third, suppose we have done an endometrial biopsy and the report says that there is no malignancy, right? So the report is saying that there is no malignancy, but patient has persistent symptoms, right? Patient has persistent symptoms. Okay. Then Do you think we should try and re-evaluate her? Now, what do I mean by persistent symptoms? Persistent symptoms means she continues to have postmenopausal bleeding. Right? So if she has consistent or continuous symptoms, right, which means she keeps bleeding off and on, then I should really re-evaluate her, right? And this time I want to be very sure of what I am going to do, right? So if the symptoms persist, she is going in for a OT based procedure, right? Fourth, suppose we have done a endometrial biopsy or an outpatient procedure, right? And the report of outpatient procedure comes as atypical hyperplasia. Then please understand one thing. Atypical hyperplasia, right, has a very high risk of malignancy, which may be already present, right? It can convert into malignancy later. And in some area, it is possible that in some other area of the endometrium, there may already be a malignancy, right? So if the report comes as atypical hyperplasia, right? So these are some very important indications when you should be doing a OT based procedure. So if the cervix is tightly closed and you cannot do an outpatient procedure, if the biopsy report is benign, but the patient has persistent symptoms, or if the biopsy report says there is no tissue obtained and the pathologist cannot give a report only, then again we do a OT based procedure, right? And if the report comes as atypical hyperplasia on an outpatient procedure, right, then it is very important that you be doubly sure that there is no cancer, right? So which OT procedure do we do? The OT procedure is a DNC and hysteroscopy, right? A DNC and hysteroscopy. Okay, so please listen to me very carefully. A DNC stands for what? Dilatation and curettage. Now, please remember that the DNC is a blind procedure, right? Which means I simply take a curette in the uterus and I'm going to take samples from the endometrium, right? But because it is a blind procedure, I may miss, okay, some area in the endometrium. So what I do is I combine it with a procedure which also gives me direct vision of the endometrium, right? So I do a DNC and along with it, I do hysteroscopic biopsy as well, right? So one will be a blind procedure. The other one is under vision. What is a good thing about hysteroscopy? Tell me, what is good thing about hysteroscopy? Hysteroscopy, is good for focal lesions. Right? So, which means if some part of the endometrium looks very different from the remaining part, I will be able to identify it and I will take a sample from it. But can you tell me, is hysteroscopy good for global lesions? Batao. Is hysteroscopy good for global lesion? Tell me. The answer is no. Why? Because global matlab pura endometrium ek jaisa dikhta hai, right? So hysteroscopy pe you will not be able to make out that some part is very different from the other part. And therefore you may miss out on the sampling, right? So please remember that there are benefits of both. A DNC will help you sample all the parts, whereas hysteroscopy will help you sample any focal lesions, right? Which may be missed on DNC. Either of the two alone is not the best thing. So they both should be combined. And anyways, you're giving anesthesia to your patient, do the best procedure that you want to do, right? So we will do a DNC and hysteroscopy. One will give me random samples from the entire endometrium. The other one will give me focal samples. If I find any specific area, I will sample that area, right? Now, please also remember, DNC is often called as FC. So don't get confused. They mean the same. FC stands for fractional curettage. Okay, FC stands for fractional curettage. The only thing that I would like to specify when I say fractional curettage, that in fractional curettage, you will take samples from endocervix and you will take samples from endometrium and send them in separate vials. Okay, so the sample from the endocervix and the sample from the endometrium will go in different vials, right? So this is what is fractional curettage, but for your exam purposes, we use it synonymous to a DNC. So don't get worried whether they write DNC or they write FC, it means the same. Okay, is it clear to everyone, right? And if I may ask you, right, I hope in cancer cervix you understood the concepts. Tell me which one you will sample first. Will you sample the endocervix first or will you sample the endometrium first? Endocervix को पहले sample करेंगे या endometrium? So first we will sample the endocervix and then we will sample the endometrium. Why? अगर आपने endometrium पहले sample कर दिया, the cells of the endometrium can fall into the endocervix, right? So first you should sample the endocervix, then you should sample the endometrium, right? So this is what is FC and DNC, okay? Now please also remember this particular procedure that I have written, DNC and hysteroscopy, is considered as gold standard for post-menopausal bleeding. Yes, so this is considered as gold standard for post-menopausal bleeding. So now first quickly answer with me, all of you, let me see who all can answer correctly. A lady with post-menopausal bleeding, what will be the first investigation that you want to do? Very good. Transvaginal ultrasound. Excellent. If the lady has a thickness of more than 4 mm on ultrasound, what do you do as the investigation of choice? Endometrial biopsy or EAC, endometrial aspiration cytology. Very good. Then tell me if there is any discrepancy like no tissue obtained or continuous bleeding or atypical hyperplasia, or if the cervix is stenosed, then what should I do? I should do the gold standard procedure, which is fractional curettage or DNC with hysteroscopy, right? What are other investigations that you should do? Other or kaun sa karna hai? The other investigations that I must do is pap smear, right? So if the lady has never undergone cervical cancer screening, you must also do a pap smear. But please remember, pap smear, it has not to be answered as investigation of choice or first investigation. It is one of the other investigations that you will do, okay, in a patient with post-menopausal bleeding. Is it clear to all of you? We will do a pap smear, but it is not the investigation of choice. Okay. Also, what word did I say was an indication to do paps first? In case we use post-coital bleeding. Do you remember? I said the specific complaint for cervical cancer is post-coital bleeding. Yes. Is it clear to everyone? Okay. Now, very, very important concept. This is when a lady is postmenopausal and she is coming to us with postmenopausal bleeding. Now, listen to me very carefully. Okay. Listen to me very carefully. Right? Any patient or woman, I will say, any woman who's more than or equal to 45 years of age, okay? Any woman who is more than or equal to 45 years of age, which means she is not yet menopausal, है ना? Not yet menopausal. Yes, then what should you do? If she has abnormal uterine bleeding, right? So if she has abnormal uterine bleeding, what should you do? Let me see how much you recall from my previous classes. What would you want to rule out first? Batao. What would you want to rule out first? Let's see. Pregnancy. Okay, always remember, first rule out pregnancy. Whenever a lady comes to you with abnormal bleeding, rule out pregnancy, right? Second thing, the next thing you will do is ultrasound to look for anatomical causes, right? And you must also do endometrial sampling before you give hormonal treatment. So listen to the concept very carefully. Now I am talking about a woman who is not postmenopausal but is more than 45 years of age and has come with abnormal bleeding. Let's say menorrhagia. Okay, that's just an example. Now please remember, right? Please remember, when you talk about this, which is more than 45 years and abnormal uterine bleeding, you have to first rule out pregnancy. You do an ultrasound to look for anatomical causes. You may find an anatomical cause, you may not find an anatomical cause. You know, irrelevant of that, you will do endometrial sampling. Who will tell me a gross difference here? Who will tell me a gross difference here? We are not talking about any endometrial thickness. Do you realize this? So if she is not postmenopausal, I am not talking about any cutoff for endometrial thickness. I am saying if she is more than 45 years and she has come with abnormal bleeding, apart from a pregnancy test in TVS, you must do endometrial sampling before you start any treatment. Why? Because the risk of cancer begins to increase beyond 45 years, right? So risk of cancer begins to increase beyond 45 years. Is this clear to everybody? Yes or no? Right? For example, you know, I would say, let me give you an example. A lady is 46 years of age. Yes, so let's say she is 46 years. She presents to us with menorrhagia for past 6 months. Okay. I have done an ultrasound and she has a 2 into 2 centimeter fibroid. Okay. And I'll be more precise a little later, in her uterus. My question to you is, should you still do endometrial sampling or start treating her for fibroid? Tell me. Should you do a sampling of the endometrium or should you start treating her for the fibroid? So please remember, keep this in mind. Okay. Especially, you know, what they will add here is if she has a 2 into 2 centimeters intramural fibroid, right? That's what they will write, right? So they're just trying to confuse you. So please remember this, that if she is more than 45 years of age, even if you have found out something in the ultrasound, right, you still have to do the sampling before you start treatment. Is the concept clear? Yes. I will talk about this example one more time when I teach you fibroid, but this is very important here. Okay. Now, the third component. If a woman is less than 45 years, if a woman is less than 45 years, then what are indications for endometrial sampling? Okay, so if your patient is less than 45 years, what are the indications for endometrial sampling in this case? So the age is less. So now let me see if there are some bright ones here. Batao, agar age kam hai, fir bhi, when would you like to take a sample? Tell me. Very good. Excellent. When the patient is high risk. So if the patient was high risk for cancer, then even if she is less than 45 years, if she has abnormal uterine bleeding, I should take sampling if she has high risk. For example, women who are known cases of Lynch syndrome, women who have Cowden's syndrome, women who have PCOS, women who have granulosa cell tumors, right? Do you understand the concept now? So when the age is less than 45, then also in some patients, I might have to do the sampling, but these are only high risk patients. For example, Lynch syndrome, Cowden syndrome, PCOS, and granulosa cell tumors. Is this clear to everybody? These are very important for your exams. And jab tak concept clear nahi honge, MCQs will keep confusing you. So you have to be very, very confident in answering. If the age is less, when will you mark sampling? If the age is more than 45, then what will you do? And if she is postmenopausal, then what will you do? Right? Is it okay to everyone? Bache, if the thickness is less than 4 mm, then there is no risk of cancer. It's just atrophy which is causing the bleeding, which will subside by its own. So you don't have to do anything in that case, right? So if the thickness was less in postmenopausal women, then you don't have to do anything, okay? Now, let's look at, yes, if the patient has been receiving long-term tamoxifen therapy. But then again, tamoxifen and breast cancer is usually in older women, right? Not such younger women. Younger women only if they have familial cancers. Yes? Okay. Now, if this is clear, coming to the pre-invasive lesions now. So if we talk about pre-invasive lesions, right? I told you this is endometrial hyperplasia. Yes, endometrial hyperplasia. Okay. Now, endometrial hyperplasia, I have to ask you on one note, is it a histopathological diagnosis or is it a clinical diagnosis? What would you say? Histopathological or clinical? This is a histopath diagnosis. So you know that you have done endometrial biopsies, and the endometrial biopsy or sampling report will come as hyperplasia, right? So let us see on histopath what are the different types of hyperplasia that you should know. Okay, so there is simple hyperplasia, without atypia. Then there is complex hyperplasia without atypia. Then there will be simple hyperplasia with atypia. And lastly, complex hyperplasia with atypia. So these are the 4 types of hyperplasia that we may come across on tissue diagnosis. On what basis does the pathologist say whether it is simple or complex, right? So when the pathologist uses the word simple, what would the pathologist be saying? That there will be increase in stroma as well as increase in glands, right? दोनों proliferate कर रहे होंगे, stroma भी और gland भी. And along with this, you will see cystic dilatation of glands, right? So along with this, you will see cystic dilatation of the glands. And this is therefore also called as cystic glandular hyperplasia. Okay, so this is therefore also called as cystic glandular hyperplasia. Right? So this is what is simple hyperplasia. And a classic finding on histopath in such a hyperplasia can also be of what? Swiss cheese pattern. Right? So on histopath, we can sometimes get a classic pattern which is called as Swiss cheese pattern. Right? And this condition where you get Swiss cheese pattern on the histopath is called as metropathia hemorrhagica. Right? So metropathia hemorrhagica is the special thing that you name it. You give this name when you see the Swiss cheese pattern on histopath. Right? So even before I tell you something else, can you tell me what would be the problem? Why would someone develop cystic glandular hyperplasia or simple hyperplasia? The answer is again the same. If there is unopposed estrogen or excess estrogen, yes. So if there is unopposed estrogen or there is excess estrogen, then, there is going to be, or it is possible to get different forms of hyperplasia. The most common being cystic glandular hyperplasia or simple hyperplasia. Is this clear to everybody? Okay. What is the term complex mean? What is the word complex mean? Or before I go on to that, can I see this cystic glandular hyperplasia in perimenopausal women? Yes or no? Can we get this in perimenopausal women? Yes. We all know because their cycles are anovulatory, right? So it's very often that you will get this in perimenopausal women. Right? So you will get this because of anovulatory cycles, where there is unopposed estrogen. Very good. Perfecto. Now, going on to complex hyperplasia. What does the pathologist see when they give you the report is as complex hyperplasia? Then what they see is that the glands are proliferating much more than the stroma, right? So now the glandular elements are proliferating much more than the stroma. So, the image that they would be getting on the microscope is full of glands, okay? The tissue is full of glands, and because it is full of glands, they have a typical arrangement, which is called as back-to-back arrangement of glands, right? So back to back arrangement of glands. And if you talk about in the terms of a pathologist, they will not say too many glands. They will say there is crowding of glands. So what the term the pathologist use is crowding of glands, right? So this is how they decide whether it is simple or complex. And now, if along with these changes, they see features of atypia, you all know through pathology what are the features of atypia: high NC ratio, loss of polarity. Yes. So all those features, if they see, then they will say it is with atypia. And if they don't see it, they will say without atypia. Clear how we get a diagnosis of with and without atypia? Perfecto. Now, why are we interested in knowing what is the type of hyperplasia? Okay, because the risk of cancer is dependent on the type of hyperplasia. For example, if it is simple hyperplasia without atypia, the risk of cancer is only 1%, right? So if it is simple without atypia, the risk of cancer is only 1%, right? If it is complex without atypia, right? If it is complex without atypia, then the risk of cancer is 3%. Now, let us see what will be the risk if it is simple with atypia. Okay, what will be the risk if it is simple with atypia? Then the risk is 8-plex with atypia. Then you see that if atypia comes in, then the risk of cancer is very, very high, right? So in simple with atypia, it is 8%, and in complex with atypia, it is 29%. Whereas without atypia, the risk is fairly less. So 1% and 3% in simple and complex. Now, once we have understood the risk in these conditions, we will go on to what is the treatment for hyperplasia. Right? So what is the treatment that we want to give for hyperplasia? Again, the algorithms are very, very important. Please understand this. Okay? If your patient has hyperplasia without atypia, right? So if your patient has hyperplasia without atypia, right, then whether it is simple or whether it is complex, okay, so whether it is simple or complex, the treatment remains the same. So once it is without atypia, the treatment will remain the same. What is the treatment? So what is the treatment if it is without atypia? The treatment is simply progesterone therapy, right? So the treatment is progesterone therapy. Okay, is it clear, everyone? Now, again, progesterone therapy, would you want to give it continuous or cyclical? Preferably continuous, right? So preferably continuous therapy, right? Because when you will give progesterones in a continuous manner, they will eventually cause atrophy of endometrium. Yes, so they will eventually cause atrophy of the endometrium. So which progesterones are we going to give? So we can give any progesterone, oral, injectable, or intrauterine. But what we will prefer is Mirena. So Mirena is preferred over oral progesterone therapy, right? So Mirena is preferred over oral progesterone therapy, right? Among the oral ones, which one do I give? MPA. Do you remember the full form? Very good. Medroxyprogesterone acetate, right? So medroxyprogesterone acetate, right? So Mirena is preferred over oral therapy. For how long do we want the therapy, right? At least for a span of 6 months, right? We would want to give it for 6 months. Some textbooks give a range of 3 to 6 months. But when you have to answer one, you should preferably go with 6 months. So after 6 months, you will repeat endometrial sampling. Then we will see what has happened to the endometrium, right? So you would give these therapies for a span of 6 months. And after 6 months, you would want to repeat the sampling, right? Now, this was when you have hyperplasia without atypia, okay? Now I'm going to talk about hyperplasia with atypia. So if my patient has hyperplasia with atypia, then what am I going to do? The first thing that I want you to understand is that in hyperplasia with atypia, if it is a OPD procedure diagnosis, what did I tell you should do first before you start treating? If this diagnosis is based on the tissue which we have got in the OPD procedure, then what should you do first before you treat the patient? What should you do first? Then first I will recheck. I told you we have to be doubly sure that there is no malignancy. So now first I will do a DNC and hysteroscopy. Right? So I will first do a DNC and hysteroscopy. Once I am very sure that it is atypia and not cancer, right? Then I will start the treatment. Yes, is this part clear to all of you? Yes. So once I am very sure that there is no malignancy, then I will go on to the treatment. Perfecto. Now, what is the treatment that we would want to do for atypical hyperplasia? It is going to be hysterectomy. So treatment of choice is, right? And depending on whether my patient is premenopausal or she is, depending on whether my patient is premenopausal or postmenopausal. If she is premenopausal, I will only do a hysterectomy. Right? I will only do a hysterectomy. But if she is postmenopausal, okay, Dr. Sumer is checking, okay, don't worry, just keep writing. If she is postmenopausal, we will do a hysterectomy with Sumer. Okay, then if she is postmenopausal, then we will do hysterectomy with BSO, bilateral salpingo-oophorectomy. Okay, then we will do a hysterectomy with bilateral salpingo-oophorectomy. And remember, the hysterectomy that we will do here in both these situations will be a type 1 hysterectomy. Do you all remember what was type 1 hysterectomy? Simple extrafascial hysterectomy. Yes, I taught you this in the last class. Simple extrafascial hysterectomy. Right? Perfect. Now, let us see this. In case the patient does not want to undergo a hysterectomy, right? So, if patient refuses hysterectomy, yes, so if the patient refuses hysterectomy and she has atypical hyperplasia, then what do? Then you will again give progesterone. Yes, so then you will again give progesterone therapy. Right, so then you will again give progesterone therapy. Okay, and again the progesterone that we will prefer is Mirena over oral progesterones. Yes, so then we will prefer Mirena over oral progesterones. Yes, and please remember, in case we are giving oral progesterones, if you give, then which one we will prefer? Then we have to prefer a very strong progesterone. So among the oral preparations, we will prefer a progesterone which is megesterol acetate over medroxyprogesterone acetate. Yes, so if in case she wants oral progesterone, then you will give her a progesterone which is much more stronger, that is going to be megestrol acetate over MPA, right? And remember again, the time duration for the progesterone therapy has to be for a minimum span of 6 months. Yes, and after 6 months, you will repeat an endometrial sampling, right? So then you will repeat a endometrial sampling. Yes, is it clear to all of you? Now, this is what we do for endometrial hyperplasia. This is very, very important for the exams as well. AIMS as well as Neet. They're very fond of asking postmenopausal bleeding, hyperplasia in your exams. Now, once we know all this, I will go on to the management and staging of endometrial cancer. Okay. Endometrial cancer. Now, please remember, the staging for endometrial cancer is again surgical, right? Okay, it is again surgical. And how do we do it? We do it like the staging for ovarian cancer, right? So I will tell you about it, but again, you have to do the same procedure, which is a staging laparotomy, right? So it is a surgical staging, okay? But in case the woman cannot undergo a surgical staging, let's say she is inoperable, then you can use investigations also to get an idea about this stage, all right? Among the investigations, okay, among the investigations, which investigation do you think is endometrial cancer? Right? Because when it comes to uterus and myometrium and spread into the parametrium, all these things are what? They are very well seen on MRI. But as I have told you, please remember that the staging is surgical. Okay? The staging is surgical. Fine, everyone? Now, first we will write what is the staging, and then we will talk about, okay, then we will talk about the steps that are slightly different between endometrial and ovarian cancer, right? Okay, so the staging is again given by FIGO, International Federation of Obstetricians and Gynecologists. Okay. Now, let us look at FIGO stage 1. So FIGO stage 1 has been divided into 1A and 1B, right? So it is divided into 1A and 1B. 1A, what is 1A? 1A is when the cancer is restricted to endometrium or has in than 50% or myometrium, okay, or it has invaded less than 50% of myometrium. What is 1B? 1B is when the cancer has gone into more than or equal to 50% of myometrium. Right? So more than 50% of the myometrium is invaded. That is what is 1B. नहीं, इसमें नहीं छोड़नी, treatment हम अलग से लिखेंगे. Hanging a lot. Okay, we are checking. Sir is checking what is the problem because at our end it is working fine. Let us check the internet connection. Maybe my internet connection is creating a problem. क्या करूं? क्यों नहीं देख रहा है यार सुमेर? Okay. So 1A, 1B, have you all written? So 1A and 1B, cancer in the endometrium or less than 50% of the myometrium is 1A, right? 1B, more than 50% of the myometrium. MRI is simply the best radiological investigation for endometrial cancer, right? So the best radiological investigation for endometrial cancer is MRI, all right? Now, let's go on to stage 2. Stage 2 cancer is cancer has, okay, so cancer has spread to the cervix. But be very careful. When we say it has spread to the cervix, it means spread to stroma of cervix, right? It means it has spread to stroma of the cervix. Please understand, if it is written glands of the cervix, which is endocervical glands, then you don't change the stage. Okay, so spread to the endocervix glandular area does not mean, that it is stage 2. We will consider it as stage 2 only when it has spread to the stroma, right? So only when it has spread to the stroma. Okay. If it is in the endocervical glands, then that means the staging will be still 1. You will put it as A and B dependent on whether myometrium is involved or not and how much of myometrium is involved, right? Let's talk about क्या करूं, फिर से खोलूं, शेयर स्क्रीन करनी है, फिर से खोल दिया. Okay, so yes, that's what I did. We've reopened the OneNote. All right. So stage 3. Stage 3 is divided into A, B, and C. So A is cancer has spread to serosa and or adnexa. So if the cancer has spread to the serosa and or adnexa, right, that is 3A. What is 3B? Cancer has spread to vagina and or parametrium. So vagina and or the parametrium. C is divided into C1 and C2. Okay, C1 is positive pelvic lymph nodes. So C1 is positive pelvic lymph nodes, whereas C2 is positive para-aortic lymph nodes. Right? So positive para-aortic lymph nodes. Fine, understood? So this is what is 3A, B and C. Talking about stage 4. Four is divided into 4A and 4B, right? 4A is spread to bladder and or the rectum, right? So bladder and or the rectum, while 4B is distant spread. Okay, it is distant spread. Please remember, just like the previous two cancers, right? Cancer cervix and cancer of the ovary, pelvic lymph nodes, inguinal lymph nodes are again considered as 4B, right? So inguinal lymph nodes are also considered as 4B or distant spread. Okay, so that is stage 4. Just like the ovarian cancer, stage 1 and 2 are called as early stage cancers, right? And stage 3 and 4 is considered as advanced stage cancers, right? So it is advanced stage cancers. Now, as I said, the staging is surgical, so very similar to what we have done in ovarian cancer. So I am not going to write the steps of the staging again. Okay, so surgical staging is very similar to that of ovarian. So I am not going to write all these steps again. I am just going to write some things which are different here. All right. So what is different is what you need to know. The first thing is that you have to remember that the hysterectomy that we do here, right? So hysterectomy that we do in endometrial cancer is again going to be a type 1 hysterectomy. Okay, it's going to be a type 1 hysterectomy. But if cancer has spread to the cervix, right? If cancer has spread to cervix, okay, then we will be doing a type 3 hysterectomy. If it has spread to the cervix, then we will be doing a type 3 hysterectomy. That's the first difference. The second thing, omentectomy, which you are doing in ovarian cancers, is not done routinely. Okay, omentectomy is not done routinely in endometrial cancers, right? Whereas omentectomy was done in all, ovarian cancers, it is not done here, right? So the omentectomy is not a routine procedure here. But in case the cancer is type 2 in histology, do you remember the type 2? Yes? Papillary, serous, clear cell or endometrioid type 3. If the histology is type 2, then omentectomy will be done. Now, I want to know from you, will you know the histology before operating the patient? Will you know the histology, before operating? Yes. How? Because you have done an endometrial sampling. Yes, so you have done an endometrial sampling. So when you send the tissue, they will tell you the histology, right? So they will tell you the histology. And can you tell me, will they also tell you the grade of the tumor? Will they also tell you the grade of the tumor? Yes. So they will tell you the grade also. They'll tell you the histology. They will tell you the grade, whether it is grade 1, grade 2 or grade 3, which is what is tumor differentiation. Right? That is the second difference. Third, what are the conditions when we will do lymphadenectomy? So lymphadenectomy means removal of the lymph nodes, right? So what are the indications in endometrial cancer where we will do a lymphadenectomy, right? These are: A, if tumor size is bigger than 2 centimeters, then yes, you should remove all the lymph nodes which are draining around. Second, if myometrium is more than 50% involved, then again you should do a lymph node removal. Third, if cancer has spread to cervical stroma, which means what? Stage 2 cancers. And lastly, if the cancer is type 2 in histology, right? So if the cancer is type 2 in histology, right? That means papillary, serous, clear cell, right? Or endometrioid grade 3. Yes, is this clear to everyone? So these are certain different points as compared to ovarian cancers. The rest of the steps of the staging laparotomy remain the same, right? So I have not made you write all the steps again because they're exactly the same. I just wanted you to know the difference in the two surgeries between ovarian and endometrial cancer. Is it clear to everyone? Yes? Okay, perfecto. Now let's quickly talk about the post-operative therapy. Right? What would we do for post-operatively for our patients of endometrial cancer? Now, post-operatively, we are going to divide our patients into 3 categories. They are considered as low risk, medium risk, and high risk. So what I will tell you the 2 extremes. Okay, I will tell you the 2 extremes. That is, who are low risk and who are high risk. Everyone else goes into medium risk. So listen to me carefully. Okay. Low risk means the patient should have both the things. Number 1, it should be endometrioid grade 1 tumor. Right? It should be endometrioid grade 1 tumor, and only endometrium should be involved. Right? So only endometrium involved. That is what is low risk patient. Right? So I repeat, what is low risk? My patient should satisfy both the things. The histology has to be endometrioid, and the differentiation has to be grade 1, and it should be only endometrium involved. Right? That is what is a low risk patient. What is a high risk patient? High risk is stage 3 or 4 cancer and or type 2 in histology. Right? So please remember this. High risk is either of these 2 patients. Either the staging is 3 or 4, or it is a type 2 histology cancer. Right? Type 2 means whether it is papillary, serous, clear cell, right? So that is type 2 histology. Everything else goes automatically into medium risk. Okay, so everything else goes into medium risk. Now, once you've decided what risk patient is this, we will give the further treatment. Okay, so if she is low risk, your answer is no further treatment. So if she is low risk, no further treatment. If she is medium risk, she will receive post-operative pelvic radiotherapy, right? So she will receive post-operative pelvic radiotherapy. And if she is high risk, she will receive chemotherapy as well as radiotherapy, right? So if she is high risk, she will receive chemo plus radiotherapy. Okay? And chemotherapy, you know, the drugs again is what you have to know. The drugs we use here are cisplatin and paclitaxel. Right? So the drugs are again the same, cisplatin and paclitaxel. Okay, is it clear to everyone? So I'll quickly repeat the post-operative therapy. Low risk means both things met, endometrioid and grade 1, and only endometrium involved. That's low risk. High risk is stage 3 and 4 and type 2 in histology and or. So if it is 3 or 4 or if it is type 2 in histology, then it is high risk. Everything else I will say will go into intermediate risk or medium risk, right? Now, once you know this, I said for low risk patients, no further treatment is required. For medium risk patients, we give pelvic radiotherapy. And for high risk patients, we will give chemo and radio. And the chemotherapeutic agents are cisplatin and paclitaxel. Clear, everyone? Okay. Now, please remember, anything which, you know, makes the tumor high risk will obviously be a poor prognostic marker. So if I ask you type 2 histology, okay, type 2 histology, will it be good prognosis or bad prognosis? What would you tell me? Type 2 histology, good or bad? Very good. It is bad prognosis, right? If I ask you grade 3 tumor differentiation, good or bad? It will be bad prognosis. If I ask you cervical spread, will it be good prognosis or bad prognosis? Bad prognosis, right? So anything which increases the stage will automatically become bad prognosis. But if I ask you, your tumor is ER-PR positive, good prognosis or bad prognosis? What is ER-PR? Estrogen and progesterone receptor positive. So if the tumor is ER-PR positive, good prognosis or bad prognosis? So now it will be good prognosis, right? So remember your concepts. The concepts are anything which worsens the stage will be bad prognosis. Histology, which is type 2, will be bad prognosis. Tumor differentiation, if it is undifferentiated, it will be bad prognosis. Yes, is it clear to everyone? So with this, we finish endometrial cancer and things that you should know about endometrial cancer. Is it clear to everyone? Yes. Now, I hope it is not hanging for all of you and we can proceed to the next topic. Yes, can we do that? Right, so we will go on to, right, so then we will go on to the next topic. Is it okay for everyone? I hope it's not hanging for anyone now. Okay. Yes, so it's working fine for all of you. Okay, so we will go on now and we will talk about fibroid uterus. Okay. All right, so we will now talk about fibroid uterus. Ready, everyone? Fibroid is a relatively easier topic, right? And most of you know a lot about fibroid, but there are some conceptual mistakes that you do when it comes to answering clinical questions. So I have to ensure that those clinical questions you don't get wrong, and so that you understand the concepts well. So most of the fibroid MCQs come from the management aspect. So I will be spending more time on that rather than the other things. Okay. So let's do this. Okay. Right. So let's talk about fibroid. What is it? Fibroid is a smooth muscle tumor of the uterus. Right. And once we know this, that it is a smooth muscle tumor, you should know that this is actually the most common pelvic tumor in females. Okay. So it is the most common pelvic tumor in females, right? And please remember that it is a benign tumor. Okay. So it is a benign tumor. Also tell me, if it is a smooth muscle tumor, what is it dependent on for growth? What is it dependent on for growth? Mainly dependent on estrogen. Right? So it is mainly dependent on estrogen for growth. Right? But what I would like to tell you here is, although the main thing is estrogen dependence, right? But progesterone also plays minor role, right? So the progesterone also plays a minor role. Now understand this. Estrogen causes proliferation. Okay, so estrogen causes proliferation. But what does progesterone do? It inhibits apoptosis of these cells. Right? So it inhibits apoptosis in these cells. So there is some contribution by progesterone as well. Right? But yes, mainly it is dependent on estrogen. Now also tell me, if it is mainly dependent on estrogen, yes, it is a tumor of which age group? You are very right. So primarily a disease of reproductive age women. It can happen throughout the reproductive age, but peak incidence is after 35 years of age. It can happen in younger girls as well, but the peak incidence is after 35 years of age. Also, now if you understand that it is an estrogen dependent tumor, can you tell me what will happen to a fibroid after menopause? Tell me. What will happen to a fibroid after menopause? Obviously, it is going to shrink. Yes? So it is going to regress, right? So after menopause, it is going to regress. What about pregnancy? Please understand that pregnancy is a predominant progesterone state. There is estrogen also, but it is predominant progesterone state. So most importantly, what you have to understand is, most fibroids, okay, do not grow in pregnancy. नहीं तो आप एग्जाम में गलत करके आते हो. Some fibroids can grow, but most fibroids will not grow in pregnancy. They remain static in size. All right. So I'm telling you, otherwise you students go and do it wrong in the exams. Right. So please understand this. Most fibroids do not grow in pregnancy. Yes, some can grow. Okay. Now, this is when it comes to distribution of fibroid in the age groups. Coming to what are going to be the risk factors. What are risk factors? So, risk factors are again dependent on the same processes, excess estrogen. So yes, we have seen an association with early menarche and late menopause. Yes, so early menarche. Then there is also association with obesity because of the same reasons. There is also association with diets. So, especially they say red meat has a strong association with fibroids. Okay. And alcohol consumption also has a strong association with fibroids. And race. So yes, there is a strong racial pattern that we have seen with fibroids as well. Right? So, for example, the African race is very, very prone to develop fibroids, and they also develop it at a relatively younger age. Right? So, those are the risk factors for fibroids that you should know. Please understand this very carefully. Okay? Please understand this very carefully. Oral contraceptive pills. What do you think will they do to the fibroid? What do you think will they do? So OCPs, especially the OCPs that we are using now, what are we using? We are using low dose pills. Yes, we are using low dose pills. Do not make fibroids grow. This is again something that you have to know. Otherwise, you do it wrong in the exams. OCPs have estrogen and progesterone, but the amount of hormone is very little. Okay, it has very little hormone. It does not cause growth of the fibroid. Is it clear? Does it shrink the fibroid? No. Okay, so neither does it shrink the fibroid, nor does it make the fibroid grow. How it will help, we will talk when we go on to management. But it does not cause growth. It does not cause shrinking. Is it clear? Right? So it does not make fibroids go, does not shrink the fibroids as well. Right? Understandable? Also, what would be the effect of smoking? I have already told you. Since it is an estrogen dependent state, smoking will reduce the risk. Since it is a estrogen dependent state, again the same thing, multiparity will reduce the risk. Right? So multiparity will reduce the risk. Right? So this is very, very important, right? So otherwise you do these things wrong in the exams. Okay. Now, what are the kind of fibroids that you know? What are the kind of fibroids? So there are 3 types of fibroids. I'm sure you all know that. The 3 types of fibroids are submucosal, intramural, and subserosal. So these are the types of uterine fibroids. Right? So these are the types of uterine fibroids. So submucosal, intramural, and subserosal. Which is the most common? Batao, which is the most common? So you do it again wrong in the exams. The most common are intramural fibroids, whereas submucosal ones are least common. You do it exactly the reverse. You say submucosal is most common. No. So submucosal is least common. Okay. The most common are intramural. In fact, ऐसा बोलते हैं हम that fibroids, when they start, they are actually intramural. Then when they grow, they may grow towards the cavity or towards the serosa. But to begin with, they say that fibroids are intramural, right? So when they start developing, they're actually intramural. They may go towards the cavity when they will be called submucosal, or they may go towards the serosa when they will be called subserosal, right? Now, I want you to look at these pictures quickly with me. So these are the fibroids that we have tried to show you here, right? The gross as well as a diagrammatic representation. So this diagram actually shows you all types of uterine fibroids, right? So there can be ones which are completely in the cavity, right? Then there can be ones which are protruding into the cavity, then completely intramural, and then there are subserosal, which are touching the serosa, whereas there could be pedunculated subserosal as well. And on the right hand side, you see the gross specimen. Again, the uterus having multiple fibroids in this case. Yes. And one of the classic findings on cut section is what? What is the classic finding on cut section? As you can see here, world appearance. Right? They have a world appearance. Also, do you understand that they are quite symmetric? Yes, they are quite round. So please understand that around the fibroid, around it, there is a pseudo-capsule, right? So there is a pseudo-capsule, right? It's not a true capsule, it's a pseudo-capsule. Understandable? Now, once you have seen what these fibroids look like, right, in the diagram and, in the gross specimen, I want you to write a more detailed classification which could be asked in your exams, right? Now, what is this detailed classification? This is the Fmge classification, right? So then we will write the Fmge classification. So, Fmge class 0, 1 and 2 are submucosal. Okay, so Fmge class 0, 1 and 2 are submucosal. How do we decide whether they're 0, 1 or 2? This is on the basis of how much of the fibroid is going into the cavity. Okay, so 0 means completely intracavitary, like the one I had shown you in the picture right now. Right, so completely intracavitary is type 0 fibroid. 1. More than 50% is intracavitary. Right? So more than 50% is intracavitary. While 2 is when more than 50% is intramural. So less than 50% will be intracavitary. Right? So more part of it is into the still in the muscle tissue. So more than 50% is intramural. Please remember this. This has a clinical application, which I will tell you in a little while. But then I will ask you to recall this concept. So remember that type 2 is more than 50% intramural or less than 50% intracavitary. Okay. Now, fibroids, Fmge scoring 3 and 4 is intramural. So 3 and 4 is intramural, whereas 5, 6, 7 is for subserosal. Right? The staging 5, 6 and 7 is for subserosal. Here I want you to know a little bit more that it is the type 7 which is pedunculated subserosal. Right? Pedunculated subserosal. Right? So that is type 7. And Fmge scoring of 8. Fmge 8 is used for cervical fibroids. Right? So 8 is if the fibroid is present in the cervix. Right? So this is the Fmge staging for the fibroids. Now, let us quickly see how a fibroid presents. So if we ask you, what is the most common presentation of fibroids? Then the most common presentation of fibroids is asymptomatic. What do you understand by this? It means they are incidental findings, right? You were investigating the patient for something and you find out that the uterus has a fibroid, right? So most common presentation is asymptomatic. They are incidental findings. Don't do this wrong. Okay. So most common presentation is asymptomatic. Now, in case they produce some presentation, what would be the most common symptom. So if they produce symptoms, what would that be? Then the most common symptom is abnormal uterine bleeding, right? So now it is abnormal uterine bleeding. Now please understand, this will not help you solve MCQs. You have to very well understand what type of AUB. So remember, fibroids will cause menorrhagia. Fibroids will cause menorrhagia. They will not cause irregular cycles, right? So they will not cause irregular cycles. The cycles are regular, but the bleeding is heavy, right? Now think and tell me, which fibroid will present as menorrhagia? So this is most commonly a presentation with submucosal. So this is most commonly a presentation with submucosal fibroids, but can also be seen with intramural fibroids, right? But it can also be seen with intramural fibroids. Now, please understand one thing. Submucosal were least common, yes, but they are most symptomatic. Do you understand this? Why do you see so much of fibroid in OPD? क्यों देखने को मिलता है? Right? That's because if at all they produce symptoms, it is this, and then it will be seen with submucosal. And that is why you answer it incorrectly in the exams. All right. So please remember that for your exams, you have to know that most common is intramural, but most symptomatic is which one? It is submucosal. The subserosal ones do not usually cause heavy bleeding, right? Heavy bleeding is generally seen with these two. Now, what is the cause of heavy bleeding? So there are multiple things that have been said about why fibroids cause heavy bleeding. So one of which is fibroids are associated with abnormal uterine vasculature, right? So they are associated with abnormal uterine vasculature, right? They are associated with impaired hemostasis, and they are associated with impaired contractility of the uterus, right? So a uterus which has fibroids has impaired contractility, it has impaired hemostasis, it has abnormal vessels inside the uterus, as well as there is a dysregulation of angiogenic factors. Reasons why fibroids lead to heavy bleeding, right? So this is the most common presentation. And with what will you see this, right? What else can you see with fibroids? Can they cause pain? So the second presentation that they can have is pain. Now, when will a fibroid cause pain? When a fibroid undergoes degeneration. So when it undergoes degeneration, it can cause pain. And when it undergoes torsion, so torsion and degeneration are two reasons of why fibroids can be painful, but generally they are not painful. Okay, so generally they are not. Sometimes they can get painful. Now, what should you know about degeneration? Okay, please remember that degeneration will begin from center of the fibroids. So degenerations will begin from the center of the fibroids. Okay, why? Because the vasculature of the fibroid comes from the periphery, right? So सबसे पहले degeneration will happen in the center. All degenerations begin from the center. Okay, Sumir. So all degenerations begin from the center, but there is one exception to this rule, and that is calcific degeneration. Okay, so that is calcific degeneration. Calcific degeneration will begin from the periphery. Can you tell me the reason why? Because calcium will come with blood. है ना? Calcium कैसे आ रहा है? Calcium will come with, so calcium will come with blood, and